السلام عليكم صباح الخير. Good morning everybody. It's my pleasure to be the moderator for the first session on this day. I know it will be a long day, however it will be covering some hot topics in the breast cancer by some expertise from the region and from the international level. So without further ado, I'm going to present our first speaker, Dr. Otto Metzger, Assistant Professor of Medicine, and he is consultant medical oncologist from Dana-Farber Cancer Institute. Dr. Metzger, since he joined Dana-Farber, he developed an active clinical practice and research program aimed to improve breast cancer treatment strategies, and he also designs and leads clinical trials with the transitional focus and serves an executive officer at the Alliance for Clinical Trials in Oncology. He is going to cover an interesting topic, future of AI in breast cancer. To be honest, I have some sort of interest in AI. We are the first center at the level of Middle East who implement AI in screening mammogram in Saqar Hospital in UAE. Please, the stage for you.
Good morning, everyone. My name is Otto. I'd like to thank the organizing committee for this kind invitation to come to the UAE and to talk about this challenging topic, which is artificial intelligence in breast cancer. I'm a medical oncologist. I haven't done much research myself into this field, and it was a challenge for me to put this presentation together, and also a good learning experience, given that we are going to deal, when we're dealing with artificial intelligence in our lives in ways that are going to be unpredictable. I would say that outside of medicine, we deal with artificial intelligence in a lot of things related to finance, to robotics, social media, and so on. So artificial intelligence is really here. But I would say that in oncology, it does deserve us to pay more attention into this and to imagine that the challenges that we're going to have, because the complexity of cancer should not be underestimated. And I would say that what we would need is to see what's called a multimodal AI in oncology, where we're able to integrate omics, precision health, digital clinical trials, radiology. So we really need to think about AI as a tool that hopefully in the future we will enable this integration of different types of data sources. I'm going to share briefly with you some of our experience at Dana-Farber with some sort of like AI machine that's called MatchMiner. This is an open source computational platform that helps us to find clinical trials and match patients to specific genomic alterations. So we've had for many years a genomic profile of our patients, mostly patients with advanced disease. And the MatchMiner, basically what it does, it takes data from patients and data from specific mutations and help us match with clinical trials. Here we have the landscape of genes and cancer types in precision medicine trials. This is a publication from a couple of years ago. When we focus here on the left, we can see the number of genomic alterations that we found in our population. Those are all patients that were profiled within our institution. And we try to see which are the genomic alterations that could have a match with clinical trials. And this is very helpful for us as clinicians, because once we are having like a busy clinic and we have a list of patients, it's quite hard to find across many clinical trials which could be the studies that could be useful for patients with advanced disease by genomic criteria. So we have here in the middle the number of genomic criteria per clinical trials. And here, which is more helpful on the right, we can see the number of studies that we have for each of the diseases. So in breast oncology, for instance, we usually have about 100 to 200 clinical trials opened across the institute. So it's very hard for a clinician to find which study could be a good fit for a patient with advanced disease. And through MatchMiner, they basically mine the data that exists within our system, and we get an email before our clinic from MatchMiner, from this machine, saying that patient X could be eligible for a specific clinical trial. As a point of editorial comment here, I would say that in breast oncology, this is not that helpful, given that we, in my opinion, we haven't made so many advances in matching genomic alterations to specific drugs. But I would say that for different diseases like lung cancer and so on, this could be really, really very helpful. But in this presentation, I want to talk about 3 different topics, briefly about pathology, a little bit about the screening mammography and remote patient monitoring, and how artificial intelligence has helped or can help us tackle these areas. And starting with pathology, I have here a case scenario. In my opinion and my own bias, I would say that the diagnosis of breast cancer into these different histological subtypes can be useful in clinical practice. And here is because I've been doing research for patients diagnosed with lobular carcinoma over many years. And we have demonstrated that lobular carcinoma should be treated or should be seen as a specific subtype within estrogen receptor positive breast cancer. Here on the left, we have data from an analysis that we did using an old study now that's called Big 19080, one of the large clinical trials that compared adjuvant therapy with either tamoxifen or letrozole for patients with ER-positive breast cancer. So we went back into data from this study and looked at the outcomes for patients with lobular carcinoma versus ductal cancer. When I did that, the idea behind was that, oh well, given that lobular carcinoma is such an indolent disease, low grade, ER-positive, maybe the differential effectiveness, maybe tamoxifen is going to be as good as letrozole for those patients, because we know that this is the case for the ductal cases that have low proliferation, low grade. But what we saw was the opposite. When we have this red dashed lines, we could see that patients with lobular cancer, when treated with just with adjuvant tamoxifen, they had worse outcomes in the postmenopausal setting. And now, almost 10 years later, we looked into data from soft and text, the studies in the premenopausal setting, where this is more important, given that in the postmenopausal setting we tend to use AI. But we saw a similar pattern showing that patients with lobular cancer, they did much better when treated with exemestane plus ovarian suppression when compared to tamoxifen here in the gray dashed lines. So the idea here is that identifying lobular cancer from a pathology report and knowing which patients really have lobular histology could be of clinical relevance when we're trying to make clinical decisions. And again, particularly for the premenopausal women, given that there are challenges for us in identifying who should get a more intense endocrine regimen with exemestane plus ovarian suppression. But what's the problem? I would say that the diagnosis of lobular carcinoma is not black and white. And there is a fair amount of this discordance among pathologists. There are cases that are really classic lobular where there is no doubt. But there are cases where it's really difficult. And here we had some data from the MINDACT phase 3 study that basically had the local assessment here in the lines by clinical investigators who participated in the MINDACT, and a central assessment of pathology done by a central lab in Milan. And we see here how local pathologists call lobular and how central pathology called lobular. And when we focus here and we look into the concordance between local and central pathologists, we had a kappa coefficient of only 43%. And about 40% of cases were classified as lobular by a local pathologist were centrally classified as a different histological subtype. So there's a fair amount of discordance between lobular versus ductal. And the idea here is, well, what can we get in terms of artificial intelligence and pathology for the diagnosis of histological subtype. We have a recent publication from the group from Memorial in New York that basically constructed an AI-based model to identify lobular neoplasia. And the whole idea, the whole objective there was to construct this AI model to diagnose lobular cancer by the identification of the CDH1 inactivation. We know that lobular cancers, the hallmark of this disease is lack of ACE adhering, mostly due to these biallelic mutations in the CDH1 gene. So the investigators basically tried to create an AI model to identify those features. So this model was trained in about 1,000 patients in a two-stage model, where basically the computer tries to identify what's invasive cancer versus not, and then to predict the presence of the CDH1 biallelic mutation. So here we have this like fancy picture showing how these systems really work. And for imaging in general, we know that's where we've seen a lot of advances with AI-based tools. In addition to this, there are tools that are approved for ER, PR, HER2 quantification. So there's a lot of potential with AI-based tools in pathology. And when you look into the results of this algorithm, when we focus here on the top part of the curve, we can see an extremely high AUC. So the model was really very powerful in identifying lobular by focusing in these features that are commonly associated with the CDH1 mutations. And when we look here into the plots in the middle, we can see that accuracy, it's above 93%. So it's really, it's one of the examples of the potential of AI-based tools, maybe to complement what we have in terms of pathology evaluation for breast cancer in our clinical practice. Those are things that are obviously not commonly used yet across pathology centers, but I would say that the way I see this is it's very simple. I really feel that the computer-based algorithms, the artificial intelligence, really is going to be very useful for pathologists and make their lives much easier when evaluating diagnosis of breast cancer. I don't think this is going to replace pathologists. I see this as tools to complement their ability to make diagnoses. So let's move on to the next topic, which is imaging, and here the focus is on screening mammography. I'm using here an example of a specific AI-guided mammography screening, and the reason I chose this is because of the number of publications and the fact that this has been implemented around the globe in 43 hospitals. This is an AI-guided risk-stratified mammography screening called MIRAI. This was developed at the MIT in Boston and has been widely validated, and it's been used in clinical practice at many places. We all know that mammography and screening is controversial. We have many limitations. We all know of the advantages of artificial intelligence with imaging, so it's really fascinating to see how this is evolving. There was a publication very recent looking at the cost effectiveness of this type of AI risk for breast cancer screening, and you can see here the net value of having a tool like that in the NH system in the UK. And I would say that the value here is not as much in terms of cost saving for countries that are developed, but I think that there are huge potential here in seeing this as a way to deploy screening at places with limited resources, given that we're able to stratify the population and do more intensive screening for those who have high risk and less intense for patients who have low risk. But how this is done? This risk-based model, as I said, it's basically a simple digital mammography. It's a learning model developed to predict the breast cancer risk at multiple time points. This was trained on data sets in Boston at MGH, at Karolinska, and in a hospital in Taiwan. There are many benefits here in comparison to the other tools that we have to predict the breast cancer, because it leverages missing risk factor information. So this is basically trained only on imaging, so you don't need much about patient age, family history, and so on. And it produces consistent predictions across different populations, as I'm going to show. So briefly here as an overview, as I said, this is developed to predict breast cancer risk at different time points. The model has 4 main components. Basically, as expected, it has this ability to identify imaging and features that could predict breast cancer. There is a risk factor predictor that could be added or not, taking into consideration age, family history. So there's a lot of potential here in adding additional features to predict the breast cancer. And it predicts risk for each year over a duration of 5 years. So this is one of their initial publications showing what's the performance of this screening tool in comparison to classic models such as the thyroid-Cusick. And we can see here with the C index on the left line here for this AI-based screening tool, it's a very powerful tool able to predict, to identify patients who have a chance of developing breast cancer. And since their initial validations, it has been able to identify with more precision up to 2 times the risks of someone having a breast cancer. And I think that this is very interesting and very important given the limitations that we have with mammography, the challenges that we have with a tool that's far from perfect. So if you're able to add accuracy into this screening modality, I see this with huge potential to identify patients that could be filtered into more precise screening tools or be followed at different intervals and so on. As I said, validation is very important, and this is a tool that has been validated across multiple series. And here we can see in this publication in the JCO, showing the number of patients in each of the hospitals that had evaluated this tool. And it's also interesting to see here the breakdown by age, with a fairly large number of patients between the age of 40 and 50, where we do have challenges with mammograms because of dense breast tissue and the limitation of mammography for this patient population being quite remarkable. We know that mammography is a tool that's very good in identifying calcifications. They don't get missed, but it's not as good for younger patients with dense breast tissue who are often diagnosed with more aggressive types of cancer, such as triple negative. So it's really remarkable to see that there's very large good distribution of ages. And here we have the results. What is the AUC for predicting cancer in these initial years since a mammography across all series? And what we can see here is that it's a test that the validation shows that the performance is the same across different countries, across different hospitals. We see very high AUCs, meaning that the ability of the tool to identify real cancers is consistent across different populations and across different series. And what's also interesting, given that patients are followed every year, that the AUC is also very consistent and robust at each year of the evaluation. So this is a tool which I said has been implemented in over 40 countries, and it's nice that it has the ability to complement what we're getting in terms of regular screening mammograms with potential for transformation, because I would say that the next step is to take the results based on risk and stratify patients into clinical trials for more intense screening or screening with different imaging modalities. So for the next few minutes, I want to change gears and talk about a totally different subject, which is remote patient monitoring. And what is that? And I want to use an example here of a company in France affiliated with Gustave Roussy, that's called Regency, that has deployed this tool for remote patient monitoring across many centers in France and a few sites in Belgium. And the whole idea here is to capture patients' experience while on treatment with different types of drugs in oncology directly from patient instead of relying on the classic capture of information through electronic medical records. So, and what this company has done, it's taking what we had seen from clinical trials in the US and in Europe, showing that by monitoring patients' adverse events with information gathered directly from patients, you're able to learn more, you're able to act on these results. There was a seminal study in the US showing that this could even have an impact in terms of survival outcomes. So this company basically takes all this knowledge that exists, develops a tool that's basically deployed through a cell phone, and patients are offered a number of instruments to gather information in terms of toxicity with PRO validated tools that are basically looking at disease-related symptoms, treatment adverse events. There are tools that we see often in clinical trials for quality of life. There's a lot of engagement metrics in terms of content consumption, program completion, patient satisfaction and engagement. So it's basically a tool that's created for patients. So this is not just deploying questionnaires, but basically created to engage patients into it. It captures important things such as social determinants of health, healthy behaviors, and the demographics in terms of age, disease type, and nutrition status, and so on. This tool, the Resilience RPM, has interfaces with the healthcare system. So here's just an example of what a physician in France may see in terms of their information from their patients in the electronic medical record. And here on the left, we can see, again, that's the tool that's created for patients. So it's not just basically deploying questionnaires, but providing patients with a lot of information so they feel that they should get engaged into this tool. And the adherence to this tool has been remarkable. We can see very consistent high adherence from a patient perspective in filling up information, given that they're also getting information that's relevant for their health. And I would say that in oncology, we deal with a population that has a cumulative incidence of adverse events. And here it's just listing adverse events of grade 3 or higher. That's pretty high. Patients have a lot of toxicities with all the treatments that we give, a lot of high-grade toxicities, a lot of low-grade toxicities. And we don't get as much information as we should get in terms of these toxicities when evaluating how clinical trials are published. And it's very difficult for us in a busy clinic to really get a good sense of what's happening with a large number of patients. So this tool allows clinicians and patients to report these toxicities in a longitudinal manner. And in addition to knowing which are the patients who have high-grade toxicity, the time to development of a high-grade toxicity is also important because no one starts with a high-grade pain or nausea from immediately. It varies from drug to drug. So having information about the linearity, the time to develop these adverse events, it's very important. And the system, what it does is it collects this information. Here in each line you have a specific adverse event. This is aggregated data from multiple patients to give an example. And depending on the level of adverse events that are reported by patients using their cell phone, the system can generate alerts to hospital. So the hospital can contact patients back and try to help managing the adverse events. And here, in this color-coded graphs, we can see what is the impact of these alerts in terms of the adverse events. And we see, as has previously been demonstrated, that there is some improvement in adverse events and patients' experience just by having the system with alerts and a loop that circles back to patients to improve outcomes. But how does AI plays into that? What happens is, the vision is that with increasing number of data being gathered for specific patient populations and specific conditions, the system allows, with artificial intelligence, to predict which patients are likely to have specific adverse events. So, as an example here, let's imagine we have a novel immunotherapy for breast cancer, and we're gathering information in terms of toxicity over time. Once we have, as an example, 1,000 patients being followed for 2 years with this novel drug, the system is able to identify features that are likely to identify which are the patients who are going to have specific adverse events and generate alerts ahead of an adverse event. So, as a simple explanation, one can say that nausea can happen in 20–30% of patients by week 4 of a given drug. So the system can alert patients about the possibility of an adverse event and intervene and help patients deal with the adverse event before it becomes severe. So this idea of anticipating an adverse event using data and with help from artificial intelligence, it's really very interesting. And there is a possibility here on the right side of using this tool to enhance clinical research, to make clinical research better. As I said, there is integration with electronic medical records. This is an area for which I've always been a bit, I'm waiting to see if this is really going to be true or not. The ability of extract data from EMR has been a bit an area of controversy in itself for many years because the data, it's not structured. The free text that we get from EMR, it's unclear, even with artificial intelligence, if we're going to be able to make some good use of this data, but this is being made. But going back here to research and the idea that we can use these tools to enhance clinical trials, I think that there is a lot of advantage and potential here to identify what I call low-grade toxicities. Because high-grade toxicities in clinical trials, it doesn't get missed. There's a lot of oversight. There's a lot of good reporting of data for these clinical trials for novel drugs. But we have very little insights in terms of the low-grade toxicities. And once these drugs, particularly in breast cancer, once they reach the early stage setting, the rates of treatment discontinuation for low-grade toxicities, they are not low. We're involved in the PALACE trial with adjuvant palbociclib in the early stage setting, and we had 40% of patients who discontinued palbociclib for reasons that are basically unknown, for low-grade toxicities that were never documented. So I think that those are tools that are able to help us gather the incidence and the natural history of low-grade toxicity in a way that could be very useful in clinical research because we can learn about low-grade nausea, low-grade fatigue, and hopefully intervene early on while drugs are being developed to avoid having drugs reaching clinical practice where we don't do much in terms of low-grade toxicities. This graphic here plots 3 different CDK inhibitors that we have in our clinical practice and basically compares what is the incidence of low-grade toxicities across time in this population in France. So, as I said, I think that the AI tools, they're basically able to gather all this data and to personalize a content experience to patients that can be very helpful and with impact to their clinical practice. So what should we expect in the near future? I would say that we really need this multimodal AI that's going to integrate all these different aspects, pathology, patient experience, radiology, with a lot of opportunities for precision health. But of course, there are many challenges. There are technical challenges in terms of data integration, in terms of the data that's being used to train these models. Data sharing and privacy, it's very important. We need to create mechanisms and frameworks for sharing data, securing patient confidentiality. I would say that collaboration is key. I think that what we saw with the screening mammography is a beautiful example of how a global collaboration can lead to advances. But in medicine, we often have what we all say at conferences, that state of art, this is beautiful, but the reality is different. The reality is that it's hard for us to adopt new tools. It's hard for us to really change the way medicine is practiced globally, but we really need to work on this. So maybe in the near future, we're not going to have just artificial intelligence, but hopefully what I call an augmented intelligence, where the computer is going to help us as clinicians to make decisions and make our lives better while taking care of patients, as opposed to expect that the machine would replace us. So thank you so much for your attention.
Thank you so much, Dr. Otto. It's definitely an evolving field, something that we are very excited about here in the UAE, and your tremendous work that you do at Dana-Farber and Harvard is honestly amazing. So I'll open it up for the audience for any questions. Yes, Dr. Marwan.
Good morning. Thank you very much for this very elegant presentation, especially as it is the first presentation of our day. Breast cancer and AI might be very challenging. Just 2 comments, and I need 1 answer after these 2 comments. First comments, in our countries, breast cancer comes nearly 10 years at the average earlier than in Western countries. What I feel from your model that you have shown us, that your model will miss these 10 years for our patients. So we need to be reassured that these models are really supporting our physicians and our population, because personally I don't feel comfortable to say to a patient at the age of 42, 43 in my country, go and come back in 6 years, for example. I have seen. So we need some reassurance and we need some confirmatory data. Number 2, in our country, you know, I come from Gustave Roussy, so I have seen this program, and you have been discussing about it a lot of times. We have another program, which is a little bit, we was calling it, we say it the WhatsApp program of the phones of the patients, of the physicians. Patients are calling us up till 3 a.m. in the morning or sending us messages on our personal WhatsApps till 3 a.m. in the morning. What we need is an AI program who can look into our WhatsApps, identify specific words, you know, and tell us in the morning, this one you need to answer, this one you can answer later on, this one you can send it to your personal assistant. Thank you very much.
Well, thank you. I think you've made a very important comment, 2 very important comments. I think that for the younger patients, I fully agree, and I don't think that what we have in terms of the screening with AI-based tools, they are ready to be implemented in terms of changing the timing of screening. But I think it does provide us with the ability of identify the younger patients who might be at higher risk and maybe offer more screening for those. And for the younger patients, I really feel that there is a need for more research. We need to do more of that, because it's a real problem in the UAE and in many countries where we're seeing this increasing incidence of cancer in very young patients. And mammography is less sensitive there. And I hope that with the AI-based tools, we're going to be able to empower patients so they don't feel as compelled to contact us all the time with questions that could be solved in maybe with education, providing them resources, or AI-based tools that are able to answer to questions that we get all the time that are basically the same and difficult for us as clinicians.
Question, just for the sake of time. I think we'll allow 2 more questions. So go ahead, Dr.
Okay, thank you. Oh, there you are. I felt him already in my bag, so I knew I had to stand up. So Dr. Metzger, thank you very much for this very inspiring talk early in the morning. Well, I think this is like AI in medicine. We ain't seen nothing yet. And this is going to be a multi-trillion business with a lot of competitors on the road. So, but the quality of the models that are future going to be sold to hospitals is all about the area under the curve. And if companies or third parties are able to hire the best centers in the world, they're gonna need a lot of money to pay for the validation and all the follow-up. And that's gonna cost a lot of money. And if aren't you afraid of that we can end up with poor man's models and rich man's model, because some hospitals simply cannot afford the models which have very high areas under the curve, but they're too expensive. And if you buy one of those, you have to go for validation every 2 years, and then you pay money.
It's a very good comment, and I agree. And I think that the problem goes beyond that, because the models, they even when developed in specific populations, they may not represent the reality outside of where they were developed, because the machine basically learns based on data, creates algorithms, predicts outcomes, but it's based on the population that they evaluated. That's the beauty of what I think what has happened with digital screening for mammography is the validation across several hospitals around the planet, and with the idea that those are tools that should be deployed. They should not be, there is no value in having just a specific tool inside the Dana-Farber, because it's not reproducible. And so there's a lot of need for governments and societies to be involved and in very open discussion about the utility of those things and how they're going to failure if they're not going to be widely available and validated.
Just one quick comment on AI, that we should be the driver of the AI, not drive us out, you know. That's always a concern, because I think the human touch will be very necessary, and it's not going to go away.
I fully agree. Thank you.
Thank you for your quick comment, Dr. Hazan. Thank you so much, Dr. Otto. That was a great presentation indeed. So we'll move on now to the next session, which is cases, the multidisciplinary case presentations. So yeah, some little change in the plan. So we'll start with Dr. Debo Tripathi. Dr. Saeed Rafi, if you would like to introduce him, please.
Thank you very much, Dr. Aida. Good morning, everybody. I think, for this session, Dr. Tripathi is going to update us about the management of the progression after the first-line CDK4/6 inhibitor, reviewing the data in that setting. Thank you.
Hello, thank you for inviting me. I wish I could be there in person, but I'm going to be presenting to you from here on updates in the management of patients beyond first-line therapy with CDK inhibitors. So you're all aware, of course, of the advances that have been made in this area, yet momentum keeps going on. So following CDK inhibitors, which have made, as you know, a huge impact in the outcomes of patients with hormone receptor positive disease, we're now on the heels of newer areas that we need to develop for our patients who ultimately develop resistance to these drugs. So first of all, I just want to check that you're able to see the slides, since I'm projecting them from here. If someone could just verify that for me.
Yes, yes.
Okay, perfect, wonderful. So I'm showing you a diagram of the complex interactions between several of the pathways that are operative in hormone receptor positive cancers. Estrogen is an important driver, of course, as we all know, of hormone receptor positive cancers, but so are growth factor pathways. In fact, growth factor pathways drive resistance to hormonal therapies. It's been known for decades that these pathways are turned on when we see hormonal therapy resistance both in patient samples or as well as in cell line models. So these offer us opportunities to intervene by blocking the resistance pathways, whether they are growth factor related pathways shown on the left side, and they all feed into the cell cycle, because ultimately any stimulus that makes a cell grow, whether it's nutritional, whether it's a growth factor, is going to be needing to enact the cell cycle machinery to initiate cell dividing both at the DNA level and at the mitotic level. So these represent targets for the development of resistance to endocrine therapy, but also we have to understand what drives resistance to CDK therapies. But I'm going to mostly focus on the endocrine part of it, yet it does bear a relationship to resistance to CDK inhibitors as well. So you're all familiar with the data from the pivotal trials that introduced CDK inhibitors are summarized on this table. And interestingly, the progression-free survival hazard rates are all roughly similar in the 50 to 55% reduction in progression-free events. Some of these have also shown a survival advantage, as you see on the left side. And however, what we do know is that ultimately most of these patients do develop resistance to hormonal therapy with a median time of about 2 years. By the time you go out to 5 years, about 70 to 80% of patients will have progressed. But there are patients who do maintain sensitivity for quite some time. So let me review the data we do have on what we can do past resistance and progression on endocrine and CDK inhibitor therapy. So one of the first questions that was asked and already studied in trials is just switching the CDK inhibitor. These are a series of trials that have recently been completed and presented. Now, looking at different strategies, the PACE trial took patients who had progressed on palbociclib and either changed the endocrine backbone or added the immunotherapy avelumab, and showed maybe a hint of benefit with avelumab, but it did not actually reach statistical significance. The Palmyra study attempted to change simply the endocrine therapy, but continue palbociclib in patients who developed resistance to endocrine therapy and palbociclib, and also showed a trend towards a benefit, but it did not help. Now, the Maintain study was a smaller study. It was a randomized phase 2 study that took patients on endocrine therapy and palbociclib and allowed for a change of CDK inhibitor, in this case ribociclib. And this study actually was a positive study. It did show a hazard rate of 0.57 in terms of progression-free survival, although it really wasn't a large enough study to be considered definitive and isn't really considered practice-changing. And then finally, the post-Monarch study, which was a large phase 3 study, and added abemaciclib to patients who progressed on CDK inhibitor-based therapies, and did show, in fact, a significant benefit. So as these trials are published and followed a little further, this may be one opportunity. Another opportunity is to block the PI3 kinase pathway. That was a pathway that I showed you in the first slide. The PI3 kinase pathway is like a superhighway. It is what many of the growth factors signal through, and it is made up of several players. The receptor to many growth factors, and then the intracellular component that can phosphorylate the PI3 kinase, which is a heterodimeric multifunctional protein with a regulatory end and a kinase domain that then sends a cascade of signals through AKT. And also you can get signaling through the RAS pathway that ultimately governs many cellular functions, including survival, apoptosis, and signaling for directly to the cell cycle apparatus. And a lot of this in breast cancer is driven by PI3 kinase, particularly the alpha isoform. In other malignancies, for example, in lymphoid malignancies, it's the beta isoform. So an alpha isoform is important, and that explains why the alpha catalytic unit is mutated in about 40% of hormone receptor positive cancers, is because that is one of the mechanisms that cells can become autonomous and malignant. So on that basis, one important component of that is mutations of PI3 kinase, which can now be targeted with small molecules. One of the first of these to enter trials in breast cancer was alpelisib, which is an alpha selective or alpha preferential small molecule. And that was put to test in the SOLAR-1 study that tested some patients with PIK3CA wild type, but really enriched for the PIK3CA mutant cohort. And in fact, that's where the benefit was seen, shown here. This now is specifically in the patients whose tumors had PIK3CA mutations, and you can see the progression-free survival benefit. And of course, this has led to the approval of this agent. One of the drawbacks of this agent is because it is so powerful in blocking the PI3 kinase pathway, it actually introduces a lot of toxicities, because some of the normal factors that signal through this pathway include the insulin receptor, for example. And so hyperglycemia and other metabolic derangements, as well as gastrointestinal effects, are very prominent with this particular drug, as you can see in the toxicity table. Another strategy is to block a different component of the pathway. AKT is a membrane-bound protein that is directly downstream of PI3 kinase. So blocking this may actually be more efficient and potentially more specific for growth pathways, as opposed to growth factors that have nothing to do with malignant transformation. And this study compared fulvestrant plus placebo versus fulvestrant plus capivasertib in patients who had developed recurrence on endocrine therapy, and more than half of the patients enrolled on this study had progressed on CDK inhibitors as well. So this trial in all patients did show a statistically significant improvement, about a 40% reduction in all progression events. And in the subset of patients that had alterations in the PI3 kinase AKT pathway, including loss of PTEN, which is the phosphatase that inactivates activated PI3 kinase. And that is actually lost in about 20 to 30% of breast cancers as well. So if you add all of those up, you see even a wider difference between the curves. And this study did lead to the approval of capivasertib. And you can see the toxicity profile does have some resemblance to what is seen with alpelisib, but to a lesser degree. You can see that nausea, rash, fatigue, hyperglycemia are all seen, but the grade 3 events are quite rare, although grade 1 is common, especially with diarrhea, but not so much with hyperglycemia. So this is essentially a more tolerable drug that can be used after CDK inhibitor therapy. Another approach is to get more specific. Inavolisib is a P10 alpha selective inhibitor. So it selectively inhibits not only the alpha isoform, but the mutant. It's more selective for mutant as opposed to wild type. So again, more selectivity. This was a study that took higher risk patients who had progressed within 12 months of completing endocrine therapy, and they were randomized to the standard palbociclib fulvestrant, which is a regimen that we would use after progression on AI, with a placebo or with inavolisib. And that study did in fact show an improvement in outcome, as shown here, a reduction of more than half. So a hazard rate of 43.43 in a more refractory group of patients who had progressed early. So you see the representation of patients who may have some degree of intrinsic hormonal therapy resistance in this population. Now let me switch to a different side of the equation. And this is another mutational escape pathway that was actually discovered by Suzanne Fuqua more than 20 years ago, but she described mutations in the estrogen receptor that made them autonomously activated even in the absence of estrogen. And if you think about it, it makes sense that this would be an escape pathway if you deprive estrogen using aromatase inhibitors. And so we see a selection of the fittest. This is a common theme in cancer. And in this particular situation, the mutations are in specific domains of the estrogen receptor so that they now can be activated without even having estrogen bind to them. And so the specific drugs that can affect the mutated isoforms, there's a handful of mutations that represent a majority of the ESR mutations, and we know their crystal structure, so we can now design synthetic drugs that can specifically affect these. One of the first ones to go into clinical trials was elacestrant, and this ultimately led to this trial, the Emerald trial, where patients who had progressed on aromatase inhibitor or fulvestrant therapy were randomized to get the standard of care, either an aromatase inhibitor or fulvestrant. Obviously, the physicians here chose the one the patient hadn't seen yet, versus elacestrant. And that study in all patients shown on the left here did show a benefit, but even a larger benefit in the subgroup of patients that were found to harbor ESR1 mutations. And this led to the approval of the drug about almost a little less than 2 years ago. And this is just the beginning of the story. There's a whole new generation of drugs now that are being fashioned that are going to be more potent estrogen receptor inhibitors. We have a long way to go to fully exploit this opportunity to arrest growth in hormone receptor positive cancer cells. Some of the newer SERDs, like elacestrant and others, are going to be approved as more data comes in. The PROTACs, these proteolytic chimeras, they target the estrogen receptor through degradation through the proteasomal complex and very efficiently erase all the estrogen receptor in the cell. The SERANs, the complete estrogen receptor agonists, also like camizestrant, these are also showing activity for 30–40% response rates, and then the SERCAs also. So you're going to be hearing more about these. We don't have much data on the combination of these agents with some of the biological agents like CDK inhibitors and PI3 kinase inhibitors and so on. So this field is a little further behind. Even with elacestrant, we're struggling to catch up to see how well these combine with some of the biologic agents. Okay, so when patients now become resistant to the biological therapies, and of course there's still more advances coming there. We know ultimately that chemotherapy is used. You all know that the pathways show that once someone is declared to be resistant to endocrine therapy, which by the way is difficult to know when exactly that is, that we can use a variety of chemotherapies, and we have for many years. I'm going to focus on the newer chemotherapies, the antibody drug conjugates that are specifically approved in this situation, because we know that they are more potent because they are directed specifically to tumor cells through ligand interactions. In the case of trastuzumab deruxtecan, you're all familiar with the fact that it uses the trastuzumab backbone, and it's bound to each antibody is bound to 8 molecules of deruxtecan, which is a synthetic topoisomerase 1 inhibitor. It's internalized into the cell. The linker is then cleaved in the lower pH environment and released to cause injury and damage and death to the cell. And then the chemical can go out into the tumor interstitium and achieve what is called a bystander effect, and killing other tumor cells, maybe even those that express lower levels of HER2. And these drugs now have been tested. I think many of you are familiar with the data in estrogen receptor positive but HER2 low, which has enough HER2 on it to internalize the antibody drug conjugate. And compared to treatment of physician's choice chemotherapy, TDXD in the Destiny Breast 04 study performed quite well, as you can see, both in the hormone receptor positive cohort as well as in patients that were hormone receptor negative, but still all had to be HER2 low, either 1+ or 2+. That fit 2+ had to be FISH negative. And you can see the dramatic impact here with hazard rates in the 0.3, 0.4 range. Overall survival has also been improved in this group of patients. Now, the representation of CDK inhibitor treated patients is still limited in these trials, but a lot of these patients were, and that's something that's very important for us to look at. The other drug that is commonly used now in this setting that has been approved specifically, and again, in this particular study, these patients did have CDK inhibitor. The TROPiCS-02 study enrolled patients who had had at least one endocrine therapy and at least 2 chemotherapies, and randomized them to sacituzumab govitecan, which is also an antibody drug conjugate. This one binds TROP2, and the payload is irinotecan. Versus treatment of physician's choice, one of the 4 chemotherapies that you see listed in the schema. And this one did again show a significant improvement in progression-free and overall survival. Maybe not as dramatic, but again, the patient populations were different. So it's very difficult to compare these trials to each other. And one of the big questions is, how do patients respond from one antibody drug conjugate to the other? There were several presentations at ASCO in the last 2 years showing that there is benefit in these, maybe somewhat modest, but not in all cases. There are some patients that have long PFSs when they've seen one and then see the other one. So we need to learn more about the outcomes in that sequence. So really, to summarize where we are, we have a lot of options after progression on CDK inhibitor. This is a modification of both the ASCO, NCCN, and the ESMO guidelines. I've modified it a little bit to put in the modern approach of therapy, where we're starting with CDK inhibitors upon discovery of recurrence. It's important now to genomically profile these cancers initially, or certainly in second line. After progression on AI or tamoxifen, it's recommended to use a CDK inhibitor and use the appropriate endocrine therapy, fulvestrant, if the patient was on AI. And then if the patient progresses, your options are to use either capivasertib if the PAM pathway is affected, and that includes PIK3CA mutations, it includes AKT mutations, which are somewhat rare, and it also includes other mutations such as PTEN that can activate this pathway. And then, of course, fulvestrant and alpelisib for PIK3CA is another option as well. And then there's still the data from everolimus that you compare with several endocrine agents. I wrote exemestane since that was the first one approved, but also tamoxifen as well. Elacestrant as a single agent for those patients whose tumors harbor ESR1 mutations. And there are now trials to start testing the combinations of elacestrant with drugs like ribociclib and alpelisib. And so we'll learn more about those combinations. We shouldn't forget that PARP inhibitors should be used after initial first-line endocrine therapy in patients who have germline BRCA1 or 2 mutations. And then, of course, as I mentioned, at some point you pivot over to the chemotherapy. And this is still a tricky area. At what point do you do that? We don't have firm guidelines, but certainly with rapidly progressive disease, patients that are at threat for symptoms, we know that we can see nice responses with these drugs. So this is really where we are in the year 2024. And I want to thank you for your attention. But we have come a long way, and there's much more to come.
Amazing presentation. I just want to thank you, Professor Tripathi, for this very comprehensive and nice review of the landscape for first-line progression on the CDK4/6 inhibitor. Now, this is, we have come from almost very limited number of options in that line to such a big kind of area at the moment, and I'm very aware that we also limited time. I know that we are quite a lot of questions, so if you allow me, I'll just allow for 2 or 3 questions. Professor Marwan.
Thank you. Good morning, and thank you very much, Professor Tripathi. I think it's 3 a.m. in Houston, so thank you very much for being with us. 2 very small questions. First questions, how you address the patients who have double mutations, the ESR1 and the PY3K. This is number 1. And number 2, do you have any candidate to take the place of the first-line CDK4/6 inhibitors in the future?
So yes, the first question is, PIK3CA mutations do not seem to spell too much in the way of resistance. So I think that if you have a patient with a PIK3CA mutation and they have an ESR1 mutation, and let's say they have diabetes or glucose intolerance, I do think you can use elacestrant. There is some data to suggest that PIK3CA may make the patient a little more resistant, but not much, because it's a different driver. So fortunately, there isn't too much cross-resistance in that regard. Now, in terms of what is coming up as first line, there are some interesting molecules that are coming up. One of them is CDK4. Now, you might think, well, that's not very exciting. We already have CDK4/6 inhibitors. It turns out that by inhibiting CDK4 alone, you actually get less toxicity, and you might actually get a better effect. So there are several CDK4 inhibitors now that are in testing. I think Pfizer's is the furthest ahead. They're now in randomized phase 3 studies. Beijing has one too, and there's other companies that are developing these. So I think that's going to be an important one. Also, CDK2 is an important one also. It's a bypass mechanism for CDK resistance. When you upregulate cyclin E, you have a bypass pathway through CDK2. So that's another group that is coming up as one. And then there's actually antibody drug conjugates. Instead of attacking chemotherapy, you can put a CDK inhibitor. So it specifically gets it into the cell, and they tend to be more effective with less toxicity. So there are a few new things coming our way in that regard.
Perfect. Hassan?
So already part of my question was, and I was going to ask you about CDK2 and the association with MYC. We had some beautiful data that the main mechanism of resistance is actually through this CDK2, and not only in ER positive, it may spill also into the triple negative breast cancer. So we may see more about these CDK2 inhibitors. But my question, I mean, we haven't seen much more clinical progress using CDK2. I've seen a lot of CDK4, as you mentioned, as being more potent, but we haven't seen much about CDK2. Do you know where they are in their development?
Yes, there have been some issues with toxicities that we don't fully understand. There were some ocular toxicities seen with one of them. Fatigue is another problem. Especially when you combine them with CDK4 and 6, which you ideally should. When you use them alone, they're not as active. And then when you combine 2, 4, and 6 together, you do see a lot of toxicities. In fact, it wasn't until we got specific inhibitors that you could even target CDK at all. We've been trying to target the cell cycle for decades, and only can we do it now because we have specific inhibitors, but finding the right mix has been difficult. I do think the CDK4 is going to be the one that really gets this one across the finish line. But there are other pathways and epigenetic pathways that can modulate this response. The KAT6 is an epigenetic drug that seems to also potentiate drugs that work through blocking the CDK pathway. And then another mechanism of resistance that we see is upregulation of IL-6 and the STAT pathway. So STAT3 inhibitors, for example, and IL-6 receptor antibodies, these are all being tested as well, because that is another mechanism of resistance.
So for the Monarch 8, just last point, many of us were a little disappointed that it was modest benefit when you look at 5.3 versus 6 months. And then when you look at visceral versus bone, it didn't seem to have any signal in the visceral met. So do you think that strategy is there for some patients, but where would you re-challenge clinically?
Yes, I think that re-challenge clinically, in my sense, should be done in someone that does not have very high burden disease. As you pointed out, specifically someone with liver disease, they already seem to have a worse outcome, plus they tend to have more aggressive and more bulkier disease. So I think you have more luxury to try something simple like a CDK switch in someone that has bone-only progression, for example, and is not very symptomatic. And you might get some time there. Really, what we're hoping is that we can extend a healthy life for our patients as long as possible. And so sometimes even getting a few months of good time is worthwhile, but you have to be, as you said, selective. So I think you can use those drugs and save some of your drugs for later in someone that has very low burden disease.
Perfect, thank you. I'm very well aware of the time limit. So with that, thank you so much indeed, Professor Tripathi. If you could please stay with us to participate in the MDT meeting, which is the next session. So the next one, I think, is that you, Professor?
Thank you very much, and good morning again, everybody. I think this is it should be a debate. I think it should be a debate, but maybe it will be a small presentation. Two-case presentation. So it will be two-case presentation, and I would like to invite my co-chairman, Dr. Nahid Balba. She's not here. Okay, so we're gonna do it. It would be our honor, Doctor. It will be our honor and pleasure. So we have with us Professor Nuhad Ibrahim. Maybe he will have the first. Please, Professor Ibrahim from MD Anderson. Yes. Dr. Ernest Luton also. And Dr. Ibrahim Abu Ghaida. Very elegant discussion with two medical oncologists, one radiation therapist, one surgeon, and two local medical oncologists. Doctora. Faddali.
Yes, and also we are honored also to have Dr. Cargigliano with us online to hear from his opinion. I would like to announce to all of you that Dr. Cargigliano was selected by our board committee to win the Lifetime Achievement Award Global. So congratulations, Dr. Cargigliano. We wish to have you with us. And Dr. Hamid will be in Milan in December, so he will deliver the award at that time. So thank you so much.
Thank you very much, really.
Thank you so much. Thank you so much, Prof. Cargigliano, for all what you do to advance breast cancer. We have all witnessed a tremendous effort that you put with your team through international level to advance breast cancer, which eventually will improve the life of our patients. So thank you so much. Okay, so without further ado, we would like to move on now to the case presentations. I will start with my first case. My case is a 30-year-old premenopausal Emirati female with no significant past medical history. She has 4 kids. She is a housewife. No family history of breast cancer. She presented to us back in March of 2021 with a rapidly growing lump in the right breast for 2 months. On physical examination at that time, at 2 o'clock, there was a right-sided breast mass, 6 centimeter on maximum dimension, with overlying mild skin dimpling and associated nipple retraction. At that time, there was no erythema on the breast, and she had enlarged axillary adenopathy. So we did the mammogram, which obviously, as you can see, is a lesion that measures about 4 centimeter by 7 by 4 centimeter associated with numerous pleomorphic microcalcification. The ultrasound showed the mass on the same location with pathologic right axillary lymph node. The maximum dimension was about 2.7, but it was mobile and soft. So in terms of the CT scan, there was no evidence of distant metastatic disease, and the bone scan was also negative. So the right breast mass was biopsied. It showed invasive ductal carcinoma of grade 3. ER was strongly positive, PR negative, HER2 1+, and the Ki67 of 90%. And the right axillary lymph node was positive for metastatic disease. So we deemed her at clinical T3 and 1M0. So at this point, my question to the panel, how would you like to approach this case? Dr. Nuhad Ibrahim. Yes, the staging scan was negative for metastatic disease.
I would start with neoadjuvant chemotherapy.
Excellent. So this is exactly what we have done. So in April of 2021, she started and completed 4 cycles of dose-dense AC with significant improvement. And then she received weekly paclitaxel, but with cycle 7, she insisted to have ultrasound just to document the response, although like clinically she was doing excellent, and actually the ultrasound of the right breast showed complete response. But in September of 2021, so sorry for the typo, 1 week post-cycle 11 of Taxol, she developed redness and heaviness on the right breast. So it was a rapidly developing erythema all over the breast. So we did imaging, and you can see the MRI of the breast showed extensive infiltrating, enhancing lesion affecting all quadrants of the right breast, associated with diffuse breast edema with significant skin thickening, mainly affected the medial aspect, but there was also bulky enlarged axillary adenopathy, and the overall presentation was highly concerning for inflammatory breast cancer at this point. So we repeat the staging scans with no evidence of metastatic disease. So here is my question. A patient who progressed by end of weekly Taxol with a very aggressive feature. So how would you approach this case? And I'm glad we have a multidisciplinary team right now with our radiation, medical oncologist, and the surgeon to sort of approach. Do you think that we should, at this stage, should we change the systemic therapy or proceed with surgery? I mean, I know there may not be a right or wrong answer, but I think I would like to hear your opinion as well. So Dr. Tripathi, what do you think at this point you would advocate to do?
Well, I think the first question is this patient even surgically operable? Because if the patient really is unresectable at this time, really our only choice is going to be to try another systemic therapy. And based on what you're telling me with the redness and the edema, I don't think that this patient is resectable. So I would probably opt for a change in therapy. At our center, we have some clinical trials, so I might also get a biopsy and get next generation sequencing. But my feeling at this point is that I would still give the patient a systemic therapy. Of course, after anthracycline and taxane, we know that there's a lot of resistance. We generally opt to use an antibody drug conjugate at this point. It's not always approved in this setting, but many of the drugs that are approved in the metastatic setting can be used if the patient does not have resectable tumor. So I think in this case, I would probably use, if the patient was HER2 low, I would use trastuzumab deruxtecan, or not, I would use sacituzumab govitecan. Now, if the patient was operable, I might consider surgery, but it doesn't sound like this case is.
Okay. Excellent. So we have discussed this case in our multidisciplinary tumor board. Dr. Ernest actually was there. And we deemed the patient to be surgically operable. I think you did the mapping of the skin, and the margin could have been saved with surgery. So Dr. Ernest, from the surgical perspective, can you...
Partly I'm biased because I was one of the previous partly I'm a little bit biased because I know the case, but on the other hand, I fully agree with my dear colleague from MD Anderson that if the situation changes, then you have to go for a complete new workup, also a new biopsy. And as you already stated, I would also go back to our first biopsy and to see if to do some kind of molecular subtyping, because we know that even in luminal B-type tumors, actually this is a luminal B-like tumor because it was only classified on immunohistochemistry, that there is about a 20% discordance about a real underlying case. Like this could well be like this bad guy in the luminal types, which actually is functionally a triple negative. Because it may have its estrogen receptors, but then the intracellular pathway is not functioning. I always say, like, if the car has a headlight, you only know if it's working when you switch on the key and to see if it's working. Look, maybe we were like tricked by this patient that actually she was a triple negative patient, and but you're not sure. But go back to the initial biopsy and do new biopsy and try to get more, unravel more the initial, the real disease.
Excellent. Dr. Ibrahim, from the radiation, maybe from the radiation perspective, any comment on this case?
Right now, nothing. Right now, it seems our concern is systemic disease failure in this case with a very high Ki-67 as well. The only thing maybe, I would like to see on this patient initially is a PET scan, because a lot of times, those IMC lymph nodes might light up on a PET scan, and these will really upstage the patient and allow us to, we need to give a boost if these were there. So, with the high Ki-67, with the progression, I would love to see a PET scan on the progression.
So we did actually a PET scan, and it did not show an evidence of metastatic disease. I think I had did I have a picture in there? Maybe I did not include it. So we indeed repeated the biopsy, and it confirmed again the same pathology. ER remains strongly positive, PR 5 out of 8, where initially it was negative. HER2 now 2+, and the FISH was negative. And interestingly, the Ki-67 went down from 90% to 20% at that point. So we discussed this patient in our multidisciplinary tumor board, and I think the question was, the surgeons will do the skin mapping, and then if they can salvage the breast or not. And I think we made the right call by proceeding with mastectomy with frozen section for a clear skin margin and axillary lymph node dissection with closer together with a plastic surgeon. So this is the pathology post-operatively. The tumor extends now to 11 centimeter, invasive ductal carcinoma, grade 3. All ink margins were not involved by the tumor. There was an extensive LVI, dermal lymphovascular invasion. Treatment effect was minimal, 10 out of 17 lymph nodes positive with no extracapsular extension. The feature was consistent with inflammatory breast cancer, PT4 and 3A, ER highly positive again, PR 5 out of 8, and the HER2 is 2+, was sent for FISH, which came back negative, and the Ki-67 remained at 20%. So at this point, I will pause and see if the panel has any comments. Yes, Dr. Ibrahim, go ahead, please.
This patient has clearly demonstrated primary resistance. And if you're coming from the point of view that breast cancer is a systemic disease, so I'd be more worried about treating the patient systemically before I go to surgery, because I want to pick up on a drug that helps the patient. So I agree with Dr. Tripathi with chemotherapy choice to demonstrate at least some kind of sensitivity before you remove it. Otherwise, you may miss the compass here if you remove the breast at this point in time. So I agree with you that rebiopsying and rechecking the markers is very appropriate. But this patient, I hope you can give us a better ending to this case, but it is a very bad situation.
It is. is, I mean, somebody who progress on chemotherapy with an inflammatory picture, I mean, the patient is highly also educated, very much involved in the decision making as well. So all of these options was presented to the patient, and we did not take this decision lightly. But what made us more comfortable is that when we did the skin mapping, it seems that the breast was salvageable. Also, there was a huge symptomatic component that maybe pushed us toward more surgical aspect, but I definitely agree with you. Doing systemic therapy before proceeding with surgery is an option that we have considered, but eventually, you know, the decision was to go for surgery. So thank you for your comment. Yes, Dr. Marwan.
Thank you. I think that now the patient has been operated. Now the patient has been operated, so we cannot come back to see and how to test. So the question is what to do now. Yes, exactly. Do you try to pick a kind of adjuvant chemotherapy for her now? This is number one. Number two, after radiation therapy and after the local control, or do you wait for the relapse? And when she will relapse, most probably she will relapse very rapidly, you will have to begin a new treatment. So at least you will see a target in front of you when you're gonna treat her. Yeah. Personally, I would not give her anything, and I will wait till she relapses, because
she's ER positive. I mean, even before, yes. So she's ER positive.
So she'll have an adjuvant hormonal treatment.
Absolutely.
Okay,
absolutely.
okay. I was talking about picking a new treatment for eventually, because most probably, I don't know, maybe you're gonna wait 1 or 2 months till the radiation therapy will end. You'll do a PET CT scan. Yeah. Most probably she will be metastatizing at that point, most probably.
So indeed, even before the surgical planning, we immediately put her on ovarian suppression and started her on AI. So just for the planning of surgery. So we did that just to sort of like give her something in the meanwhile for the proper surgical planning. So we did start her on Zoladex exemestane. As a matter of fact, it was even before. She completed radiation therapy at 50 gray in 25 fractions, and there was a little bit of delay of giving the radiation therapy just because the wound healing issues. And then we immediately started her on abemaciclib, which was very appropriate in this case, adjuvant per the Monarchy trial. She completed adjuvant abemaciclib in February of 2024, so she completed 2 years, and as a matter of fact, at the full dose, I do remember that she tolerated the treatment very well without major issues, and the compliance was very good. She also remained on the ovarian suppression in the exemestane, and we were also monitoring her hormonal levels, and it was indeed in the postmenopausal range. But in just 4 months from completing abemaciclib in June 2024, she walks to my clinic with left arm swelling and pain. And on examination, I noticed enlarged left-sided. Now the contralateral side with enlarged axillary adenopathy, no palpable lesion in the left breast. So we immediately did the full workup, including the PET scan, which you see now. There is a bulky contralateral axillary adenopathy, but there was no other signs of metastatic disease. So at this point, we did, again, a mammogram and ultrasound just to make sure we are not dealing with a new primary contralateral breast cancer, and it came back negative. We tried to do the MRI, but the patient refused. She was severely claustrophobic. She was unable to do it completely. So at this point, we also did the Guardant 3. We repeated, obviously, the biopsy, and the markers was consistent with the primary. ER strongly positive, PR was low positive, and the HER2 was 2+. So we did the Guardant 360 just to sort of understand more about the biology of the disease, and there was an NF1 mutation. ESR and PI3K, surprisingly, were wild type, MS stable, and the TMB was low. So at this point, now this is the perfect situation. We have a multidisciplinary team in here. What do you think the next point will be? Dr. Mark, we would like to hear your opinion.
I think, first of all, this is a very difficult situation, and you're going to have to give a next line therapy, which would probably be, in my book, another endocrine therapy, if you could get one in. So she's had an aromatase inhibitor. Even if she's got wild type ESR, she may benefit from fulvestrant or next generation SERD. It's all you've got, or you're going to go down a later line chemotherapy. So the other option that we would consider in this situation would undoubtedly be capecitabine.
May I ask a question? Was there a biopsy and biomarkers done of the contralateral axillary?
Absolutely. So we repeated, and it was positive again. ER strongly positive, PR low positive, HER2 was 2+, FISH negative. So it remains similar to the primary tumor.
ESR was Y? ESY?
Wild type, yeah.
So if not surgically resectable, this is an ideal patient also to be candidate to trastuzumab deruxtecan. In our Destiny Breast 06, there were 9% of patients exactly with these characteristics, so relapsing within 6 months after the end of adjuvant CDK4/6 inhibitors. So since this is an HER2 low, and if no indication to a surgery, I would consider in this case trastuzumab deruxtecan.
Okay. Thank you so much, Dr. Kargal. Indeed, this is actually what we have done. We started recently the patient on trastuzumab deruxtecan. She got about 3 cycles, and most recently she came to visit me, and I examined her axillary lymphadenopathy, and I've seen a remarkable response actually. But now the question, if she, let's say, had a complete remission or excellent partial remission in the contralateral side, would you at all, I mean, I believe again there is no right or wrong answer, but Dr. Ernest, would you at all consider debulking her axillary side? That's a tough question.
That's a tough thanks for the tough question. Yeah, that's a tough question because as you said, there is no right or wrong, but what is the benefit to be expected from the surgery? For sure, you will end up with a pathology that will give our dear friends of radiotherapists an excuse to go for full-blown radiation, and the patient will end up with lymphedema on that side. And if this will improve her overall survival, that's one of the side effects she may want to carry. But on the other hand, if it's not going to add or bring any benefit, I think that surgery is more or less the last resort.
Excellent.
Can I add a comment?
Yes,
Can I add a comment?
Yeah.
I think that the answer is in the right place, because if she responds for a long period of time, let's say that you are continuing in 1 year in HER2 and the patient is nearly in a complete remission, at that point of time, I think that surgery or local control might be discussed.
Yep.
But discussing it now, maybe it's a little bit too early.
Absolutely. I definitely agree with the longer the response is there, the more comfortable maybe you take these big decisions. Dr. Cargigliano, in your center, would you, we sort of consider this as an oligo, let's say, recurrence. Would you at all in your center consider more aggressive approaches in these patients, young lady with, you know, aggressive disease? If we gave her a good chance in HER2 with the, let's say, excellent response, prolonged response, would you at all consider in this case be more aggressive and debulk the axillary adenopathy, maybe augment that with radiation therapy?
So this is a shared decision making, of course. We should discuss with the patient. The best scenario would be that you have occult breast cancer, contralateral cancer. The worst scenario is that this is a metastatic disease. So after discussing with the patient, if she agrees, I would consider an axillary dissection followed by radiation therapy. Optimistically, of course, since this was an high risk, I know perfectly that this is a metastatic disease. But since she is very young, if she agrees, for sure I would discuss this approach.
Excellent. Dr. Ibrahim, from the radiation perspective, any comment?
Thank you, Aida. Yeah, it's a tough situation. So, you know, I'm really concerned about her systemic disease, because this disease declared itself only a couple of months after you stopped your systemic therapy. So, you know, I always, you know, I believe breast cancer is a systemic disease, so our role is very minor in this case. And with what Dr. Ernest mentioned, it does come with toxicity. Now, that being said, the only question I have was, because she's young, I didn't see if BRCA was done for her. Was she BRCA?
The BRCA was negative.
Negative, okay. So in that opinion, you know, if, as Dr. Dirani mentioned, the discussion ended up going with the surgical dissection and the patient understands the morbidity of that, then yes, I mean, we have to consolidate with radiation. I will not use 50 and 25. I would use 40 and 15.
Excellent. Thank you so much. I think this concludes our case, and I'll give it to Dr. Saeed to proceed with his case.
Thank you very much, Dr. Aida. So the next case is a little bit more challenging and probably doesn't have a lot of data at the moment to fall back into, but I think, you know, these are the cases that we sometimes see in our clinics as well, so it would be good to have that discussion. So this is a case of early triple negative breast cancer, a 37-year-old lady. She is highly educated, assistant professor of biology with no past medical history of note. Around a year and a half ago, in May 2023, she was diagnosed with a 25 by 30 millimeter lesion in her upper outer quadrant of her left breast, which was extending to the retroareolar area. She also had enhancing left axillary lymph nodes measuring around 27 by 17 millimeter in size, and the biopsy was performed on the both breast lesions and the axillary lymph node, both of which they showed basically a high-grade infiltrating ductal carcinoma, NSC, with lymphovascular invasion. The immunohistochemistry showed ER very occasional, very weakly positive 2 out of 8, progesterone receptor negative 0 out of 8, HER2 2+ FISH non-amplified with a ratio of 1.1. Ki-67 was over 80%. PET-CT scan at that time did not show any evidence of distant metastatic disease. So I would guess that this is, everybody agrees that this is a triple negative breast cancer node positive. I suspect that nobody disagrees that this patient needs to start on neoadjuvant chemotherapy, and based on Keynote 522, a lot of us would start this patient on weekly carboplatin paclitaxel every week for 12 weeks, plus pembrolizumab, followed by AC and pembrolizumab. This is what it was done for her, and she followed on to have a surgery. And so she decided, although that she does not have any germline BRCA mutation or any other predisposing mutation, she decided to have bilateral mastectomy. So she proceeded with that, and level 1 and level 2 axillary lymph node on the left side was done for her as well. So this is the final histopathology after the mastectomy, which shows multifocal disease, at least 4 foci of this disease seen all over her, all quadrants basically, extending with the retroareolar area. The size of the disease, they were between 3 to 26 millimeter in size, and it's again high grade. The treatment effect was assessed, and there was no definite response to pre-surgical therapy in the breast or in the axilla. So effectively, our neoadjuvant chemotherapy did not do much in that patient. In terms of the biomarker, post neoadjuvant chemotherapy, still estrogen receptor 2 out of 8, progesterone 0 out of 8, HER2 2+ non-amplified with a Ki-67 80%, and extensive lymphovascular invasion present. Nodal status 3, lymph node is still positive with the largest size of the disease in the lymph node, 2 centimeter in size. They stage here as pathological staging YPT2, PN1, and basically After the surgery, she received the adjuvant radiotherapy to the axilla and also chest wall boost as well. Is that what you agree with, Dr. Ibrahim?
Yeah, so chest wall boost in the setting, usually we give it in the setting of T4 disease or inflammatory breast cancer or residual, or positive margin in case there was something. But we don't usually routinely give chest wall boost.
Nonetheless, this patient received that one. I guess, again, based on Createx X, a lot of us, we possibly offer this patient adjuvant capecitabine and continuation on pembrolizumab. I don't know if anybody disagrees at this point. So if not, this is what we did. And, before we actually started this patient on capecitabine, and that is around 4 weeks after surgery, we did a ctDNA for her. So this is her ctDNA, and ctDNA was positive at the level of 60.88 mtm per ml. I just want to ask that question from Professor Cargigliano. Is that useful in this situation? What would you advise for this patient that they are high-risk disease with little response to the neoadjuvant chemotherapy? What is the role of ctDNA in this situation?
We have some data from the C-track triple negative adjuvant trial. The PI was Nick Turner. In the context of that study that was designed exactly for this patient population, residual disease and ctDNA positive after surgery, the majority of the patients were already metastatic in that study. That's why the trial failed, because in the idea of the trial, there was a randomization to pembro versus observation, but 78% of patients were metastatic. So first, I would perform a PET scan for this patient to exclude metastatic disease. If negative, I would consider one of the adjuvant trial ongoing with ADCs. There is one that is the SASHA trial with sacituzumab. There is another one with datopotamab. But the probability to have metastatic disease in this specific patient is very high.
Thank you. So the PET-CT scan was done at that time, apart from some reactive lymphadenopathy at the site of the axilla where the previous surgery was done, and there was no evidence of distant metastatic disease. Any of our colleagues, they advise to do anything at this stage instead of continuing capecitabine and pembrolizumab in the adjuvant setting? Maybe Professor Tripathi, you have any comment at this point?
No, I agree with what's been said in that the current assays that are available for circulating tumor DNA are not yet sensitive enough for us to count on just adjuvant systemic therapy. Most of these patients do go on to get metastatic disease. So I think I think we need to continue to test the concept of giving these patients a second chance at adjuvant therapy, but we first need more sensitive assays. So I think for this patient, you said the scanning does not show anything at this time, right?
No, correct.
Right. So, this patient, of course, is at high risk for progression. I generally want to put patients on protocols if we can. We do have a protocol with sacituzumab for patients who are in this situation. But I do think that systemic therapy, while you can try it doesn't seem to be that helpful in this group of patients. At the same time, if you knew already that the patient was responding to a therapy previously that they had received, I would continue to use it. If the patient is in good shape, we don't know enough to totally say it's not going to be helpful.
Okay, so we continued with capecitabine and pembrolizumab, and a couple of months after that, we measured the ctDNA, and there is a drop in the ctDNA, so we are encouraged to continue with that. But suddenly, the ctDNA start to go up, to a higher level. And at that point, the patient has a skin nodule over on the same side of her breast that she had a mastectomy. That skin nodule is small, around 10 to 12 millimeter in size. And a biopsy was done on that skin nodule, which showed compatible with recurrent disease on the chest wall with extensive cutaneous lymphatic vascular invasion. PET-CT scan again was done at this point, which showed no evidence of systemic disease. At this point, Ernest, would you advocate anything for this?
First question, the PET-CT scan did not show any signs of systemic disease, but did the nodule come, was the nodule show up?
Correct.
On the PET?
Only the skin nodule.
Only the skin nodule?
Yes.
Yeah, well, you know, once again, I think that's one of the most easily amenable lesions to resect surgically. But on the other hand, why not use this one as a clinical response monitor for any future therapy, rather than to go for circular tumor DNA every time, which is much cheaper. And once it progresses, you can either adapt your therapy, and if there is not all resources are used, then surgery may be in place.
Professor Nuhat, would you do something differently at this moment, resect or systemic therapy?
No, definitely I would not resect. I agree with that. I'm happy that my friend and surgeon is against surgery. I would use it as a marker. It's much useful than following up with ctDNA, because, you know, it does not really help very much in that situation, and I will do accordingly.
Dr. Mark?
I think this is an interesting one because the patient hasn't got systemic disease, and we're all advocating a change in treatment before she's got metastatic disease, and I would regard that as burning our boats a little bit. So you're responding before you actually need to. So yes, at some point she's going to get SG. At some point, if she lived outside the UK, she'd get TDXD, but we can't use it in HER2 low in England. It's usable in Scotland. But I think that you've got somebody who at some point is going to get metastatic disease. Why are you using a line of relatively toxic chemotherapy to treat an itty-bitty little skin nodule when at some point they're going to have really life-threatening disease, and you say, well, we can't use TDXD or SG because we already used it to treat this non-life-threatening skin nodule. So I think there is an element here of actually playing it and treating the patient, not saying, well, we've got a skin nodule, we're going to use this as a biological marker. So I would be up for taking out. The other thing is this persistence or is this metastasis? And if the patient's, if it's in a mastectomy flap, it may be that it just wasn't adequately cleared by the previous surgery and radiotherapy, and it's not a marker of systemic disease. So I would sit in my hands a little bit more here and try and play the long game.
Thank you. So that is a little bit of a division in the, you have Marwan?
Yes, the only thing I would like to add is to do some molecular biology on this new biopsy also. Maybe we're going to have any target.
I think, you know, we went with what Dr. Verrell recommended. We felt that this was a small disease to really try to actually give systemic therapy for that. So we went and basically resected this disease. I mean, this is now a disease that around 4 or 5 months after the neoadjuvant chemotherapy, radiation to the chest wall, and it's still happy going in that part. So we took it out, came back as ER0, PR0, HER2 again FISH non-amplified, and we sent it for Caris molecular profiling, which showed no actionable mutation and no PD-L1 expression either. So shortly after this surgery, the patient comes back with another patch of skin disease in that area, which is not like a nodule, but it is a flat redness in that area, which was not resectable anymore. I mean, there was no more skin to be able to close. So what do we do now?
Don't resect.
We couldn't actually. Yes.
No, I'm just a joke. I think I always come from the point of view that breast cancer is a systemic disease. And if this nodule came like 10 years later, I might be more permissive and say remove it. But we did not have very good response on neoadjuvant therapy in the first place. Maybe it's only prevented it from progression, but it did not respond. You did not show us on pathology chemotherapy effect on the tumor, so we knew that the chemotherapy did not do anything there. And now the challenge is how to treat. And if this patient started with systemic therapy and it shows the response, it's okay to remove it then. So you need to prove the chemosensitivity of these tumors before you remove them, because this patient, unluckily, she recurred in a radiated field, but also it could be in the liver, could be in the lung. And I would not spare chemotherapy until she has more advanced disease. The lower the burden, the better the chance you may give her more mileage from therapy. So I would not have removed it in the first place, and definitely in the second place, definitely I would, like Marwan said, I would do NGS on the tumor to give me some guidelines for later on, but definitely systemic therapy.
So, no, Professor Cargigliano, there is no actionable target here. We have another patch of disease here on the chest wall. That is a ER negative, PR negative, and HER2 2+. It's a triple negative patient, so we're going to start some systemic therapy here. What is your recommendation?
No, my first option was also before trastuzumab deruxtecan. I completely agree with the surgeon that said this patient has no indication to surgery since the first local recurrence. So I would propose 100% trastuzumab deruxtecan.
Perfect. So I want a vote here between trastuzumab deruxtecan and sacituzumab govitecan here. Dr. Tripathi, would you advocate for sacituzumab here or trastuzumab deruxtecan?
I would opt for trastuzumab based on the data we have from the trials available to us. So that's my vote.
Anybody else is for sacituzumab govitecan here? Mark?
I think it's very interesting that we're prepared to make a recommendation on a 10% population within a trial that's been looked at as a subgroup analysis. So while we all get very excited by TDXD and think it should be put in the water, actually the amount of evidence in favor of SG is greater. So I would like to play devil's advocate.
But doesn't this patient have HER2 low? Not.
She does, yes.
HER2+, right? So it's not like, you know, HER2 0 or null, right?
Oh yeah, I'm just being provocative, because the other thing is we had a patient.
So last time we listened to you, Mark. This time we didn't. So we went for trastuzumab deruxtecan, and this is the time point that we actually started her on the treatment, and basically. Very rapidly, she had a response to treatment, as you can see on this Signatera assay, with reduction of the ctDNA to 0.2, and then subsequently to 0.05, and then eventually to 0 completely. So the patch of the skin also responded extremely well within the first 2 cycles of treatment, completely disappeared. So what do we do at this point now? So we have a patient who has no evidence of the ctDNA, the skin lesion has gone. Where do we stop?
If you allow me to comment, actually, I would have done exactly the same thing as you did, actually. But the question is that the role of ctDNA, I mean, we don't have any approved assay yet, so what is the utility? Although it gives us a sense on how the patient is doing, but now we have a clinical picture where we actually assess the patient, so I don't feel that would be a cost-effective situation for the patient. Maybe we could have utilized the money on something else. But having said that, I think I would definitely, if the patient started to progress from there, then the next option will be to do another antibody drug conjugate as opposed to like jump into chemotherapy. And at that point, I would do sacituzumab govitecan.
Sure. So the question here is that how we do actually utilize ctDNA in patients with micrometastatic disease. I mean, obviously, this patient had metastatic disease on their skin, so it is not completely based on the ctDNA. Nonetheless, I think there is no evidence of distant disease. And, you know, how do we actually use ctDNA? How do we monitor the patient? How far are we going to continue with the treatment? And, you know, how accurate is ctDNA in predicting the long-term response to the treatment? Professor Cargiglione, do you have any feedback on that?
You know, we don't have very much data on this. For triple negative disease, the only data we have are from the C-TRAC triple negative trial. This is not the standard of care, of course. For sure, in many models, a ctDNA clearance usually may correlate with a better outcome. This doesn't mean that this patient is cured. I absolutely don't think this. But you need a prospective randomized trial in order to understand how much the liquid biopsy should have a clinical utility and clinical validity to inform our decision making. In my opinion, this is a metastatic breast cancer patient. Independently of ctDNA clearance, you should continue with trastuzumab deruxtecan.
Professor Ibrahim?
Yeah, you know, I agree with Ernest. You know, you had a biological marker while you're doing this expensive test. Number one. Number two, it is not validated for that purpose. We don't know how to interpret the data. We don't know how to use it. We don't do it at MD Anderson on a regular basis. We're developing protocols to study more these issues and with the understanding there are more than one way of testing it, and some tests are more sensitive than the others. So really, we do not understand it. It might reassure you, it might make the patient happier when you see the numbers is lower, but what is the biological meaning of this trend? On the surface, it's easy to explain, but really we do not know. In that case, if your question is what to do next, I do not do more NGS on her, I don't do more ctDNA on her. I would keep giving it a chemotherapy for as long as it's tolerated and there is no evidence of progression.
I would like just to add just one comment favoring the ctDNA. I agree with all what have been said on that we don't have data, etc. But what would you do after 2 years of response, let's say on HER2? Will you stop? Will you continue? So maybe if you have some data on the ctDNA coming from before, and you have a long period of time of negativity on your ctDNA, maybe it will help you to decide on an optimum date, maybe to stop the treatment if the patient does not tolerate really well the treatment. We need some data, but it might help us, not only reassure us, but give us some clues on how to do for the future. If we can do it. We
do collect this data on the patient, but we do not put it into a clinical use because we do not know. I'm sure in 2 years, maybe I would. I'm ready to come back and say I was dead wrong.
Yes.
But at this point we do not know, and if we know at one time about how to use or to interpret or to benefit from that, no doubt about it. But at this point there remains a research entity.
Agree completely. Ida, you have any feedback here?
Yes, actually, we don't have a patient advocate in here, but I always like to speak from the patient's perspective. Although these technologies are very important, but it will add to an anxiety for the patient. What if the patient had a complete remission, let's say, on the systemic therapy, but we continue to measure this copy, the circulating DNA, and it goes up, and then it will add to the element of an anxiety while she does not have a measurable disease at that point. So just from that perspective, I would be more careful of adding more testing and looking into the patient perspective and emotional sort of feeling in this regard.
I agree. I think, you know, it is difficult one if we agree with the point that I actually do agree with Professor Cargill on this, that, you know, this patient has a metastatic disease, and then like any other metastatic disease that we do, we should continue with the treatment. Often in patients who have measurable disease on the imaging, we do every now and then do a scan to find out whether our treatments are working or not. Perhaps, you know, this is what we should do in this patient as well, every now and then measurable disease on the scan. But again, you know, ctDNA may give us another layer of information here. We still don't know how to use it. And, you know, I think, you know, we are all waiting for more data to see how it... Mark, you have any?
Yeah, I was just going to make the point that you're going to be doing regular CT scans anyway to look for evidence of ILD. So the question then is, if you're scanning her and she gets a ctDNA rise without CT changes on the scans that you're doing anyway, are you going to respond to another rise in ctDNA, or are you going to wait until there's CT evidence of change? And I think that, having been around for a few years and treated more cancers than just breast cancer for a long time, it takes me back to all the data that Gordon Ruston looking at changing treatment in ovarian cancer on the basis of CA125 rises. And it was a busted flush, and it's probably an advantage to wait for the CT changes, because they may give you a lead time bias, and so you think your patients are doing really well when you change on the basis of a blood biomarker, whether it be ctDNA or CA125 in ovarian cancer, but that just means that you're changing your treatment earlier. It doesn't mean that you're improving the outcome for your patients. So I think that ctDNA is, in my book, it's really, really interesting. I was on the IDMC for C-TRAC-TN with Giuseppe, so there were some quite challenging conversations that we had to have based on what was happening with ctDNA and the predictive value for metastatic disease. But I think once you've got metastatic disease, the proverbial cat is out of the bag. And I'm not completely convinced that it helps you, other than making you work through your treatment options quicker, because you change before you necessarily need to. And these people are incurable with if you look at the ESME real-world data, they've got a median overall survival of 14 months. If you work through all of your chemotherapies in the first 6 months, then in month 7 you've got a terrible problem with what to do. And though in some settings, in England, we're restricted with some of the drugs that we can use, and we don't have the flexibility to chop and change in the way that may be possible in other healthcare systems. So I think there is still trying to play a chess game with the cancer and try and make the journey last for as long as possible.
Thank you.
Did you get human markers on her?
We have actually, and that is an interesting one. I didn't really want to dwell on that too much. We actually have seen the CA15-3 at the same time that the ctDNA was very high. It was also high as well. It responded very nicely to the treatment. But within the past few weeks, something strangely happened. The ctDNA has become negative, and the CA15-3 has started to elevate. We still don't really know what is going on, and that is the complexity of really how to interpret this conflicting data.
I think...
Well, over time, what happens over time is the ctDNA becomes less sensitive because the tumor is mutating, and the tumor-informed pieces of DNA that you're using for the assay don't match as well. So what sometimes they do is they get another liquid biopsy and they redo the tumor-informed component, and so Signatera has a partnership with Foundation One, for example, where they do that.
Perfect. And one last question also for you, because I'm really aware of the time. Dr. Tripathi, if this patient progressed on trastuzumab deruxtecan, now given the lack of information about ADC after ADC, would you recommend to go for sacituzumab govitecan in this patient?
Yes, that would be my choice. I think you can use another drug like eribulin, for example, or platinum-based drugs, but I would go with sacituzumab. That would be my choice. And it's not, we haven't done trials for it. That's just my gut feeling.
Yeah, so this session will not be obviously complete without Dr. Hassan giving his last comment. So we give him another.
So just a comment. So you know, this is an expensive tumor marker. As Nuhad asked you, I was going to ask you about tumor markers. To me, this is a tumor marker. To me, since it was positive and you proved a clearance, I would personally continue. Actually, I have patients with colorectal cancer. They are asking about this even before I recommend it to them, if they have read about it. So as long as you know what to do with it, I think it's okay. And by the way, for the cost, if you combine all of these, it's half a price, half dose of trastuzumab deruxtecan and all of these.
Okay, Hussam. I think somebody needs to give microphone to Dr. Hussam.
It's just a question regarding radiotherapy, because with all respect, Saeed, rather than questioning, you know, something about circulating DNA is that not really proven, it's more something maybe would have helped the patient. For a patient who's mastectomy, for a long time we question chest wall wax bolus. For some time we don't do it in the UK. I think the Danish showed 5mm wax bolus will certainly reduce the risk of recurrence, and that would have been possibly far better for the patient if we improved the skin distribution radiotherapy. Is that something we do routinely, 5mm wax bolus to the chest wall here, apply it in UAE centers, or what's the practice?
Thank you. Thank you so much, everybody. Thank you.
Let me answer that.
Yes, sure.
Just because it's a question, it's not a comment.
Now what can you know?
Yeah. So to answer yes, you know, I can't speak of all the centers, but yes, in routine practice, I mean, I trained at the Anderson breast unit, and yes, chest wall bolus is one of the things on our protocols. For inflammatory breast cancer, we use it throughout the entire treatment. For the other kind of just chest wall boost or chest wall radiation, it's usually week on, week off. So yeah, to answer you, we do use chest wall. I don't know where this patient was treated, but yes. The other part, I just want to comment that there's data on re-irradiation of the chest wall in the setting of local recurrence. So usually it's complement surgery as well, but you usually give a slightly lower dose. We give 40 gray in 20 sessions. So there is some data on re-irradiation, but again, this is just the tip of the iceberg, as you can see. It's a systemic disease.
Thank you so much. I just want to thank Professor Cargigliano, Professor Tripathi, and everybody else who attended this. Thank you.
Thank you. Thank you. Yeah.
Okay, so we will move on to a very hot topic that we always deal with in breast cancer, and we yet don't know the right answer for this situation, which is the oligo. You look so right. Okay, so it's an oligometastatic breast cancer. We always face this situation in our clinic, and there's a lot of controversies, a lot of different approaches. I think we will put everything together and maybe try to come up with a consensus. So we'll start with the talk by our radiation oncologist, Dr. Ibrahim Abu Ghaid. With my apologies. We always like to start with medical oncology, right? So our honor, we have Professor Nuhad Ibrahim, who's going to give us his expert opinion and the MD Anderson approach to oligometastatic breast cancer in the modern era. Thank you so much.
Thank you, Aida, for this introduction. Actually, my preference to start because I want to keep the best to the last. How about that? You know, when Aida was emailing me about this subject, I said, okay, I don't have much to say. not much to say, not much data to present. And I knew that most of the data, probably with radiation and also with surgery, but not to admit failure, we are doing studies on this, but still, you know, it's very early and in the making. So basically what I decided to do, as I told Ernest earlier, I'm doing an introduction to you. So the most intriguing thing to me, and And actually, at one time, but it's still on my list to do, is to define oligometastasis, what it is. We do not know. And putting my thoughts together, which were the core of a clinical protocol, clinical research protocol, that one of the fellows is showing interest in it, that I drafted maybe a couple of years ago, but did not pursue it. It's my laziness. Is what is it? Oligometastasis. We started with solitary metastasis, which is very easy to define. It's one single lesion. We talked about one of those today. But oligometastasis, what is the number of oligometastasis? And I will try to go over this issue a little bit later. Not only that, are all equal? If they involve one organ or different organs or more than 3 organs, are they still considered or behave like oligometastasis? Are there differences between synchronous and metachronous appearance of these lesions? Do their biological subgrouping make a difference? Maybe yes, and I will show you some preliminary data on that. The time of occurrence, like we said, also we touched on that earlier. Something comes like immediately after receiving neoadjuvant therapy, or in 10 years, for example. So what do we do about all of this, and not to forget about microRNA expressions, and this is going to divide this more into smaller groups. And the more you think, the more you come up with the questions only to tell me that do we know what we are talking about? I don't know. So Astro came up with some definition, which is probably most used, which says 1 to 5 metastatic lesions, but they do not specify very much more than the counting of it. But at least I would say we have a starting point, but there is not very much consensus of that. And I put some papers because I looked at how do you define it? What are the published material on that? And really, I did not find damn slung definition of it. But I started, getting information about my questions. For example, in this review about the pulmonary metastasis, where they're trying to define oligometastasis, and they talked about different grouping in pulmonary metastasis, like a single resectable lesion that appears within 36 months, multiple lesions that appear less than 36 months, more than 36 months. So they started, looking at the number and the time of appearance. And the same paper also look at hepatic metastasis. It's an older paper, and it is not very informative, but they address, like there were some attempts to look at hepatic metastasis, but really it was not very informative, except looking at the table and see the 5-year survival of hepatic resections. But this is all tumors, all put together, and we really could not learn very much about that, except like saying that somebody was trying or thought about looking at it. In data study, they're looking at resections. Another paper, they were looking also about the effect of radiation, and Brahim is an expert on that. I know he's going to address these issues in greater details. But also you see that all the tumors were put together in this situation. In this study, only 15% of the patients were breast cancer, and I am sure, and many of you would agree with me, that a metastatic breast cancer to the lung is not the same as colorectal cancer to the lung, for that matter, and so on. But overall picture is that radiation therapy did help these patients, but definitely more details will be addressed later. Purposely, I did not want to go through it. Number one, because I'm not a radiation oncologist, and number two, I knew Brahim was going to address that. When you're looking at breast cancer papers in specific, there were very few and scattered papers. The common denominator between all these studies were small series, and very hard to get information about that, and only tell you that we need to do more work on this subject. And in this paper, which about only 70 patients that were reviewed, and many of them took systemic therapy, and a lot of them took a variety of local approaches, like using surgery or different forms of radiation therapy. But also they looked at the biological profiles of these tumors in terms of hormone receptor and HER2 amplifications. And indeed, it showed that the triple negative is probably acting the worst, not necessarily so. This is a small study, but it shows that the triple negative is the worst. And then when we took the multivariate analysis, indeed, it shows that those who benefit best are the hormone receptor positive, HER2 negative, and also the metastatic lesions that are addressed by surgery, although the majority of the data is in favor of using radiation therapy more than surgery. And in this paper also tried to address the number of the lesions, and again they're looking at the different numbers of lesions, but the majority of the literature is about less than 5 lesions as considered as the definition. But I'm not sure of that. Maybe we should change it, or maybe we should come up with more defined entities. And all these numbers were based on different types of studies. Since we are in a breast session, the least of them were on breast cancer patients. So we are very, very deficient in data. I think the most were addressed were in lung cancer and in prostate cancer. To a lesser extent in colorectal cancer. I do not know why in colorectal cancer was so few of those, although we know that, as I show later, that probably they benefited a lot. And another paper also looked at the number of the lesions, and still less than 5 were the majority, and probably this is why ESRO came up with 1 to 5 lesions as considered as a solitary or oligometastatic lesions. But when you look at all those randomized trials that look at these lesions, and as you see here, the majority were treated with radiation, with or without surgery. Majority of them were non-small cell lung cancer. The first study, COMET study, has a different grouping of patients. It has some breast cancer patients in those. Also, a couple of papers were on prostate cancer. The nice thing about it that we're uniformly showing benefit. And this is the patients who have different types of radiations with or without surgery. And interestingly enough, that caught my eyes is that the CRS, the colorectal cancer patients did better than everything else. I do not know why. Remain to be addressed. Probably we can learn more with my colleagues who is going to discuss this topic later on. So definitely the treatment is an aggressive multimodal approach, but in this paper, what they meant by multimodal is surgery and radiation. They did not mention about chemotherapy at all. And then they put this diagram is how to approach this patient. And if you look quickly at this diagram, it's a combination by majority of radiation and therapy. And I have going to give you a little bit comment about that a little bit later. At this point in time, I found this table published in 2023 about ongoing randomized trials. And you see histology mixed, they're taking everything together. I don't know how we can learn when we put colorectal with the prostate cancer, with the breast cancer, with the sarcoma for that matter. But hopefully we can learn something about it, and hopefully that there will be some biological arms to these studies so that we can learn more about these diseases. So what did we take home from all of this? Is that the phase 2 data about ablative treatment in patients with oligometastasis is very promising. We practice it, you know, and I'm not saying that it is something we should not do. We do, but definitely we need to do more about these patients. In my opinion, when I see patients that are solitary or oligometastasis, as in the case that we discussed earlier, before resecting it or before radiating it, I prefer to prove chemosensitivity of that lesion before I do anything. And again, and I remember even when I was a fellow, the first lesson I learned is that breast cancer is a systemic disease. And I believe it, I witnessed it, and I see it every day. So every time, even before we address an oligometastasis, we need to show chemosensitivity, and then you feel more comfortable dealing with that lesion or that lesions as needed. Breast cancer specific data are still coming. There are some studies going on. Majority of them do not have chemotherapy in it. But at MD Anderson, we are getting a trial that we're assessing standard of care, which be doctor's choice, versus assessing chemosensitivity before we addressing it definitively with surgery or with radiation therapy, and probably with both. We do not know really about that. So are we ready for phase 3 clinical trials? Yes, as an oncologist, I always look at phase 3 trials. And indeed, there is no level 1 evidence studies yet. They were all smaller studies. Many of them were retrospective studies reported, and many of them showing benefits. And I believe in the benefits, but still we do not have randomized clinical trials in that. There are some ongoing with small non-small cell lung cancer, prostate, and colorectal cancer, and also in some trials that they took everything together and put them together. I do not know what the investigators on these multiple histology studies would be able to learn from that, but we can always find some lessons in anything that it is done. Comet 3, I'm sure there will be a lot to be said about Comet 3 a little bit later, but still we are waiting at more definitive data on that trial. Comet 10 also is coming up as well, we need to wait on the results of this ARREST schema. This is only a list of the trials that I could find in literature so that you can stay tuned to those studies, and I'm sure there is more than these, but definitely we need to monitor the data continuously, at least from the medical oncology point of view. I like to see more data about determining sensitivity of these lesions before we do with definitive therapy. And again, I have my concern about the definitions, because I'm sure there is more into it. We hope with the review of our data at MD Anderson, and we have a huge data there. I'm sure we are going to find sufficient numbers to answer some of the questions there. But definitely, it is a very early developing field, I would say, and I would thank you for that, and leave the room for my colleagues to help me out to get better answers. How about Ibrahim? You ready? Or Ernest, who's coming first? Was it a good introduction?
I think the main course has already been served, is it? Thank you. Thank you. move forward is this one, okay? All right. First, thank you, Professor Hamid and his team for having me here. And when I talk about his team, I especially like to also to mention Dr. Aida, a colleague I used to work with, and I really miss her already. So having said that, I realized this morning that this may well be my last talk as a practicing surgeon, although I could have run another mile. As for now, this may be the last time, and there's no better place to do that in a group of of my friends here on the Emirates Oncology Society. So thank you for giving me that opportunity. And I was called last week by Micheline, and she's also always giving these nice phone calls and asking me, like, would you be willing to give a talk about the role of surgery in oligometastatic disease? I said, of course, I'd like to do that. The only disclosure I have is that I didn't have access to PubMed, so I had to do it with the abstracts. So let's move on. So if we talk about the role of surgery, where's my screen? Oh, there. We have to go back to the process of the breast cancer stem cells disseminating to cause clinical metastasis. And this surgeon there, with the pointer, will guide you. Initially the breast tumor is confined to the breast. But the problem starts when tumor cells are starting to disseminate to become distant metastasis, either microscopically or limited microscopically, or the visceral crisis. And I joined this session in 2013 in Washington when there was a James Ewing lecturer, and Giuliano, he said, the smart cells will go by the blood and the dummies will go by the lymph. And that's where you come in as medical oncologist, because once there is hematogenous spread, then all alarm bells will go off, and this is what it's all about, this Congress. Where do we stand as surgeons? Well, as long as the breast tumor is confined to the breast, we are definitely in the lead. But I worked with my dear friend Philip Portmans, the past presidents of the Astro, and we operated also on recurrent breast cancer. He's a very nice guy. He's a very bright guy, by the way. And we calculated the time elapsed interval between like the initial stage, like the initial start of breast cancer, and the lesion to become only 1 centimeter. And that's about 6 years at least. So if you ever, by the way, if I make a sidestep, if you ever have a manager trying to punish you for your waiting list, that the waiting list for some start of treatment like neoadjuvant is 5 instead of 4 weeks, just tell him that the tumor is already there for like 6 years. On the other hand, it also gives like a relief for patients in your consultation room to tell that there is no need to really hurry, because the tumor is already there for at least 5 years. Still, we want to make some progress. But we already know for 20 years that in stage 1, 2, and 3 disease, if you go and look for it, that micrometastasis disease in bone marrow is already present in more than 30% of cases. And in a multivariate analysis, it was an independent predictor of poor outcome. So actually, as surgeons, in the case of metastatic disease, we are already in business. But then, in 1995, Hellman and Weichselbaum brought up the definition of oligometastatic disease, like a transitional state between locally confined disease and widespread metastatic disease. And they postulated that a subset of patients with a small number of macroscopic metastases may have a limited microscopic tumor burden and could be treated with a curative, between brackets, local therapy and adjuvant drug therapy. And there we go. However, currently about 6% of new patients presents with de novo and metastatic disease. And only 10% of them is possibly oligometastatic disease. So we're talking about 0.5 to 1% of all patients presenting with de novo oligometastatic disease. And we have to bear in mind that with sensitive imaging for breast cancer, the question arises whether present-day oncologists treating de novo oligometastatic disease with palliative systemic therapy which a few years earlier would have been treated with curative intent, and then presenting excellent survival data, like 3 years overall survival of more than 80%, which I will show you in a minute, are reported. Yes, of course. And as surgeons, we're more or less put out of business. But to treat distant metastasis, actually the way to go is stereotactic radiation. And so it were the radiotherapists who took the lead to make a proper definition, set up the proper definition of oligometastatic disease, because you cannot point your gun at any metastasis like 20. And due to the ability to deliver safe and clinically meaningful radiotherapy with curative intent to all metastatic sites, consensus was set at 1 to 5 metastatic lesions. Some studies talk about 8, but 1 to 5. Independent of primary tumor, independent of metastatic location, independent of the time interval, and both synchronous or metacoronous. The systemic-induced therapy-induced oligometastatic disease is a distinct state. So when the job is done by the medical oncologist, all eyes are back on the surgeon and the radiotherapist. What are you going to do in an MDT? Like, we had such a nice response and the PET-CT scan is now normal. Let's go for aggressive local regional therapy, which is, in this case, for surgeons, like surgery of the breast plus or minus the axilla, and radiotherapy to the 5 distant mets. There are some groups that report on surgery for distant mets, but they're very rare. The role, altogether, the role of local regional treatment, either surgery and or radiotherapy of primary cancer and intervention to metastasis is up till now unclear. And the results from retrospective studies investigated the use of surgery in de novo metastatic breast cancer are conflicting, and these studies have methodological limitations and selection bias. I'll show you. I'm not going to bombard you, which is more like common use on medical oncology congresses, with a whole kind of bunch of tables. We surgeons like to keep it simple. But my attention was caught by this study from India, where they presented a 30-year experience of patients with oligometastatic disease, and the ones that developed complete response went on to proceed with local aggressive local therapy, surgery plus radiation. And they present an overall survival rate of 20 years, mind you, of non-responders and responders of 30% and higher, and patients that were treated with local therapy, 20-year survival of 50%. So actually, my take-home message from this study was, if ever a patient is diagnosed with stage 4 disease, there's only one country to go, that's go to India, because there is where you have to be. Meta-analysis of de novo stage 4 breast cancer was analyzed over 200,000 patients, a lot of studies which I showed here on the slide. And they also came to some kind of conclusion that there was a significant reduction of mortality of more than 30% receiving local therapy. However, there is evidence of publication bias, and there you go. Do we have any randomized controlled trials? Yes, we have. There are a few underway. There's a Japanese trial underway and another one which I cannot remember. But we have, I went into these 4 trials, and actually 3 of them did not reach any clinical significance of adding local aggressive regional therapy, either surgery plus or minus radiotherapy. And here, if you look at the overall survival there, they are much more realistic. Even the study from India, the first one, like 2-year survival rates of about 40%, which is like a little bit more realistic than 80%. But anyway, there was no clinical benefit of adding local regional therapy. There's only one study from Turkey suggesting a benefit especially for ER-positive, HER2-negative patients, younger patients, and patients with solitary bone metastases. But overall, due to uncertainty with regards to tumor biology and molecular mechanisms underpinning metastasis, the benefit of primary surgery on mechanistic level is unclear. Sorry for that. So where do we stand as surgeons? For local control in cases, you may question if you have to maintain local regional control after having achieved complete response. It's a little bit contradictory that in these cases we're pushed towards surgery, while in the neoadjuvant curative setting, we're setting up studies to even refrain from surgery in patients that are complete responders. Of course, in patients refractory to systemic approaches, ulcerating breast cancer, not responding to any kind of therapy, salvage mastectomy is the way to go. And if you really want to go investigate isolated recurrences, you may want to go and have that surgery done. How about local intervention to distant metastatic sites as preventions of fracture of bone lesions? In my career, I've put a lot of intramedullary nailing for humeral and femoral possible fractures, and then have afterwards them radiated. But to go for liver resection or lung or even brain, and mind you, I had one patient here in the Tawam. She presented with an ulcerating breast cancer, having a mastectomy on the right side 2 years ago. And then I asked her about the scar on the head, and she said, oh yes, I had 2 brain surgeries. I said, well, what was it? Yeah, they took out some metastasis. I said, what? Bring me that pathology. And there was like some kind of cowboy that had gone for brain surgery, and it was a radical, and they even went back. So anyway, each case, and finally, should be discussed in a multidisciplinary meeting, especially if local treatment for metastasis is being considered outside established guidelines. And in addition to potential high morbidity for patients, unnecessary local treatment contributes to additional cost to healthcare and does not give any clinical benefit. Here on the right side, you see cowboy boots. And I remind you of the song of Nancy Sinatra in the mid-60s. These boots are made for walking. These boots are made for cowboys, and that's what they are. And there is no place for them in the OR. Thank you so much.
Thank you very much, Dr. Luton. We'll keep the questions till the end. And now we'll hear the sound of radiotherapy with Dr. Ibrahim, and then we're gonna try to wrap up at the end. Thank you.
Perfect. Thank you so much. We'll try to be quick just to catch up on time. So good morning, everyone. Oh, buongiorno, since I'm Italian, apparently. But it's really good to be here. So I'm not gonna go over this. I have a couple of slides that overlap, so I'm gonna skip them. And I will go to the recent phase 2 evidence for that. So first of all, unlike Dr. Ernst, I knew about this talk yesterday, so I would like to thank my friend Abdul Majid Dayat, who really was kind enough to lend me some of his slides, and our colleagues, Dr. Mariam Aslani and Dr. Rana, for their support. So this is kind of what is oligometastatic breast cancer. You know, we know that it is, there's multiple theories. It goes back to 1995. Again, it's a spectrum of disease, and oligometastatic is somewhere between localized disease and widespread metastatic disease. So we know that systemic therapy is the mainstay treatment for metastatic breast cancer. There's no question about this. So the treatment goes prolonged survival, improve symptoms, and improve quality of life. So we know that breast cancer is also divided into, HER2 negative, HER2 positive tumors. So in HER2 negative tumor, we have the HER2 positive, which have a lot of strong systemic therapies. In HR negative, we have the chemotherapy plus minus immunotherapy, and in BRCA patients, we have the PARP inhibitors. In HER2 positive, we have anti-HER2 directed therapy as well. And we can see from this change in survival over years with metastatic breast cancer patient, and this is mostly related to the very advanced systemic therapy that our colleagues from medical oncologists are now providing. So we can see that there's a shift for patients to live longer, even with stage 4 disease. In the same time, I keep on hearing the aggressive. Actually, radiation is not that aggressive. Surgery is, but the radiation, patients comes in, we do the treatment in and out, and they leave. Because we are able to do so with the new modalities of radiotherapy or radiosurgery, we are able to really target with a very high dose and high precision the lesion, and with minimal toxicity, and most importantly, minimum interruptions to systemic therapy. We know that the radiobiology of stereotactic radiosurgery is different than regular fractionation. And with radiobiology, we are actually affecting the tumor cells and the tumor microenvironment, which is extremely important in the case of systemic therapy, because as I mentioned, we change the microvasculature, we change the microenvironment of the tumor, and we might actually enhance the patient's immunological response to immune therapy with SBRT. So again, this is the kind of the landmark study that have defined the definition of the oligometastatic disease, and this is led by Wendy Woodward, my mentor from MD Anderson, and this shows they reviewed all this and they have defined the definition of oligometastatic disease into synchronous versus metachronous, oligorecurrence, oligoprogression, or oligopersistent disease. We can see that the definitive radiotherapy for oligometastatic disease, there is a big international survey of more than 1,000 radiation oncologists, and it is quite widely used and utilized. So some also of reviews on ongoing trials for radiotherapy for oligometastatic disease. There is a lot of, as Dr. Nuhad mentioned, very few data on breast cancer. So this meta-analysis, which is about the stereotactic radiotherapy in treating breast cancer oligometastatic, included 10 studies. It's mostly retrospective, and you can see that the control rate was significantly well with the SBRT, with a minimal toxicity. So again, I question the term of aggressive treatment. Sorry. So again, based on this study, we noticed that the biology of patients with bone-only disease were slightly different than visceral disease. So we can see that patients with bone-only disease has a much better outcome than patients, this is the slide I wanted to show, the bone-only disease has a much better outcome than non-bone-only disease as well. So moving on to the three most important phase 2 trials, which is the SABR-COMET trial by David Palma that set the stage for SABR-COMET 3 and SABR-COMET 10, the NRG BR002, and the CURB study from MSK. So the SABR-COMET is a phase 2 trial that included multiple sites, including breast cancer, of patients who were randomized into standard of care with palliative radiotherapy versus SABR, which is the SBRT term, stereotactic ablative radiotherapy, to the oligometastatic sites. And in this study, we can see that in breast, there was not a lot of patients, as surprisingly, and you can see that the toxicity was not higher significantly, and the actually survival was improved when we do metastatic directed ablative therapy. Moving forward, the NRG, which unfortunately came out as negative, is a phase 2, planned to be a phase 3 trial, comparing standard of care versus SBRT when newly diagnosed oligometastatic, so this is de novo oligometastatic breast cancer, and it's stratified, it has to have less than 4 metastatic sites, and it included about 112 patients, and they were randomized between systemic therapy or total ablation for metastasis. And this is the protocol. So they excluded brain metastasis. Metastasis should be more than 5 centimeters, and the met size should be less than or equal to 5 centimeters. And the SBRT schedule was mostly every other day, and it has to begin within 6 weeks of study entry. So again, this is a phase 2 trial, 125 patients. However, 116 were enrolled. The median follow-up was 35 months. The median age was 54. 80% were hormonal positive breast cancer, and 60% had one metastasis only, and 20% had synchronous presentation, because some of them had oligoprogression as well. Sorry, I failed to mention this. So again, there was unfortunately no difference between the standard of care with the standard of care with ablative radiotherapy in this trial. So this was a kind of a unfortunately negative trial in our field that have kind of set a lot of tone back. Not only this trial, a study from MSK Memorial Sloan Kettering, which is the CURB trial, it had two category of patients, non-small cell lung cancer and breast cancer. And then patients did follow up for 12 months. It included 106 patients. Out of those, 47 were breast cancer patients, And 66 of those, which is 31 patients, triple negative, and only 16 patients were positive. And again, this study was negative for the breast. It was positive for the lung, but it was negative for the breast. So, based on these two, again, these are very small number of patients. Is that enough? Should we stop offering SBRT? So, real life, when we're talking about real life, so we know that breast cancer is a very diverse group of disease with different natural histories. Single metastasis in a lower grade tumor is much different than multiple metastases in a triple negative or HER2 positive disease. And both these trials, the NRG and the CURB, had actually a small number of patients to conclude. And there is a short follow-up. And we know from the hormonal positive breast cancer that a lot of those potential recurrences tend to be really late. So we need to keep this in mind. So to conclude, again, in order to be in time, so women with limited breast cancer metastasis probably have a different natural history with patients with more extensive metastasis. The outcome of metastatic breast cancer patients has improved significantly because of the systemic therapy advances that we have. The NRG-B R002 was actually, unfortunately, a negative trial showing no overall survival benefit or progression-free survival benefit by adding radiosurgery or radiotherapy. The ablative radiotherapy should not be offered as a first-line treatment for oligometastatic of a clinical trial, just to be on the safe side, because the trials were negative. There is an evolving role of oligoprogressive or oligopersistent breast cancer patient, because this is quite different biology than oligometastatic de novo. My opinion is that, as we always do, is that these cases should be individualized in a multidisciplinary approach. Consider treating them on our protocols, as I mentioned. And we need to really look at those patients who are motivated to be on SBRT. It's very important to have a discussion with the medical oncologist when they have further systemic lines of therapy that are not toxic, that the patient can tolerate. Give this a priority, because we know what we see on imaging is the tip of the iceberg. But when the change of line of systemic therapy, or there is no line of systemic therapy, or the medical oncologist is concerned of changing the line of systemic therapy because he or she knows that the patient might not respond to the second line of systemic therapy, and there is just a single lesion that is progressive, do radiate this safely as well. And after a thorough and well-documented discussion in the tumor board. With that, again, I wanted to really acknowledge Dr. Abdelmajid Dayat for your support and for this presentation, and thank you all for being with us today. And we look forward to welcoming you in Burjeel Cancer Institute in Abu Dhabi soon. Thank you.
Stay on the stage, Dr. Ibrahim, Dr. Luton. We have 2 or 3 minutes. I see Dr. Hassan, but before Dr. Hassan, I have one question for the 3 panelists. We are treating oligometastatic patients on a curative intent. We agree on that. These are patients who have oligometastasis, and we are treating them on curative intent. So my question for the 3 of you, do you have a difference if it is hormone receptor positive, HER2 positive, triple negative breast cancer? This is first question. And number 2, for the brain metastasis, what is the number of brain metastasis which should be considered still oligometastatic? 3, 4, 5, 6, 8, 10, 12? Okay. How many?
I can easily answer the second question, yes, because it's more related to radiation. For you. So the brain metastasis, most of the prospective trials initially included 3, 5. Now they are pushing the envelope up to 10 because of the ability to treat them safely. Yet we don't have published trials for 10 metastases. I know some centers in Japan is even taking it further. But we know that the fact that when we are seeing multiple brain lesions, and in order to achieve high dose of stereotactic radiosurgery, the entire brain is also getting some dose. So you are kind of doing a whole brain radiotherapy in the same point. So in these cases, so the guidelines says up to 5 right now in terms of prospective trials. More than 5, we sometimes individualize based on the patient's performance status. And ultimately, if we had to treat with whole brain radiotherapy, we are actually now shifting towards hippocampal sparing whole brain radiotherapy with memantine to decrease the neurocognitive toxicity. But this is for the second question. For the first question, maybe Dr. Nuhan.
We'll go to Dr. Ibrahim, Ibrahim. Micro.
The Japanese published on 15 lesions that you can address with stereotactic surgery. So, but can you repeat the first question?
Do you have a difference when you are dealing with oligometastatic disease on a curative intent? Do you have a difference in your thinking if it is triple negative,
I'll follow
hormone receptor, HER2 positive?
If there is no clinical trial, I'll follow the standard of care.
Yes.
I don't have a particular preference if it was on what agent to use depending upon the profile of the patient.
So I'm meaning how aggressive you can be. Let's say hormone receptor positive, maybe they have a better prognosis than the other ones, so you might want to be more aggressive than if you have a triple negative breast cancer patient, for example. I'm asking if you have.
No. I don't think there is, but you give the best that you have for that particular situation.
Okay.
So it depends really also. We know that hormone positive, tend to live longer, but in the same time, it's what systemic therapy options do you have? If you have a solid, which is where I ended, if you have a good, systemic therapy and the patient is maintained on a good systemic therapy and you don't need to change the systemic therapy, then will be that. But if you have a single lesion where it's growing and you don't want to change your systemic therapy, I tend to be, again, quote unquote aggressive, because I really don't think SBRT is a very powerful thing, but it's not as aggressive as people call it aggressive, because we're doing it safely now.
Surgery?
Well, I think it's a multimodality decision, and only to rely on the subtype is a little bit difficult, although we should not discard initial impressions like from the Turkish trial, stating that ER-positive, HER2-negative tumors and younger patients may be better off for solitary bone metastasis. But randomized controlled trials give the highest level of evidence, but they only start from lower level of evidence, like even expert opinions that feel like these are the patients that we should investigate. So if we ever go for like randomized or prospective trials, we may want to start with patients where there were like reports that they are probably better off. And then we may want to start with ER-positive, HER2-negative patients.
Yeah, I agree with you. Yeah.
Great. Thank you very much, doctor.
Yeah, actually, in the clinic, we sometimes see patients who are clearly eligible for SBRT, say, or surgery for solitary or two metastases. But after initiating systemic therapy, these lesions, like bone lesions, become negative on PET-CT. Should we go to treat this patient with SBRT or other local modalities, or just keep with the systemic therapies that already give us the complete remission? Yeah,
Dr. Ibrahim.
Yeah, you mean if they went into clinical remission on a particular, and yes, what you want to consolidate?
Complete
there
remission.
There is no data on that. Mm-hmm. If consolidating might help, there are. I should not say there is no data. There's anecdotal data about that. It may or may not improve. Myself, if the patient is in a remission, I would not do any further intervention. I just continue the treatment that the patient is responding to. But on the other hand, the question would be, if the patient has a lesion or couple of lesions in the liver, and you see that she is responding to treatment X, would you ablate those lesions and continue on treatment X? Probably I would be in favor, because there is older data to suggest that the patients who have a localized tumor and went into clinical remission, the chances that recur is highest in that same locality. So you want to treat the bed, the tumor bed in that case. But with the modern treatments that we have, this was not revisited.
Okay, thank you.
Dr. Hassan.
So I just want to say one word. The NRG study, as you presented, put the brakes on. There was a lot of rush into doing SBRT. He asked my name, by the way. I wasn't volunteering. So I think appropriately so put the brakes on the rush to do so much of these oligo story. As Dr. Nuhad mentioned, this is a systemic disease. When you have metastatic disease, you have systemic disease, and that's why we only apply this in ER positive, because it's a more indolent course than an ER triple negative, for example, where it probably wouldn't make much sense there. Most of the studies have used ER positive. And in my mind, the test of time, as also Dr. mentioned, is critical. So don't do it from the get-go. Give the patient a test of time, because then you will see if this persistent, like he said, a single liver met area or single brain met area. Those are isolated cases where we want to be more aggressive. But to give a picture that we can do oligomets up to 12 or 15, this is ridiculous, I think.
I like your comment, Dr. Hassan. This was the point of the question, and I think that the panel and the panelists tried to respond to it in a way, each one on a personal way, but this is a take-home message for everybody. Any other questions? Yes, Doctora.
Yeah, just
Aida.
a quick comment, actually. I shared the same question as you, and I just want to reiterate the fact that the duration of response is what actually we have to count on when it comes to going further into more aggressive or radical approaches, but then also the location, and that's what you basically mentioned in your beautifully in your presentation. The other thing is that the evolving role of circulating DNA, I think there is a big potential in this regard, and this is what we need to push to identify those patients who would actually benefit from more radical approach in these cases. Thank you.
Very good comment on the circulating tumor DNA after the discussion that we had half an hour ago. Doctora.
Yes, hi.
Just we don't hear you very well.
Hi. I think it's fine now. So, Professor Ibrahim, you were mentioning about systemic therapy for recurrent tumors. I just wanted to ask you, if it's a lady who has maybe a triple negative tumor and she has only local recurrence, a PET-CT is negative initially, would you still expose her to systemic therapy before you consider resection of that tumor? Because then if you resect it, if the patient does not have mets to the body and you can resect the tumor, would that be a patient that you would give adjuvant chemotherapy?
Let's begin with the surgeon. Ma'alish, let's begin with the surgeon, then Dr. Ibrahim, you reply.
But I didn't get the question.
I'm asking if it's a patient who has a local recurrence, like the lady we discussed, the one with the nodule in the breast.
Chest wall recurrence,
yes.
Local recurrence.
Yeah, but there is no evidence of mets. So when we give them a trial of systemic therapy, the way we are saying we should, before trying to, because we want to see the response to the recurrence. But then we would not expose such a patient to adjuvant chemotherapy, I'm assuming.
Yeah, it's an interesting question. Actually, once you have the recurrence, you first start with the staging. As you mentioned, there was no evidence of recurrent disease. It's a little bit depending, like if it's recurrence in patients that were treated with breast-conserving therapy, it may be another case than patients that develop recurrence after mastectomy, because that's possibly a whole other case. That in the last case, it could well be an early sign of possible metastatic disease to develop in the short term, whereas local recurrence could either be a result of inadequate surgery in the first place, and that's a whole different clinical picture. In those cases, I would advocate to go for upfront surgery.
Dr. Ibrahim.
Yeah, I agree with him, because I have difficulty calling this oligometastasis. Probably it's a failure of local treatment, which should be addressed in a very different way and not necessarily exclude surgery at all. But you need to always to test for chemosensitivity, systemic sensitivity. Let me put it this way. In this case, it's a triple negative. You need to give chemotherapy. If she's ER positive, you can also, the patient may benefit from anti-hormone therapy, and then you address the local treatment. We see a lot of cases like this, and many of them secondary to poorly executed local treatment.
Dr. Ibrahim, in regard of local treatment for this patient, Any comments?
Yes. So if we're investing in local therapy, yes, I would add consolidate.
Thank you. Any other questions? Yes, Dr. Falah.
Yeah, I mean, for oligometastasis, for brain in particular, we know that most of systemic treatment do not cross brain barriers. If you have a patient with 1 or 2 small lesions that are asymptomatic, I think you can watch them and follow up if they have any progression there. And we see that quite a lot in the clinical setting, that they come after 3 months with lesions are bigger or more lesions in the brain. Or if they are symptomatic, definitely they need to have SBRT or SCDR.
Thank you very much. I think that for the sake of time, we need to stop. Thank you very much. Thank you.
So there will be an election now for EOS board members. Those with active membership, please, you can go to the Al-Anud room. So please join us there. And for others, we'll be taking 10 minutes break, and then we'll come back here to continue the gynae session.
Bismillahirrahmanirrahim. It's my pleasure to start the gynecological cancer session. The first presentation will be presented by the Professor Abdelmajid Dayat. Professor Abdelmajid is Assistant Professor at the University of Manitoba, and he is Radiation Oncologist at Cancer Care Manitoba, Winnipeg, Canada. The overarching goal of his academic career and creative professional activities revolve around the advancing the quality of care by introducing new technologies with evidence-based practices and improving the quality of life for cancer patients and survivors. He has a special interest in brachytherapy and the extracranial stereotactic radiotherapy. Please, Dr. Abdelmajid.
Good afternoon. Thank you for the kind invitation to participate in the EOS meeting and today to present this very important subject. And now we are wondering why we are talking about cervix cancer in 2024. But let me see how this thing works. Okay. Yeah, despite the improvement in immunization and the screening and advanced care, unfortunately, this is still a huge problem worldwide. And despite the WHO initiative to eliminate cervix cancer, you, in theory, could eliminate it with the introduction of vaccines and the screening. However, this is still a huge problem with the recent GloboCan 2020 estimates of about 600,000 new cases for 2020 with expected 340,000 deaths. So it still impacts patients in terms of morbidity and mortality. Now, before going into the treatment paradigms, we'll go through some anatomical and staging consideration. You know that the cervix is a 3 by 3 centimeter fibromuscular organ divided into 2 parts, the supravaginal part, which is the endocervix, and the vaginal part, which is the ectocervix. The parametrium is of, the boundaries of the parametrium are very important in terms of the radiation therapy planning, and it's always treated when we do radiation therapy for cervix cancer. It's bounded anteriorly by the posterior bladder wall, posteriorly by the mesorectum, laterally extends to the pelvic side walls, superiorly into the fallopian tube broad ligament, and inferiorly into the urogenital diaphragm. The lymphatic drainage are primarily to the obturator, parametrial, external, internal iliac, and common iliac, and also into the para-aortic, which is now considered still a regional lymphatic drainage rather than distant. And for the distant lymphatic drainages are the mediastinal and left supraclavicular area. These diagrams are very important to document at the time of diagnosis for cervix cancer, because this will have implications in radiation therapy planning. I need to accurately outline the tumor extent into the cervix, the parametrium, and also into the uterus. Some notes about the staging system for the cervix cancer. It underwent dramatic changes over the years. The recent 2019 FIGO staging introduced the 1B3 subclassification of cervix cancer that was not present before. The lateral extent of the tumor for stage 1A is no longer considered. It's all about the depth. And for the 1B, it's the tumors less than 2 to 4, and more than 4 centimeters. The same thing with the stage 2A, which is the tumor extension into the vagina. It's subdivided into 2A and 2B, 2A1 and 2A2, depending on the tumor size, less than 4 or more than 4. And also the recent introduction of the 3C1 and the 3C2, where the 3C1 is the pelvic lymph nodes, and the 3C2 is the para-aortic lymph node metastases. This is, again, the FIGO staging, the old one of 2009, and these are the recent changes that were introduced in 2018, with the most important ones is the new 1B3, because this will have implications in the treatment recommendations, tumors more than 4 centimeters, and also 2A2, tumors more than 4 centimeters with the extension into the vagina. And you can see here in the old FIGO staging, the para-aortic lymph nodes were considered the stage 4, but now in the new staging system, it's stage 3C2. This has been validated in many retrospective trials, and we can see here for this cohort of patients of 1B and the 3 patients, we can see differences in survival between the 1B tumors depending on the tumor size. The same thing also among stage 3, and you can see here even for the stage 3C1 they have better survival than stage 3A, 3B. This is primarily because this has implications in the treatment that is offered for these patients, because we can find some difficulty when offering radiation therapy for stages 3A and 3B. Okay, we'll skip this now. We'll give you this example of a 5 by 5 centimeter cervix with the parametrial invasion, and the vagina is uninvolved. And you can see here how the migration of the stages through the years. This was considered a stage 4B 10 years ago, but in the new staging system, it's stage 3C2. Now, what are the implications of the staging system on the management? If we want to draw a line with what are the stages that are surgical and what are the ones who are non-surgical. The early stage, stage 1A, is typically managed by radical surgery, and for tumors more than 4 centimeters, and the stage 2 to 4 are managed with a non-operative technique, including radiation therapy. Moving to radiation therapy as a definitive treatment for cervix cancer, this is the typical schedule for cervix cancer management. It typically consists of 5 weeks of radiation therapy, 25 treatments given daily, Monday to Friday, with the brachytherapy in the afterwards, week 6 and 7. Chemotherapy is typically the cisplatin given weekly with radiation therapy, and it's very important to keep the overall treatment time within 7 weeks, because more than 7 weeks we lose control by about 0.5% per day. And now with the recent introduction also of the pembrolizumab, according to the recently published keynote trial that was published last month, that showed improvement in the progression-free survival and overall survival with the addition of pembrolizumab as a concurrent and adjuvant treatment for patients receiving chemoradiation therapy. So probably we might see this as a new standard of care for these patients. Now, where did chemotherapy from? This has been established since late 90s. The addition of chemotherapy improved the outcome of patients with cervix cancer. It has 6% improvement in overall survival. 8% improvement in progression-free survival with a 9% improvement also in the local regional control. So chemotherapy is the standard of care in patients receiving radiation therapy as a concurrent treatment. What about the role of adjuvant chemotherapy? Unfortunately, the Outback trial that tested that came out as a negative trial. These patients were randomized to chemoradiation therapy followed by brachytherapy versus the same treatment, but with the addition of 4 cycles of carbotaxol with a median follow-up of 6 months. These patients, they're still the main distant metastasis is the main issue, so we tested if chemotherapy would improve the outcome, but that was a negative trial and the chemotherapy did not improve the study endpoints, which are the overall survival and the progression-free survival. And with that, chemotherapy should not be offered in this setting outside of a clinical trial. Are there other treatment approaches for cervix cancer, not including radiation therapy? This has also been tested for these stages that we typically treat with radiation therapy, stages 1B, 2, and 2B, neoadjuvant chemotherapy, followed by hysterectomy and lymph node dissection, versus chemo-RT and brachytherapy. And this trial was published in 2019. And here there has been no difference in both the treatment approaches. However, the toxicities were more with the surgical arm, and because many of these patients also will end up having radiation therapy and or chemotherapy based on the pathology. So the chemoradiation therapy and brachytherapy remains the standard of care because it's less toxic treatment. Now, moving into some radiation therapy consideration. When we treat the tumors with radiation therapy, we treat the visible tumor that we see on imaging, which is the primary tumor, as you can see here, and also any visible lymph nodes. But what about the microscopic disease? Something we call it the CTV, which is an added margin to these tumors that you need also to treat to eradicate any cancer cells in there to achieve the cure, and also to prophylactically treat the lymph nodes, which can also be involved with some microscopic disease. And this is basically when we do radiation therapy, these are our volumes. The GTV is the gross tumor volume. The CTV is that margin around that volume that needs to be treated. ITV is the internal target volumes because structures in the body are not static, so you need to treat a larger area to make sure that you cover all that. And the PTV is a planning target volume because the patient setup and all that varies from day to day. So you need to treat all that volume to make sure that you eradicate all the microscopic disease. But that certainly will come at the expense of the normal tissue toxicities. And if there are any organs at risk nearby that could be affected by radiation therapy. So we need to find that balance that we can achieve the maximum tumor control while keeping the normal toxicities to the minimum. For the treatment of cervix cancer, it has 2 components. The first one is the external beam radiation therapy. Typical dose is about 45 grays. And but that is not enough to cure these patients. An additional dose that is delivered typically with the brachytherapy to reach a total dose of about 85 grays to these tumors to cure them. And that would be a combination with the external beam radiation therapy and the brachytherapy. Certainly you cannot deliver that entire dose with external beam therapy alone because that would be extremely toxic treatment. So we need the brachytherapy for these tumors. Talking about the techniques of external beam radiation therapy, historically the one that you can see on my left side of the screen, which is the 3D, or we call it the box technique, in which these are static fields. You treat everything in there that you ensure the coverage of the tumor as well as the lymphatics. But now we are moving more towards more individualized treatment. As you can see here, this color wash represents the delivered dose. And you can see the difference on that with the IMRT and VMAT in terms of the sparing the organs at risk. Here, the bladder and the bowel. And this has been established a long time ago, the advantage of the image-guided IMRT, which is more sophisticated treatment in terms of improving the toxicity profile for these patients. And I will not go through the literature review. This is already a standard of care now. But when we consider this very highly precise conformal radiation therapy, we have two problems. First, setting up the patient every day is not the same, so there might be a chance that you might miss the tumor. And the second thing is that the structures within the body are not even static. So different studies looked into that, and typically a 5 to 7 millimeter margin is always needed to make sure that you compensate for the setup variation. However, the risk of geometric mess and doses to the ARs depends also on how these structures move inside the body. Let's say for the uterus here, it is affected by the bladder and the rectum filling, and these the uterus can move up to even 4 centimeters in these one, as you can see in here. And if you do very highly conformal radiation therapy, you might risk not covering the tumor in all the time. Also, this is an example of different rectal fillings, the one that you planned, and this is the one that you see on imaging when they come for the treatment. And you can see here that you will end up treating more rectum if the rectum is full. Also, there are changes in the also on the body external contour. If the patient loses weight, that will also affect the accuracy of radiation therapy and the distribution. What we can do for these ones, for the rectum, we have specific protocols like empty bowels before each treatment, and also for the bladder to have it a controlled filling. For example, we ask the patient to void, drink 500 millimeters of water, and then treat after 45 minutes. I'll just skip many of these for the sake of time. Now moving to adaptive radiation therapy, which is a state-of-the-art treatment in which you adapt every day. You change the treatment plan mostly every day to adapt for the changes in tumor contours and the body. And this is different from the image-guided radiation therapy, because image-guided radiation therapy is a process in which you reposition the patient. You don't change the treatment plan itself, while the adaptive radiation is that you modify the initial plan every day. It's a longer process, it's resource consuming, but it's certainly the therapeutic ratio here is high, because every day you treat what you can see on that day. The key features of adaptive radiation therapy is that it uses frequent imaging and replanning, CT or MRIs, personalized treatments, and also the use of advanced technology like MRI and also AI, which has now been used more often for these ones, machine learning. The benefits of adaptive radiation is that it's increasing precision in ensuring accurate radiation treating despite anatomical changes, reducing toxicities, and improving the outcome in which we can offer better tumor control. There are different kinds of these ones. Again, for the sake of time, we'll just move. For this process, it has some limitations. Certainly in some centers, it's been introduced, but this is a resource consuming workflow complexity, because this will require a radiation oncologist to be on the treatment unit every day, which we don't typically in our workflow. But for these ones, you need radiation oncologist to be there to see the tumor and check the contours and the plan. There are image quality issues. It's the time constraints, limited applicability, because not all the centers, they have the resources, and also it needs the training and expertise requirement. Now moving to the brachytherapy, which is an integral part of the radiation therapy. Before that, let's just go back in time, and towards the end of the 19th century, it was the first automobile race and the first electric generator in Niagara Falls. But you are wondering, how is this related? It's not, but it's just in that same year, It was the discovery of the X-rays by William Röntgen through his experiments on electric charge in a vacuum, and they found this fluorescence. And this is his wife's hand, his very famous picture. When she saw it, she saw a skeleton, and she said, "I saw my death." But we can say that that year is the birth year of our modern radiology. A year later, the Olympics started in Greece, and Zanzibar was defeated in 38 minutes. But again, this is not related, but in that same year, it was the discovery of radioactivity, which has certainly implications in radiation oncologies. And 2 years later, it was the discovery of radium. And radium becomes used worldwide for, in medicine, and it was described as the mysterious element of nature. This is our typical radioactive source that we use in brachytherapy for gynecological cancers. It's called the iridium. It's only 5 millimeters, but this is the source that we use to treat these patients. This is the inside the brachytherapy unit. The machine that you see here is an afterloader. This is something controlled remotely, and the radioactive source will go through these transfer tubes into the patient and goes back, and it has a certain time and certain positions inside the patient to ensure that we deliver the dose that we want to the tumor. There are certain intrinsic differences between a brachytherapy and external beam radiation therapy. Here, these lines represent the dose of radiation therapy. As you can see, with the brachytherapy, you can have more concise radiation and less radiation to nearby tissues compared to external beam radiation therapy. And this is the concept. Radiation therapy in brachytherapy is from inside out, while in external beam radiation therapy is from outside in. So the surrounding tissue will receive more doses of radiation with the external beam radiation therapy. And this has implications. It's used in different parts of the body, especially in cervix cancers. Now, for the use of brachytherapy in cervix cancer treatment, as I showed you this earlier, you need at least 85 grays to the tumor to cure it. You deliver half of the dose with external beam radiation therapy, and the rest is with the brachytherapy. And using this treatment schedule, typically brachytherapy comes towards the end of the treatment after completing the chemoradiation therapy. This SEER database showed that there has been a decline in use of brachytherapy over the years from the US. And you can see here how the decline in brachytherapy led also to decline in survival in cervix cancer patients. Time is up, okay. Let's move. This very important note about brachytherapy. Historically, it's been used the 2D planning, in which we use just X-ray to do the treatment planning for cervical cancer patients. But now this has been largely replaced with 3D planning, in which you use more advanced imaging like MRI or CT-based planning. This is, you can accurately estimate the dose and see the doses to organs at risk. The difference is that with the 2D planning, it's like one suit fits all, while in the 3D planning, you individualize the treatments. The use of MRI is of paramount importance, with the less use of CT in these patients if you don't have the MRI. Okay. What we do in brachytherapy is that we define the tumors at the time of the brachytherapy. After the treatment is completed, we insert the applicator in a patient. The patient will go to the MRI, have a scan, and then we define the target to be treated, in which is the tumor and any potential microscopic disease in the cervix and the parametrium, using the different applicators used in cervix brachytherapy. Again, these are just notes about our volumes that we define on the MRI, and this certainly depends on the initial extent of the disease and whether there has been a good response or not. If not, then you need to treat a larger volume. We use different constraints for the coverage and also for the organs at risk, and we follow these to keep the side effects to the minimum while achieving the excellent local control that we're looking for. Why 3D brachytherapy? Because this has accurate verification of the applicator position, it has accurate estimation of normal tissues doses, and the ability to conform the dose to the target, so it's just, it's individualized treatment, and the ability to reduce the doses to the organs at risk. Move more. Now, the value of adaptive image-guided brachytherapy, we told, now we are using adaptive radiation therapy for external beam radiation therapy, but this has also been used in brachytherapy with the introduction of interstitial catheters. As you can see here, between the difference in two ones, the dotted line represents the target, which is not covered if we use just the intracavitary approach, while the one on the right uses the needles in which you insert these needles into the parametrium and load these with the radioactivity to improve the dose coverage. So it certainly led to better outcome because you are able to cover the target with the prescribed dose. Did technology improve the treatment outcome? It did, and there has been many publications in that regard. They are mostly retrospective single institutions, like this one from the Netherlands that showed that with the introduction of image-guided brachytherapy, the 3D, compared to their historic control, led to improvement in overall survival, about 30% improving in survival, and also in the recurrence. And the rate of toxicities is less with the more advanced techniques. This is also another paper that shows that the newer technology in terms of IMRT or image-guided brachytherapy led also to improvement in all the study outcomes, endpoints, the control, the overall survival, and the freedom from relapse. Now, moving to this very important landmark trial, which is the Embrace trial of about more than 300 patients, stage 1B to 4A, and this is a landmark trial that utilized advanced imaging like MRI for brachytherapy. And this has led to improvement in the 5-year local control, reaching about 92%, which was not possible, let's say 20 years ago, using the conventional methods of radiation therapy and 2D planning. Just skip that. Now, brachytherapy is resource consuming, especially if we're considering image-guided brachytherapy. Are there any alternatives? And this has been a matter of debate in many symposia and meetings, is that because can we do SBRT? You hear SBRT every day, it's used in every site. Can we do SBRT instead of brachytherapy? And it's less invasive for sure. As you can see here, there has been a decline in brachytherapy, but first of all, why brachytherapy has been declining over the years? It's time and resource consuming, for sure. The fear of complications, because it is an invasive procedure, and you have patient under anesthesia, you do dilatation, you insert an applicator, risk of perforation, bleeding. It's a lot to take with the brachytherapy, while in SBRT it's non-invasive and it's something that we do every day in the clinic. And also we become more aware of the limitations of the conventional brachytherapy technique that we were using before, and if we want to do it right, probably you just do it with the 3D and advanced imaging. Also, it requires manual skill because the local control depends directly on the value of your implant, and also there has been limited exposure. So with that, just want to show you this slide about I thought I had 30 minutes. So the use of brachytherapy versus other modalities. You can see here there has been a significant reduction in survival if you use other techniques compared to brachytherapy. And so brachytherapy would still be the standard of care for these patients. Now we'll skip all these ones, but here you can show the differences in local control between the historically versus the new data from the Emirates that uses MR-guided brachytherapy. Again, we'll skip all that. Just a small note about the use of AI for these patients, and there has been a growing role for AI in the use of brachytherapy to save the time and also improve the efficiency in the clinic. And with my going to the conclusion for the sake of time, I only have 2 words. Brachytherapy works, and technology is great, but it's double sword. Thank you.
Thank you, Dr. Abdelmajid, for the excellent presentation. It's my pleasure to be with you today. First of all, because I don't know how the committee chose me for a gynae session, because I'm not doing gynae for the last 15 years. But we have our expert here, Dr. Imad, who will talk about immunotherapy in early cervix. We are moving from advanced and metastatic disease to early stage of use of immunotherapy, which is to make things more complicated and more expensive.
Assalamu alaikum, good afternoon. Thanks, Dr. Benini, for this lovely introduction. And I thank all of you for being here today, attending our gynae session. And I'm very excited and happy to talk about cervical cancer, because in early stage cervical carcinoma, for the last 40 years, nothing. So as a medical oncologist, we are more than happy that there is finally, we have some data. So this is my disclosures, and the current landscape of cervical carcinoma, no doubt that since 1980s, that stage 1B, 3 up to stage 4A, as per the guidelines, the standard treatment is concurrent chemoradiotherapy, so with the weekly cisplatin. And we spent a long time to improve the outcome, and we have a meta-analysis from almost 18 clinical trials. What we get from this concurrent chemoradiotherapy is the 5 years absolute benefit 6%. But if you're looking for the who drive the most of this benefit, it looks like when it comes to overall survival or disease-free survival, those early stages, stage 1, stage 2, with almost 10% absolute benefit. But looking for the stage 3 and stage 4A, the outcome less than 3%. And unfortunately, this is the most common presentation in our region. Majority of our patients, they came with very advanced disease. So there are a lot of attempts to improve the outcome for those patients, and probably surgery post-chemoradiotherapy, it's an attractive idea, especially there are many retrospective data, many. We have at least 8 retrospective trials showing adjuvant hysterectomy after chemoradiation, it improved the outcome. But when we go for prospective clinical trials, we have 2 clinical trials up that show no improvement in outcome. So again, no improvement even with the hysterectomy. What about the adjuvant chemotherapy? And this is Outback trial, which is randomized patient for concurrent chemoradiotherapy versus concurrent chemoradiotherapy plus adjuvant chemotherapy, carboplatin paclitaxel for 6 cycles. And you can see the outcome. The 2 curves are overlapping. There is no overall survival benefit. So again, failed the trial. So what about immunotherapy? Immunotherapy now is approved almost in all tumors. And the most important, why immunotherapy in cervical carcinoma? Number one, more than 90% of cervical cancer because of human papillomavirus infection, where the integration of this virus itself inside the epithelium and the release of the foreign viral antigens, this will attract the immune response. Add to that, majority of patients with cervical carcinoma, they are PD-L1 positive, and PD-L1 is the current biomarker for the response and benefit from immunotherapy. But the most important that cervical carcinoma is one of the tumor with high tumor mutational burden in the landscape of tumor mutational burden. And you can see that when you have high tumor mutational burden, this will attract the immune response and as a biomarker for immune response as well. The initial data comes in metastatic setting, and this is the keynote 826 for the patient with metastatic cervical carcinoma. Adding pembrolizumab to the chemotherapy, it did improve the overall survival, mainly for patients with PD-L1 positive tumors. And this is a couple of markers for intent to treat population, PD-L1 positive, and most important, high PD-L1 expression above 10. So what about the early stage of cervical carcinoma? Unfortunately, the earliest data was negative, and this is the CALA trial. CALA trial for the durvalumab in locally advanced or early stage cervical carcinoma. One group of patients, chemoradiation with cisplatin. The second group, chemoradiotherapy plus durvalumab, followed by maintenance durvalumab up to 2 years. The primary endpoint of this trial was progression-free survival. Look to the Kaplan-Meier curves. Again, no improvement in progression-free survival. It was a negative trial. Luckily, last year in the ESMO, 2023, we have the keynote A18 trial, and this is for pembrolizumab plus chemoradiotherapy, followed by 2 years of maintenance pembrolizumab versus standard of care chemoradiotherapy in stage 1B positive lymph nodes up to stage 4A, according to the FIGO classification 2014. If you're looking for this trial, majority of the patients, more than 50%, are stage 3 and stage 4A, which is, this is what we are seeing in our clinical practice. Most of our patients presented with advanced stage, and 85% lymph node positive. This is a baseline patient characteristics. It was well balanced between the two treatment groups. I just to highlight the PD-L1 expression, 95%. And this is what I mentioned. Majority of the patients with cervical carcinoma, they express the PD-L1 receptors, which is a biomarker for response to the immune therapy. And 85% of the patients with lymph node involvement, including the para-aortic lymph node. For radiotherapy, for those interested in radiation therapy, so it also well balanced between the two treatment groups. So the total dose was 76 gray for both groups, and the equivalent dose was up to 86%, including the brachytherapy in both groups as well. The primary tumor received 45 gray, and the lymph nodes 56 gray. So it was well balanced between the two treatment groups. 90% received radiotherapy by IMRT, only 10% non-IMRT. And this is a primary endpoint. We have significant improvement in the median progression-free survival. At 2 years, we have absolute benefit of 10%. 10% improvement in progression-free survival, with almost 30% reduction in the risk of progression or death by adding pembrolizumab to the chemoradiotherapy, followed by maintenance pembrolizumab. So the trial was positive. And this is the subgroup analysis. You can see that the benefit was mainly driven by advanced stage, stage 3C, or stage 3 and stage 4A. What about the overall survival? And luckily this year, in the ESMO 2024, we have the updated overall survival, and again, we have 8% gain in the median overall survival in favor of adding pembrolizumab to the chemotherapy, with 33% risk reduction of death. So this is very significant data at only 33 months of follow-up. Response rate was not different between the two treatment groups, probably numerically in favor of pembrolizumab, 3.4% gain, but look for the median duration of response, which is also significant in favor of durvalumab, pembrolizumab. As a concern of toxicity, and when you give radiotherapy to the pelvis, probably colitis from radiation therapy increasing the risk of diarrhea. Immunotherapy also can increase the risk of diarrhea. That's why you can see I'm looking for the diarrhea as a concern. There is no significant difference in diarrhea incidence in both treatment groups. And no matter the toxicity was not higher in the combination arm or even in the maintenance phase. The most common immune-related toxicity was hypothyroidism. Colitis as a concern was probably equal in both treatment groups. And the most important, this did not impact the quality of life for the patients because adding more treatment, we might expect there is some symptoms and affected the quality of life, but actually it was maintained in this trial. And this leads to the FDA-approved pembrolizumab in the early stage for stage 3 and stage 4. And this also has been updated in NCC guidelines. But also we have data last year. This is an interlaced trial. In this trial, they included patients with cervical carcinoma from stage 1B up to stage 4A. And they gave concurrent chemoradiotherapy in both groups. But one group, they give neoadjuvant carboplatin paclitaxel for 6 weeks, followed by chemoradiotherapy, which is feasible and not expensive. But this trial has been conducted in 5 countries only, 4 European trials and Mexico. So that's why you can see the majority of the patients here are stage 2, 75% stage 2. And this might reflect the well-established screening program in these countries and the early detection of cervical carcinoma. Stage 3 and 4 in this trial only 14%, which is not what we are seeing in our clinical practice. Lymph node involvement in this trial only 43%, which again, this is not the kind of patients in our region, probably in Europe. So the exclusion criteria from the trial, they excluded patients with the vaginal involvement, lower third, or para-aortic lymph node above the bifurcation of the aorta. Look for the progression-free survival. At 5 years of follow-up, the trial also positive. And we have 8% gain in median progression-free survival at 5 years in favor of neoadjuvant chemotherapy, carboplatin paclitaxel for 6 weeks. And this is also overall survival, and again, we have 8% gain in overall survival at 5 years of follow-up in favor of 6 weeks of induction carboplatin paclitaxel. As a chemotherapy, we are concerned about the hematological toxicity. So there is a little bit increase in the risk of hematological toxicity in male neutropenia in this group of patients. But in general, there is no that alarming toxicity by giving a neoadjuvant 6 weeks of carboplatin paclitaxel. So the question, I think, every oncologist in MDT, what to do? We have 2 positive trials to go for the neoadjuvant 6-week carboplatin paclitaxel, followed by concurrent chemoradiation, or add pembrolizumab. This is my opinion, my interpretation, how to deal with this situation. So if I have a patient with early stage, stage 1B lymph node positive, and stage 2, I prefer to go for interlaced trial, since 75% of the patients are already stage 2. Stage 3 and 4 was only minority, 14%. Lymph node involvement very low, 43%. If I have a patient with stage 3 or stage 4A, more advanced disease, and those group of patients well represented in the keynote A18, so I'll be in favor to give pembrolizumab chemoradiotherapy for this group of patients, because 85% of the patients, they have lymph node involvement, and 56% of this patient population are stage 3 and stage 4. So in conclusion, immunotherapy is now moved to the early stage cervical carcinoma. Concurrent chemoradiotherapy with pembrolizumab followed by adjuvant pembrolizumab up to 2 years according to the FIGUS classification 2014 for stage 3 and stage 4A, improved both progression-free survival and overall survival. And also induction chemotherapy with weekly carboplatin paclitaxel for 6 weeks, followed by concurrent chemoradiotherapy for localized cervical carcinoma, male stage 2, according to the FIGU classification 2008, improved both progression-free survival and overall survival. And the open question is, can we integrate both options, since it's very attractive. Why not to give induction chemotherapy followed by concurrent chemoradiotherapy, immunotherapy, followed by immunotherapy? This is an area-free zone, and we'll leave this for the discussion. Thank you.
Thank you, Ahmad, for the excellent presentation. Now, for sake of time, we'll go to the third presentation about ovarian cancer, which will be presented by Dr. Hind Malik, consultant oncologist in Qatar, and we'll leave the questions to the end of the session. Dr. Hind will be talking about an update on management of ovarian cancer.
Assalamu alaikum. Good afternoon. I would like to thank the EOS Scientific Committee for the invitation. I would like to thank you all for being here at this time before the lunch. And I think we have very interesting data to talk about today for ovarian cancer updates. The green? Yeah. It's my disclosure. Okay, thank you. Ovarian cancer is not one disease. This is like a meta-analysis always telling that. It's different disease in everything, including the outcome. And if we'd like just to look at it's a disease of relapse, definitely. From this icon 8, care for survival, showing that the patient at 6 months, 20% will relapse after the standard care of treatment. At 18 months, 50% will relapse. At 36 months, or that means 3 years, 80% of patients will relapse. And this is what we are seeing in the clinic as clinicians. Example, of course, of advanced ovarian cancer after standard of care, which is surgery followed by taxol carboplatin plus minus Avastin. Every time we'll be having smaller PFS, gradually, steadily, till the end by having death, most probably after bowel obstruction. So we do have really unmet need in the first line treatment, definitely for ovarian cancer, because our ultimate goal is to go for a cure if we can. To date, relapsed ovarian cancer remains incurable. There is significant need for better frontline treatment to improve this outcome for women with ovarian cancer, and I will leave you these figures to look at. The guidelines today, the ESMO, the ESGO, NCCN, ASCO, all talking about the same. Surgery, number 1, in all ovarian cancer, could be like primary, complete primary surgery without any residual, zero residual, to have the BRCA and HRD at first time diagnosis, initially after surgery or biopsy, and to go for maintenance therapy after chemotherapy, platinum-based. So just a small hint quickly about the surgery. Surgery, as I said, it's about complete cytotoxic surgery, could be primary, if applicable, or after interval, after 3 cycles of neoadjuvant chemotherapy and interval debulking surgery, plus minus bevacizumab. This is really discussion in the clinic all the time. We can talk about that later if you like. But just one comment here. Cochrane meta-analysis all the time telling us residual disease is not only about 1 centimeter, it's about 0 centimeter. And you can look at the difference in survival for those type of patients. And not to be done by gynecological surgery, not to do by general surgery, to be done only by specialized gynecological surgeons. Not only that, who has really high volume will make the difference in survival for those type of patients. So we cannot emphasize this point really, and we need the gynecological surgeons specialized in this field nowadays, not to give this really important patient for the general gynecologists, surgeons. The latest data of ESGO telling us about, you can just check here, the outcome, survival, it really links with the upfront surgery with no residual disease, and also the maintenance therapy giving us a better survival for those type of patients. So in the guidelines, we do have 2 things, good surgery, no residual, and maintenance therapy to have good, better outcome for those relapsed patients, especially in advanced ovarian cancer stage 3 and 4. This is the essence or the idea now of why we need the maintenance therapy, because we'd like to address the minimal residual disease after finishing surgery and taxol carboplatin. Like the hematology before, we used to do that, and now this is really exactly the case. If we left it without treatment, it will growth and having more clonal resistance or more popping up of new cells. So the recommendation today, for example, in the ESMO, telling that maintenance treatment with PARP inhibitor with or without bevacizumab is recommended for patients with tumor BRCA or HRD positive tumors with no evidence of disease at the end of the chemotherapy or complete or partial response to platinum, taxane, and platinum. For BRCA 1 and 2 positive, HRD positive as well, if BRCA is wild, niraparib for 3 years is there, olaparib Avastin for 2 years is there. For BRCA mutant, a wild type, HRD negative, bevacizumab for 2 years is there, or niraparib for 3 years. Also, rucaparib is there, but we don't use it because we don't have it here in the region. So this is today, up to now, the guidelines all over, including the ESMO. Why we do that? Why we do have these guidelines? We do have really very, very informative, precise, impressive data for these guidelines. We'll start with the monotherapy as maintenance for stage 3 and 4 patients with the famous or the popular SOLO-1 trial, which is all we know it. It was about newly diagnosed the cohorts of patients stage 3 and 4, BRCA germ or somatic positive patients, and this after good cytoreductive surgery, interval or upfront, after complete platinum sensitivity with complete response or partial, they were randomized to either to give olaparib 300 milligram BID, again it's only placebo, for 2 years treatment if no evidence of disease. And the primary endpoint was PFS, and overall survival was also a secondary endpoint. And just to mention that the patient characteristics of Paula 1, they were mainly stage 3, mainly no upfront surgery, most of them, no residual disease. So this really we have to, today, with the new, updates, would love to know the cohort of each, trials to know exactly what is meant by PFS and overall survival for those type of cohorts of patients. And came the unprecedented really, result. As we mentioned before, the relapse at 3 years, more than 60% of patients were free of disease in comparison to only 26.9, and with hazard ratio of 0.3. Very impressive for BRCA positive patients. And the follow-up after 5 years is still having maintained this positive effect for those type of patients. And after 6 years, the time to the first systemic therapy was really delayed for those type of patients with very impressive curve and widespread of the curves. And the overall survival also was having a very clear trend to having overall survival for BRCA patients, even with after crossover of the patients of, the placebo arm to the PARP inhibitor. Prima is talking about niraparib, another simple, single agent PARP inhibitors, and this was the same idea, the same patients, stage 4, 3, advanced ovarian, after finishing surgery, chemotherapy, platinum-based, partial or complete response, they were randomized to niraparib or placebo for 3 years here, only once daily, the dose, but with putting in mind that we can just decrease the dose from 300 to 200 milligram for patients with less than 177 kilogram body weight or platelets less than 150. And the PFS also again was the primary endpoint, and the overall survival was another secondary endpoint. Just to mention again, in Prima trial, these were the cohort of patients, highly advanced, high burden of disease. 30% of patients have stage 4. More than 2/3 received neoadjuvant chemotherapy. That is very, really highly burden of disease in this cohort of patients. 31 achieved partial only to first platinum. So we do have different cohorts from the Paula 1 trial here, and really different, patients, residual even disease was more than 99% after surgery in stage 3. And the PFS was met, then the endpoint in the Prima, with 38% reduction in the hazards of relapse of death for the whole intention to treat population. And not only that, it was only the HRD patient also was having the same 57% reduction in the hazards of relapse or death with niraparib. And even by sub-analysis, HRD positive patient with BRCA mutant was having positive hazard ratio of 0.4. HRD positive with wild BRCA was having the same, more or less 0.05. Not only that, the HR proficient patient were showing also some response with a hazard ratio of 0.68. And recently, two weeks back in the ESMO, the overall survival of this trial unfortunately came negative. No benefit overall survival for those type of patients. And we'll discuss with this a big debate. We can talk about that also later. And again, the overall survival was negative in all the intention to treat population, in HRD patients, in HR proficient patients as well. Different factors, we can talk about that in details, why it was negative, in spite having the same more or less, like the solo, or the OLAP Paula one. Maybe I can just say some notes about why PRIMA was negative, in spite we are expecting it to be positive, to be honest. As I mentioned, different clinical trials, population sensitivity to platinum, no direct, of course, comparison. The combination of bevacizumab in the Paula maybe give a different really outcome because we start with the bevacizumab early enough before the randomization. So could be this is a difference also, giving this cohort, control arm 3 chemotherapy and bevacizumab in comparison to only what's called PARP inhibitors. Safety could be also because they have a lot of interruption and disease in the niraparib, maybe because they couldn't tolerate, maybe because I don't know, even the 3 years could have like some popping of resistant clonality or clonality. The clonal of the disease could be resistant now. Progression during PARP itself was there. 90% of those patients were progressing during the PARP inhibitor, the niraparib. Maybe because, as I mentioned before, they were really highly disease, like burden of disease. They were really advanced, poor prognosis disease. With high risk recurrence and high risk failure. And to be honest, also these patients, if you compare them to Paula, the progression during the Paula is only 30% or 20%, even in the HRD positive patients. Other just important also factor to mention, the subsequent trial, the subsequent chemotherapy or treatment was really having a role here, meaning that those patients who was having really post-progression surgery, in the 2 arms, the control and the niraparib were there. 15% of patients, they received this in PRIMA, while less than this in the Paula. So this also could be one of the reasons why it is negative, because these patients really were having a lot of subsequent therapies, including surgery, including bevacizumab, which was 5% of patients receiving bevacizumab in the PRIMA, and only 14 in the Paula. What about the role of upfront surgery and residual disease also could be there? As I mentioned, could be there's only resistance after having a huge burden of disease after the surgery for those cohort of patients in PRIMA. This could be one of some of the factors that led to this negativity in the overall survival of PRIMA. What about Athena? Athena is rucaparib, which is not available in our region, but it still was having the same randomized trial, blinded trial, balanced cohorts to give only PARP inhibitors. Rucaparib, again, is placebo after finishing the chemotherapy, taxane platinum after the surgery, and it was positive. Again, it was positive. And this was the PFS2, and PFS1 also was positive for all intention to treat population as well as HRD population. So we do have here a business case here, that the PARP inhibitor is working for those type of patients, advanced ovarian cancer stage 3 and 4, regardless of the BRCA, with HRD positive and negative and BRCA positive patients as monotherapy. So what about adding Avastin? This is the debate all the time, as Dr. Imad knows, in our old discussion, when to add bevacizumab to this maintenance therapy. The maintenance treatment, as the guidelines of ESMO telling that, with PARP inhibitor with or without Avastin is recommended for patients with BRCA mutant, HRD positive tumors, with no evidence of disease at the end of the chemotherapy, complete or partial response. For BRCA wild, HRD positive, niraparib for 3 years, still there, and olaparib bevacizumab for 2 years. And as I mentioned, also rucaparib is added to these guidelines. So what about this combination? The famous trial was Paula trial, the same newly diagnosed stage 3 and 4, high-grade serous ovarian cancer, endometrioid or fallopian tube, first-line treatment, surgery, platinum, good response, complete or partial, and then they randomized them to olaparib after they start already on bevacizumab. Start of the bevacizumab, I will talk about that, but generally it's a discretion of the clinician at the clinic. For this trial, they were already on bevacizumab, 3 cycles at least, and they add to that olaparib. And as I mentioned here, the Paula trial, they were stage 3 again. Most of the patients, stage 4 was 30% only, and no residual disease after upfront surgery was seen in 6% of patients. And some patients, no surgery, only 7% on this trial. Very positive, again, in HRD positive patients, including the BRCA mutant, hazard ratio of 0.33, with HRD positive, but excluding tumor BRCA, the hazard ratio was 4.3, 0.43. But was negative, HRD negative or unknown, it's completely negative outcome, PFS, which was the primary endpoint. The overall survival for subgroups was showing the same in the BRCA mutant, in the HRD positive, excluding the BRCA, but again negative in the HRD proficient patients. The good thing that along all these four famous trials of PARP inhibitors, Solo, Paula, and Prima, and Athena, we can just no MDS as side effects and no acute leukemia even with the long follow-up. And as I mentioned before, we cannot do cross-link or cross-like comparison between trials, but just to give you an idea about who's there in this trial. And you can just appreciate the difference between the 4 trials. So, maintenance sequence with another also now a new trend of immunotherapy to be added. Is it having a role or no? To be honest, the things are not clear, especially that we know that immunotherapy as monotherapy was completely failure in ovarian cancer treatment. So came the DO01, which was a bit bizarre really for me. I feel it's not really very clear what about this, the regimen of the scheme of the trial. But generally, they were having chemotherapy, bevacizumab, again with durvalumab, against durvalumab plus bevacizumab and olaparib as experimental. And they compared this together, and they found that there could be a trend toward a better PFS in those type of patients when we add PARP inhibitors to Bev plus durvalumab. We're doing better for HRD, for the all intention to treat population, as well for HRD and HRD negative and HRD positive. So there could be a trend to add immunotherapy for those type of patients who is not really responding well for different reasons. We can talk also about that. Maybe the HRD negative patients, they will make use of this one. Maybe the HRD positive who are not, sometimes you can just give them the chance with heavy disease, heavy burden disease. And this all patient, by the way, they are not, they are only HRD positive and negative by the score, not by the germ mutation, by the GIS only. Athena tell us the combo that the Athena was positive, which is rucaparib. So what happened when we added rucaparib and nivolumab to it? Just having the same, either rucaparib plus nivolumab, again it's only rucaparib as single PARP inhibitor, to just see maybe there is a chance of immunotherapy to be added to PARP inhibitor having a better really outcome. But unfortunately in this ESMO also, the Athena combo came as negative study, and it was also another disappointment. So rucaparib as single agent was staying there, not to add immunotherapy to this one, was only having toxicity only. So immunotherapy, I think at the time being, is not in our, trend to treat. So selection of maintenance, what to do? Today, 2024, and today is 5th of October, after the recent updates. Again, we cannot emphasize the importance of just having these patients in the clinic, stage 3 and 4 advanced ovarian cancer, high-grade serous endometrioid or fallopian tube, or even peritoneal disease. 4 factors at least to consider. It's a bit difficult now what to do, what to choose, but still have to consider that. It depends, of course, on the surgery outcome. It was upfront. The upfront people were doing better, or interval. having neoadjuvant or no, having residual disease after surgery or no. This also can really matter on the choice of what type of treatment we are giving as maintenance. Of course, BRCA and HRD, I cannot, tell it more or emphasize more, because if every algorithm of the biomarker will give us like a different way to go. Not to forget the safety for combination. If we don't need the combination, is there. The convenience for single, like in comparison to twice a day. The preference of patients. A lot of patients, they don't want Avastin because of the IV every 3 weeks coming to the hospital. We have to really, consider that definitely. Of course, and the approval and the reimbursement and the financial and the availability in the country, what we are talking about. So today in the clinic, what to do after all this, what I have mentioned. If we have BRCA patients only, we do have solo 1, Prima, Paula, or showing good hazard ratio, positive effect in the PFS, all of them. And we have overall survival in Paula and solo 1 as well for BRCA. So we have the chance either to go for single or to go for the combination, that means PARP plus bevacizumab for the BRCA patients. What will really decide more is that to go back, as I mentioned, to the cohort of patients in different clinical trials. And not to forget, the type of surgery in the solo 1 was not really having any impact, was doing well for all patients, either upfront or interval. What about adding for solo 1 Avastin? We know that Avastin generally when we add it to, for the Paula, for the BRCA patient or HRD patients, we don't have, for BRCA patients, we don't have there was a missing what's called arm with a PARP alone or single PARP. They have done indirect comparison and they said that when we add Avastin to PARP inhibitor, maybe it will give additive effect but no synergism. So put it in your mind also as a fact, scientific fact. But Paula analysis and the solo 1 analysis telling us that the patient who really have residual disease after chemotherapy and surgery, they are doing better regarding the response rate, the BRCA patient, if they're giving the combination. Or something just to put in mind. And not all BRCA is the same BRCA, also very important. We know that BRCA1 worse prognosis than BRCA2. We know that the BRCA itself as the location of translocation or the mutation is different completely in how they're responding to PARP inhibitors as single agent. And this really like one of the report was mentioned in Annals of Oncology 2022, telling us that there is different type of location mutation of the BRCA, not all BRCA are the same, and they are responding to PARP inhibitor, here was olaparib, in a different way. The PFS was so different according to the location of that mutation. So also can put this in mind, and maybe in the future, we have to ask which location where, not only BRCA1 and BRCA2. And again, the PRIMA was negative in BRCA patients as well as BRCA negative patients. So what about, we finish with BRCA now, we know exactly what to do for them, according to what I have said. What about non-BRCA but HRD positive? Another really like big dilemma, what to do for them. We know that the BRCA mutations showing great, huge benefit on all parts. The BRCA wide but HRD positive was showing the same great really benefit for all, consistently along all the trials of the PARP inhibitors. What about the BRCA wild type and HRD negative, showing some benefit in one of the trials, as the PRIMA trial, as you can see here. So, what to do? Based on the PRIMA and Paula, PARP should be incorporated to all maintenance for HRD positive patients. This is number one. PRIMA and Paula showed benefit regards of time of the surgery. And then to decide, is it a combination or single? As I mentioned, if we start already on bevacizumab due to different real reasons, clinical reason, KLM, and different, like what's called stage 4, ascites, all this, continue. Please continue on bevacizumab and add to that olaparib. If there is chemotherapy response, very well, neoadjuvant, adjuvant, why to go for the combination, even for stage 3 and 4? If they have really good response, KLM was favorable, no residual disease, no ascites, no plurifusion, even HRD positive, we can go only for single agent, and at that time can go for the PRIMA trial. Toxicity, as I mentioned before. The combination, of course, have toxicity more than the single agent. So this is the thing that we have to put in mind for those type of patients. And the KLM, as you all know, this is a kinetic elimination of CA125. Recently, we used to use it. Despite this all mentioned in retrospective trials, we don't have a still prospective trial that is ongoing to tell us exactly is KLM really is a factor that we have to put in mind when we decide about BEVA or no BEVA. And not to forget, in the PAOLA, the low-risk patient also were having really good PFS. In spite, we thought only the high-risk patient will do really well on the combination, but on the contrary, also the low-risk were having good, PFS for the PAOLA. And they found that also the patients who were having upfront surgery with no residual disease were doing very well on the combination and the single agent as well. So the things that we have to be careful about who's there in the clinic with you, who's the patient. Is it stage 4? Is it stage 3? Is it residual disease? Is it high? Is it ascites? Is no? Is good response to chemotherapy even after 1 cycle or no? Is KLM positive or no? Is it tolerable? Is it toxic or not to have the combination or to have only single agent? All these really factors we have to put there when we treat with HRD positive patient while BRCA. So what about the HRD negative and also while BRCA also a wild type? Of course, chemotherapy is there. Bevacizumab is there definitely for those type of patients, especially for high grade, stage 4, stage 3, and to continue on bevacizumab at that time. PRIMA has a role still, yes, it is there as a guidelines, as a first line for the PFS. For whom? For the patient who is really having good response to chemotherapy, no residual disease, and stage 3, and a good performance. So just to consider that. So my take-home message, maintenance therapy with PARP inhibitors in front line has changed the natural history of patients with high-grade serous cancer with GIS positive tumors. This is the genome instability score. BRCA and HRD testing is mandatory for patient treatment selection. Overall survival data in SOL1, PAOLA-1 raise the possibility of definitive cure for some of those type of patients. The role of bevacizumab added to PARP in patients with GIS tumors is still a matter of debate when and whom, as I mentioned, we can just, select those type of patients according to what I have said before, all these criteria. Optimal response to chemotherapy may favor PARP single agent monotherapy. Don't forget that. KLM score can help select some patients with large greater benefit from bevacizumab, but not randomized clinical trial waiting for it yet. HRP population remains the worst prognosis population where new options needed to be really, expressed or explored for overall survival for those type of patients. Because up to now, we don't have convincing data for these patients. New biomarkers may be needed for BRCA, for GIS, maybe tumor, circulating DNA, as we have seen in the breast cancer, could be also the way to go to identify patients that will progress on or shortly after PARP. DUO report clinical meaningful PFS benefit with first-line chemotherapy, beva, durva, plus olaparib, but versus control arm for HRD positive and negative. So something to consider. Nivolumab, in combination with rucaparib, was associated with increased toxicity, did not extend the PFS benefit of rucaparib monotherapy as first-line maintenance, and it has to be not in our guidelines. Thank you so much for your attention.
Thank you, Dr. Hind, for the excellent presentation. For the sake of time and because we are really behind schedule, we'll forget about the question and answer. Dr. Ahmed will take over for the next session.
Thank you so much. We didn't attend the session because we had the election, and thank you for everyone for being with us today. So before we break for lunch, we're going to break for lunch, so we're just going to acknowledge our sponsors. Dr. Aida is here, Dr. Falah. Dr. Aida, Dr. Falah. No? Lunch already started? Okay. So we will show the name of the company, and I would like their representative to come and will represent their appreciation certificate to them. So thank you for everyone for supporting the successful event, and we look forward, inshallah, for more success working together. We'd like to invite Lily, please. MashaAllah, Sabah. SD, please.
We would like to invite Novartis. We would like to invite AstraZeneca. We would like to invite Roche. Amgen. JSK. Ipsen. Merck. Pfizer. Menarini Stemline. Baxter.
Actually, I would like to thank you for supporting our colleagues from Iraq to attend the conference. So thank you so much. And this is an initiative we are very happy with, and would like our, to see more of this, to support our colleagues from across the MENA region to come and attend our activities. So thank you so much. Thank you.
Hyatt Investments, BGI, DIS, Juniper, New Bridge, Sandoz. Seher Pharmaceuticals, okay, for our symposia sponsor, we have AbbVie, Astellas, BMS, Pierre Fabre,
I should mention a story that, Pierre Faber, there was a patient who needed medication. I will not mention the medication name, but the medication was not available. It was only through them, and they provided the medication for free for this patient from abroad. So thank you so much for this humanitarian touch. It was really touching for me to see pharma comes out of the usual and provide the medication for free for the patient, and thank you so much for doing that.
so much for everyone. And after lunch, we'll start, inshallah, special sessions with the palliative care, pediatric, hematology. So please stay with us. See you soon.
Assalamu alaikum, good afternoon. I hope you all enjoyed your lunch. My name is Dr. Mohammed Al-Naimi. I'm a pediatric oncologist. I used to work at Tawam and just recently moved to SKMC. It's my pleasure to introduce Dr. Angela Punnett, our next speaker, who will be talking to us about pediatric Hodgkin's lymphoma. Dr. Punnett is a staff oncologist within the leukemia lymphoma section at the Hospital for Sick Children, Toronto. She's also an associate professor at University of Toronto and a clinician educator and the current director of the undergraduate medical education for pediatrics at the University of Toronto. I had the pleasure to train under Dr. Punnett, so it's really my pleasure to introduce her to this conference. Dr. Punnett, are you online?
I am. Can you hear me?
Yes, we can hear you well. So the stage is yours. I'll let the microphone to you. Thank you.
Wonderful. Thank you. It's really a privilege to join the EOS conference this morning. It's morning in Toronto, and to virtually see friends and former colleagues. Thank you, Dr. Al-Nuami, for the kind introduction, and to Dr. Al-Shamsi for the kind invite. This is Sick Kids in Toronto. I have to put in a picture of the home hospital. We are undergoing some changes, and I'll show a picture of that toward the end. I don't have any disclosures for this morning's presentation. I will be discussing the off-use label of brentuximab and nivolumab for pediatric Hodgkin lymphoma. So Hodgkin lymphoma, as everyone knows, is a curable disease. It was one of the early success stories for cancer therapy. And success was basically due to iterative experiments or clinical trials with combined modality therapy, meaning the use of both chemotherapy and radiation therapy. The type of chemotherapy that we've tended to use in pediatrics in North America has been a dose-dense regimen with ABVEPC, so adriamycin, bleomycin, vincristine, etoposide, prednisone, and cyclophosphamide, and response-adapted radiotherapy. The Euronet group in Europe has historically used an OEPA-COPDAC-based chemotherapy, so with some dacarbazine thrown in, and they have also moved to response-adapted chemotherapy. We know that the late effects from chemotherapy and radiation are significant, and I'll show some data to that effect shortly, and that has prompted the move to incorporate novel agents in the form of various immunotherapies to try to decrease exposure to chemotherapy and radiation. So I'm going to talk about a few historical trials through COG and Euronet very briefly, and then talk in more detail about more recent studies incorporating brentuximab and nivolumab in treatment. And if we have time, I'll discuss as well an immuno-oncology approach to relapsed therapy. So I wanted to highlight AHOD 0031, which was a children's oncology group trial, because it was really a remarkable 1,700 patient randomized trial that was done back in the early 2000s. So there were 1,700 patients with intermediate risk Hodgkin lymphoma. These patients received 2 cycles of our standard chemotherapy, ABVEPC, and then had a response assessment. At this time, we were not using PET solely for response assessment, so the response assessment was based on anatomic response. Patients who were considered to be a rapid early responder after 2 cycles, so if they had a greater than 60% decrease in the overall burden of disease, then they went on to receive additional 2 cycles of ABVEPC. And if they were in a CR, so more than 80% response, they were randomized to receive or not radiation. For our slow early responders, they received another 2 cycles of ABV-EPC on the standard arm, or were randomized to receive non-cross-reacting chemotherapy with dexamethasone, etoposide, cisplatin, and Ara-C. So quite a bit of therapy. And then went on to receive radiation. So this study was really saying, for our rapid early responders, can we get away with no radiation? And for our slow early responders, do they benefit from augmented chemotherapy? You can see we had very good event-free survival with 85%, excellent overall survival, and that persisted at 10 years. As regards the randomized question, for our rapid early responders, there really was no difference in the patients who received or not radiation, suggesting that if you have an early response to chemotherapy, you can avoid radiation. For the second question regarding augmented chemotherapy, there did not appear to be a benefit to additional chemotherapy if you were a slow early responder, with the potential exception of, in a post hoc analysis, those patients who were PET positive after 2 cycles. The study wasn't designed to look at that question, so the p-value was right on 0.05. So the Euronet C1 trial was finally published in the last few years. This was a trial that ran from 2007 to 2013. The Euronet group tends to do bucket studies, so all patients on the study. They too have divided their patients into low, intermediate, and high risk. They call them TG1, TG2, and TG3. The low-risk patients received 2 cycles of AWIPA, and then based on their response, and this was a PET-based response, they received radiation if they had an inadequate response, or no radiation if they had an adequate response. Interestingly, patients who received radiation, so an inadequate response and went on to receive radiation, actually did a little bit better than the patients who had an adequate response and did not receive radiation. And as a result of this, the C2 trial, the follow-up trial, includes an additional cycle of chemotherapy for patients with an adequate response who will not require radiation. In the intermediate risk and high risk groups, patients receive 2 cycles of AWIPA, have an early response assessment, and then go on to receive 2 or 4 cycles of COPDAC. The study was actually designed to compare COP, so procarbazine-based consolidation versus COPDACs, replacing the procarbazine with dacarbazine. We've had some issues sourcing procarbazine, and there are concerns about fertility with it. And in the end, there was a very minimal difference in event-free survival that favored procarbazine, but given the benefit for fertility with COPDAC, the decision was made to use COPDAC in additional cycles. Again, excellent event-free survival for these patients at 90%. They did have 1 on-therapy death with sepsis. This is the Euronet C2 trial. I'll just draw your attention to our intermediate and high-risk groups, now called TL1 and TL2. This is this group here. They are actually studying a comparison of a traditional COPDAC with an escalated DCOPDAC. So this is additional chemotherapy. It incorporates additional adriamycin, etoposide, and dexamethasone, and it is a dose-dense regimen, so given every 21 days as opposed to every 28. And the goal of doing this, although the cumulative doses of some quite toxic chemotherapy do increase, they're trying to decrease the number of patients who go on to receive radiation, and for those patients who do require radiation, trying to limit the field. So we'll anxiously await their results. As mentioned, the significance of late effects is not to be underestimated. This is older data now from the Childhood Cancer Survivor Study. So this is a cohort of patients who were treated for Hodgkin lymphoma as children between 1970 and 1986, and then followed longitudinally at 5 years from diagnosis. And you can appreciate that although our survival rates are excellent, these patients who are survivors of Hodgkin lymphoma have a lower life expectancy than age-matched controls. This is US data. It does appear, if you look at C here, that cumulative mortality is due to recurrence in the first 5 to 10 years, and then that tends to plateau. And then after that, patients are dying of second malignant neoplasm, cardiovascular disease, and pulmonary disease. And we don't have a plateau for that, as you can appreciate in D. So with this, we look at trying to incorporate new agents such that we can decrease overall cumulative chemotherapy doses and decrease radiation exposure. And one of the first new agents approved for Hodgkin lymphoma is brentuximab. Brentuximab is an antibody drug conjugate against CD30, which sits on the Hodgkin-Reinsternberg cells. The antibody is conjugated to a medication called MMAE or auristatin. This is a tubulin inhibitor. Brentuximab has been shown to be highly effective in relapsed or refractory classical Hodgkin lymphoma. We use it in the post-transplant setting for maintenance, similar to the adults. And its major off-target toxicity, I would say, is peripheral neuropathy, particularly in adults, and myelotoxicity. So the first big study to incorporate brentuximab into the upfront treatment setting was the Echelon-1 trial. This was an adult trial of about 600 patients in each arm, comparing brentuximab AVD with standard ABVD. And it showed both an early signal for efficacy benefiting brentuximab use in the modified progression-free survival analysis. And then more recently, the publication was updated, and there is now a difference in overall survival of about 5% for patients receiving brentuximab. And in North America, in many centers, brentuximab AVD has now become standard of care for patients, adult patients with Hodgkin lymphoma advanced stage disease. There were more deaths from second malignant neoplasm and pulmonary toxicity on the ABVD arm. And then in terms of toxicity, myelotoxicity and neuropathy were much more common in the brentuximab arm. On the pediatric side, the St. Jude's group did a single-arm study of a relatively small number of pediatric patients with high-risk disease, where they swapped out the vincristine in the OEPA-COPDAC protocol for brentuximab, so it became AEPA-CAPDAC. And you can see excellent event-free survival at 97% for this regimen. They were also able to avoid radiation therapy in 30% of their patients. This brings us to the Children's Oncology Group study. So not to be outdone by our adult colleagues, we also chose to study brentuximab in the context of our ABV-EPC backbone. We always remove bleomycin from a backbone if we're giving brentuximab because of the potential for additive pulmonary toxicity. So 1331 was a randomized trial of BV-AV-EPC compared with the standard arm. Patients did have an early response assessment by PET, and then any patients who had either large mediastinal adenopathy at diagnosis or a slow responding lesion at early response assessment would receive radiation at the end of all therapy. All patients received 5 cycles of therapy. So we had close to 600 patients randomized for this study. Eligibility included an age of less than 21. And then our definition of advanced stage disease for this study was patients with stage 2B with bulk disease, 3B, or stage 4, either A or B. This study was published 2 years ago now and showed a quite remarkable 10% benefit in EFS for patients receiving brentuximab compared to the standard arm. Overall survival was not different between the two arms. But this is, again, relatively short follow-up, and we know the Echelon study, it was 6 years of follow-up that started to show a difference in overall survival. The benefit to EFS was primarily due to a decreased incidence of relapse and refractory disease. An interesting phenomenon on this study, the interim response assessment did not appear to be prognostic if you received brentuximab. So if you were on the experimental arm, it did not matter if your interim PET was positive or negative, your outcomes were still excellent. So I'm just showing that in the table here for the brentuximab arm, interim PET positive, your EFS was 91%, and interim PET negative, you were 92%. Key adverse events on this study. So fever neutropenia was pretty similar between the two arms. Patients did receive GCSF on this study. Incidence of sepsis, again, not statistically significantly different. And then neurotoxicity, chemotherapy-induced peripheral neuropathy was evaluated in this study as a key outcome, and there was no difference really between the two arms. Infusion reactions were incredibly uncommon, and we actually didn't see any pneumonitis on this study. One of the objectives of this study was to evaluate chemotherapy-induced peripheral neuropathy very closely. We took a different approach in this study in terms of dose modification of either vincristine or brentuximab. So on the study arm, the protocol stipulated dose modifications related to peripheral neuropathy were to decrease vincristine doses or omit them before decreasing the brentuximab dose. This is very different than any other study, and we wanted to see if this impacted outcomes at all. So the key findings from this sub-analysis were that our protocol stipulated dose modifications actually worked very well. Overall rates of neuropathy were really the same between the two arms. We did have more dose modifications in the brentuximab arm, so patients tended to receive less vincristine, and those dose modifications occurred earlier in therapy than in the standard arm. But in the end, only about 8% of patients actually required a dose modification of their brentuximab. If I draw your attention to the outcomes slide here, you can see that for patients for whom we made dose modifications, so with patients with peripheral neuropathy versus without, there was no difference in progression-free survival. So although dose modifications were made on both arms, those dose modifications did not affect patient outcomes. So just because we have to compare, so patients on our study received less overall doses of brentuximab. Brentuximab is an expensive medication, so this was an important finding compared to adults on the Echelon trial. We had about half the rates of high-grade neuropathy as the adult trial, and our progression-free survival was excellent. Another sub-analysis of this study, which turned out to be very important, was around patient-reported health-related quality of life. So patient-reported outcomes are increasingly being recognized as important in oncology studies. Really important data that allows us to counsel patients coming through therapy at a future time. So what we had patients do on this study was to complete a health-related quality of life survey pre-treatment, after cycle 2, after cycle 5, and at the end of all treatment, so post all chemo and radiation if they received it. And what you can appreciate in the graph here is that patients on the brentuximab arm, all patients, first of all, pre-diagnosis, or at least the vast majority, did report a decreased health-related quality of life, reflecting burden of disease at diagnosis. But then as we start therapy, patients on the brentuximab arm show a very early and very significant increase in quality of life that is persistently above that noted in the standard arm throughout therapy. In fact, patients on the standard arm did not have a significant increase in health-related quality of life until they completed therapy. This was a really important finding because you'll remember I told you that after cycle 2, patients had an early response assessment, and patients on both arms had similar responses. About 17% of patients would have been considered slow early responders based on their PET response. So our health-related quality of life difference seems to be picking up something in the patient experience that is not reflected in their disease response assessment. And I think that's really important information. When we compare the results of AHOD 1331 with other adult trials, we compare very favorably. Until the BRICAD trial got published this year. So our adult colleagues completed a randomized study of BRICAD, comparing this with escalated BIACOP. So this was a European trial. The BRICAD consists obviously of brentuximab, and then there's some dexamethasone and dacarbazine thrown in, comparing to the escalated BIACOP, which is a standard therapy. Patients received 4 or 6 cycles and then had an end of therapy response assessment that determined need or not for radiation. The findings of this study, BRICAD was better tolerated with lower treatment-related morbidity and lower protocol-stipulated dose reductions than escalated BIACOP, and BRICAD demonstrated superiority. So this was not a pediatric study, it was an adult study, but it does tell us that dacarbazine does seem to be well tolerated and may be an option to replace procarbazine in the BIACOP protocol. So AHOD 1331 was the first randomized advanced stage Hodgkin lymphoma trial in children, set up in the way it was. So previous studies had single arms and compared with historical controls. It took us a long time to get this study done. We started planning in 2011, and the publication didn't come out until 11 years later in 2022. And we just we can't keep doing studies this way, right? The science changed in the decade that it took to get the study up and running and completed. That makes the results less relevant by the time we get there. And it also speaks to the fact that we're just not getting access for our children and adolescents to new agents quickly enough if it's taking us this long to do a study. So recognizing that and recognizing that the epidemiology of Hodgkin lymphoma in the AYA and adult population is really the same, we went on to work with our adult colleagues to incorporate another new agent into a chemotherapy backbone. So this next new agent will be familiar to everyone, was nivolumab. So just speaking about checkpoint inhibitors generally, obviously, these agents target PD-1 on the T cell or PD-1 ligand on the tumor cell to block the anergic effect of the PD-1 ligand on the T cell. So basically reawakening, reactivating, allowing T cells to expand and deal with the tumor. Hodgkin lymphoma is particularly sensitive potentially to checkpoint inhibitors because of genetic alterations in the chromosome 9p in the Reed-Sternberg cells, resulting in increased expression of PD-1 ligand. And nivolumab has been shown to be highly effective in relapsed or refractory classical Hodgkin lymphoma. Of course, with new agents come new adverse effects, and because we're turning the immune system back on, we tend to see occasionally immune-related adverse events. And I've just shown a picture here. These immune-related adverse events can really affect any organ system. So S1826 was the study that we worked on with our adult colleagues. This was actually run by the Southwestern Oncology Group, one of our adult clinical trial network groups. And the Children's Oncology Group was a significant contributor. This was a randomized trial comparing brentuximab AVD, so the winning arm of the Echelon 1 trial, with nivolumab AVD. So it was really a pick the winner study. Patients with newly diagnosed advanced stage disease, now defined as stage 3 or 4, and over age 12, were randomized to one of the two regimens. And radiation was based on PET at the end of all therapy. The primary endpoint for this study was progression-free survival. So this study was activated in July of 2019. It accrued ahead of schedule and closed in December of 2022. We had 994 patients, 12 and up. 25% of these patients were between 12 and 18, so a good representation of the pediatric group. Sort of equal numbers randomized to the Nivo arm and BV arm. The initial data was presented at 50% of events. It was presented early at recommendation of the Data Safety Monitoring Board at ASCO last year by Alex Herrera, because the Nivo arm showed a benefit in progression-free survival, significant benefit over the brentuximab arm. So at 1 year, progression-free survival for the Nivo arm was 94%, and for the BV arm, 86%. And remarkably, radiation use in the entire cohort was less than 1%. That's very significant. That compares with 53% on our AHOD 1331 trial. The pediatric data at 1 year was presented at ASH last year, so relatively recently. I'm just going to share those data here as well. We're hoping that the year 2 data will be out shortly. So we had 240 pediatric patients randomized between the two arms. And at the time of this data cutoff, we still had a few that were too early in therapy, but really the majority could be commented on for safety analysis. If we look at the cohort, there were really no significant differences by study arm in baseline patient characteristics or disease characteristics. And you can see that the average age was 15.6. And we had good representation across both stages and demographic factors. Supportive care in this group, so GCSF, based on the Echelon experience, was mandated for the brentuximab arm. So most patients in the brentuximab arm did receive GCSF. Patients on the Nivo arm, it was fewer, 60%, and most of those were kids, actually. I think pediatricians have a harder time not using GCSF. And patients receiving the AVD backbone do develop neutropenia. Because the cumulative dose for 6 cycles of ABVD of doxorubicin is 300 milligram per meter squared, desrozoxane was allowed on this study and was used by many pediatric healthcare providers, so 80% really in both arms of patients received desrozoxane. And I have to say, when you look at this compared to the adult cohort, we use much more desrozoxane than our adult colleagues. So adverse events of interest on this protocol, neutropenia did develop. It was a little less common in the brentuximab arm, likely because of the mandated use of GCSF. Febrile neutropenia was similar between arms at 3% and sepsis similar between arms at 1%. You can see that the peripheral neuropathy, now looking at greater than or equal to grade 2, so not grade 3 like we were reporting for AHOD 1331. You can see that the rates are basically twice as common in the brentuximab arm as in the Nivo arm, but really much lower than the rates that were seen in adults on either arm in this study. If we look at immune-related adverse events, we certainly saw ALT and AST increase pretty commonly in the protocol, although very rarely above a grade 3 or above, and similar between the two arms. Rash tended to be more common in the brentuximab arm, actually, but again, not too significant, so nothing grade 3 or greater. Pneumonitis, extremely uncommon. GI, extremely uncommon. And then a thyroid-related disease was much more common in the Nivo arm, as would be expected. In terms of treatment discontinuation, it was actually more common for children to discontinue their Nivo, typically due to toxicity, than brentuximab. This is in contrast to our adult population at this point in the study, where adults were much less likely to complete brentuximab than they were Nivo. And again, in terms of receipt of radiation, 2 patients on the brentuximab arm received radiation, putting this again less than 1% of the entire group. For children, there was a difference in 12-month progression-free survival, 94 versus 88%, favoring the Nivo arm. Because this was a subset analysis, the p-value did not reach significance, but you can see a difference in the curves there, and this is obviously being followed very closely over time. What you can also appreciate from this graph is that events tended to occur early. So most relapses were within the first year. For event-free survival, which is actually what pediatricians are more used to looking at, there was a difference between arms of 91 and 87%. Again, not statistically significant and needs to be followed over time. Events did include receipt of non-protocol chemotherapy or radiation on this study. And you can see the numbers reported here. Really, most events were related to progression or relapse. So the conclusions from this study were we can collaborate with our adult colleagues and run joint trials. And in fact, this has been the precursor experience for the currently ongoing early favorable and unfavorable trial for children and adolescents and adults running through the Children's Oncology Group. That's called AHOD 2131. We do know that we were able to access nivolumab earlier in frontline therapy for our adolescents as a result of this collaboration. We know that Nivo and brentuximab ABD were well tolerated. This is important experience because we don't we haven't for many years used ABVD as a backbone in pediatrics. As regards immune-related adverse events, they were relatively uncommon and did not result in major discontinuations of therapy. Most importantly, perhaps less than 1% of patients received consolidative radiation on this study. And I think we're going to just have to keep an eye on the cardiac toxicity potential events moving forward, and I'm very happy that 80% of patients were receiving desroxane. So obviously early days, but interesting results, and certainly will be followed. We had lots of discussions locally when these results came out as to whether we change our standard of care. I think I've just compared backbones here for you in terms of what it means for the patient. With respect to cumulative doses and outcomes and radiation therapy and duration of therapy. Because I think at some point we're going to get to we're going to be able to offer to patients and families a shared decision-making model where we have sort of multiple ways we can go with treatment. And maybe it comes down to a discussion with the individual patient around their values, preferences, as to which route they want to go. I've borrowed this from a recent publication from Justine Kahn in terms of the different aspects of care that we need to discuss with patients and families as we're making these decisions with them. Sort of a privileged position to be in, I think, because we have multiple good options, all with their distinct set of late effects to be considered. Okay, I don't think we're going to have time to talk in depth about relapsed and refractory therapy. I just want to mention Checkmate 744, which included 2 cohorts, a transplant arm and a non-transplant arm. The non-transplant arm is really interesting. So this study incorporated an immuno-oncology approach with Nivo and BV for 4 cycles. And if patients had a good response, then they would continue with an additional 2 cycles and then receive radiation. If they did not achieve a good response, a good enough response, then the Nivo and BV were moved to BV plus bendamustine, so incorporating a strong alkylator to try and improve response. And if patients responded appropriately, they received radiation. And then no transplant, they were done. So this is really an immuno-oncology approach plus radiation for patients who met the low-risk relapse criteria listed here. So a very select group, but it's really remarkable that the progression-free survival at 3 years is 95% and the event-free survival 87%. This was a phase 2 trial, needs to be further studied, but very promising. Okay, I'm going to finish up there. Happy to take any questions. For those of you who have been to Toronto, the hospital is on the right-hand side of this picture here. And we've just completed phase 1 of our renovation, and our patient support tower is now up and built, and there's this lovely bridge across Elizabeth Street when there is snow on the ground. So happy to take any questions.
Thank you so much, Dr. Punnett, for the interesting lecture. I'm happy to take any questions from the audience.
Thank you, Dr. Punnett. I'm Dr. Latif Al-Arfaj, Pediatric Hematology Oncology Fellow from National Guard, Riyadh, Saudi Arabia. Thank you for your interesting talk for the update of Hodgkin lymphoma. I'm wondering if, what about children less than 12 years old? Any update to include them in such studies?
Yes, it's a great question. So the current study for early favorable and unfavorable Hodgkin lymphoma, so stages 1 and 2, does include children down to age 5. We felt very strongly about that. We didn't want to exclude any particular population. That study incorporates nivolumab as part of treatment. It's a randomized trial for that patient population. The next joined study with our adult colleagues for advanced stage disease will include children down to age 5, as will the relapsed study that is being designed currently with our adult colleagues. So we are advocating for our patients down to age 5 to be included. I think it's tricky. There are some concerns about the use of checkpoint inhibitors, in particular in very young children whose immune systems are so malleable still. So, I think the data from the currently running low stage trial will be very helpful for the younger population. And, maybe at some point we'll be able to include all patients. I think, the incidence of Hodgkin lymphoma in children under 5 is very low, but I would hate to exclude patients who may benefit from this therapy. It's an excellent question.
Okay, any more questions from the audience? If no, then I have just one quick question, Dr. Punnett, before we move on to the next session. Given the results of the AHOD 1331 for the interim assessment PET scan after 2 cycles, sorry, do you think it is still necessary now off trial? Because sometimes we run with issues with insurance approvals, not approving PET scan after 2 cycles, because this is not what they're used to. If we omit PET scan after 2 cycles, would that make a difference?
Yeah, you're asking the question we've all been asking ourselves here, but we're asking it for a different reason. We're asking it to decide whether radiation is actually necessary for all those patients with large mediastinal adenopathy. given the results of S1826, where radiation was determined at the end of therapy as opposed to midway through, and the very good, excellent event-free survival following that therapy, I'm not convinced the early response assessment is required for patients receiving brentuximab. I don't have data, but this is a conversation. First of all, I wouldn't panic if insurance says no, but honestly, the study was designed around having that early response assessment after 2 cycles. But I wouldn't panic if you get a no. And we are having conversations with patients and families now at the end of therapy, if the PET-2 was positive and the PET-5 is negative, around how much of a benefit radiation may actually be. And it's probably on the order maybe of 5 to 7%. It's hard to say in terms of improved event-free survival. And some patients are choosing not to have radiation based on that. And I think that's very reasonable. I think it comes down to an individual decision with a patient and family around preferences.
Thank you so much, Dr. Panit, for your time. I know it's very early in Toronto right now. Because of time, we need to move to the next speaker. Thank you so much again.
Thank you. Bye-bye.
So let me present our next speaker. We have very limited time, but you will enjoy, inshallah, her presentation. So Prof. Barbara Lawrence, she is a director, scientific director of Art Fertility Clinic in Abu Dhabi. And actually, we just saw the news for the first fertility preservation for a 7-year-old girl undergoing bone marrow transplant on Abu Yas Clinic. So she did her training and study in Germany. She started with gynae, obstetric and prenatal medicine, and then gynae, endocrine and reproductive medicine. She is expert in preservation before cytotoxic therapy in women with malignant disease and fertility preservation for those children undergoing cancer treatment. This is a very important topic, and I think in our area here we always feel hesitant and we lower our voice when we are talking about fertility and cancer. And this is very important because our survivor, our children, as you just saw in Hodgkin lymphoma, they are really survivor. More than 80% they are survivor, and they always blame us when they go to the survival clinic. So this is very important topic for us at pediatric and adult, and to talk about fertility preservation. Please welcome with me Dr. Barbara.
So good afternoon. Yeah, dear Dr. Iman, thank you very much for your kind word and also the kind introduction. And as you took my first sentence, so you shortened already a little bit my presentation time. Just to re-emphasize the importance, I mean, we have seen how young kids are more and more to survive those horrific diseases. And at a later stage, they really might ask you, why didn't you do anything that we can have a family of our own? So this is the topic of my talk, pediatric fertility preservation, what can we do? So this is a very short recap about the ovarian reserve. I think, I mean, maybe I'm a bit alien here as an OBGYN doctor. Just as a reminder, we women, we bring all our eggs with us when we are born. The highest number of oocytes is already present when a baby girl is not even born. As you can see here, the number, is this working? The number goes up, and then already at the time of the birth of the baby, most of the oocytes are gone already. The smallest number will make the way to ovulate, and the highest, in the end, most of the oocytes which had been generated at an early time point will have the fate of become atretic and not having any benefit furthermore. So now chemotherapy, radiation, both of them will destroy the ovarian germ cells because they are introducing or inducing severe DNA damage. We know, and those are the data what we know from adult cancer survivors, that the risk for ovarian insufficiency depends on the number of oocytes present at the time of the cytotoxic treatment, And then, of course, it depends on what you are using, what we are giving to our patients, either the radiation dosage or the agents used. So, but also what we'll have to think about it, and this is a point especially in young girls, so it's not only about the loss of fertility, but because if the ovaries are destroyed, they will also not have any hormonal production, which means for those kids it will be also a problem that we have to induce the development of secondary sex characteristics by exogenous hormones. And also for the long-term health for those women, later on, we have to think about cardiovascular, neurodegenerative, and also the bone health. So those are data which had been published regarding the radiation dosage which will harm the ovary, but also what I want to point towards, we should not forget about the uterus, because of course for a pregnancy it's not only important to have eggs, but also the woman needs to have a uterus. Especially in this region where surrogacy is not allowed, we need to have a functionable uterus. So especially if there's a high radiation on the uterus at early ages, so later on the uterus will fail to have an appropriate growth. I have seen young girls, or then later on young women who had like a radiation of the hip bone because of a cancer, but in the end, because the uterus was not shielded enough or still in the radiation field, at an adult age she had a very tiny uterus which would never ever be able to carry a pregnancy to term. Also, even if the uterus had been developed, if we have radiation to the uterus, we might have a problem with the development of the lining, so which means if the lining is not built up nicely enough, an embryo might not be able to implant, or in case it's implanting, we have a higher risk of having pregnancy complications like miscarriage, preterm delivery, because also the extendability of the uterus is compromised, then also a low birth weight of the baby and a perinatal risk. So the threshold seems to be around with 4 gray. So from adult situation, we know we have those medically indicated reasons to do fertility preservation. It's a cancer treatment, radiation or cytotoxic treatment, but also, and this might be also a question for children who are suffering from non-oncological diseases which still require a cytotoxic treatment. For example, also systematic lupus erythematosus. Also in those cases, maybe future fertility might be compromised. And other situations which are also discussed nowadays are the other medical conditions which might cause an ovarian insufficiency. For example, for girls born with a Turner syndrome, we know that they are born with a lower ovarian reserve, and this even lower ovarian reserve will go a far faster depletion compared to a woman with 2 X chromosomes. So also those points could be later on indication for fertility preservation in children. Those are the options what we can offer to adult patients. So the most established is the oocyte cryopreservation, or in case a woman is married or in a existing relationship, we could freeze embryos, we could freeze ovarian tissue, we could do what we call a downregulation, GnRH agonist, just to suppress the ovarian function and hoping that suppression of ovarian function gives a kind of protection to the oocytes. Or in case it's a radiation to the pelvic, an ovarian transposition could be discussed just to bring up the ovaries to a higher level to move them out to the radiation field. So however, now the question is, what can we do in prepubertal girls? And what you can see here in Germany, I was active in a network which was called FertiProtect. Maybe you have heard about it. It was a network of German-speaking countries, so which were promoting fertility preservation, and then already in 2011 we were discussing what can be done in young girls. So in the end, for girls, what we have to offer is like ovarian tissue cryopreservation. And the difference to the adult situation is that usually in young girls, it's not that we just only remove part of the ovary. So in adults and females, we'll just take the cortex which is the area which contains the oocytes. We will leave the medulla and half of the ovary inside. In young girls, usually because the ovary is so tiny, we remove the whole ovary. Usually this can be done laparoscopically, and then the tissue is sliced in small pieces. We will see this video in a second. What is the aim? Of course, we keep the ovarian tissue because later in life, at certain stages, and of course this will be one of the open questions which have to be discussed, we could use the ovarian tissue to induce a period and also the development of secondary sex characteristics, or of course, if a woman wants to get pregnant. So this is a video what I'm happy to share with you, and we had been honored to be involved. So this is a history of a young girl, 7-year-old. She was diagnosed with an acute lymphatic leukemia. However, I'll have to say this was a girl who was relapsing, so it was like the first diagnosis was at the age of 4 years. Here you can see, so they removed the whole ovary, and then it was transported in a cooler to our clinic. And there's no need to worry about transportation time, because, for example, in this network, what I mentioned, we were often like transporting tissue over the night. Here you can see this very small ovary, which we then sliced in small pieces, like 2 to 3 millimeters, which were frozen in several straws. And we'll just have to see how this goes and what will be the ovarian reserve and the outcome of this child later on. So, of course, what we always have to consider when we think about ovarian tissue, because as I mentioned previously, the aim would be to conserve it, to preserve it, and at a later stage, just to retransplant it. Now again, looking into the data from adult ovarian tissue cryopreservations, for example, we know that leukemia has a high risk to be present in all the body, so which means we have a high risk of having also leukemia cells inside the cryopreserved tissue. Also, this would be a fact where we would be hesitant to retransplant this tissue. The situation is a little bit different when we are looking at lymphoma. Again, data from adult ovarian cryopreservations. So it seems there's like only a risk of approximately 2%. This is one lately published study which was doing like a review to see how often is there like minimal infiltrative disease inside the ovarian tissue. So they were checking 17 studies, and out of 150 pediatric patients who had been diagnosed with different types of tumors, solid tumors, hematological malignancies, or CNS tumors, so 25 tested positive for minimal infiltrative disease. So now you might ask me, why do we do ovarian tissue cryopreservation at all? But in the end, and I think this will something what future might show, so hopefully in the future we would be able to isolate follicles and oocytes out of the cryopreserved tissue, which means we would not have to retransplant the tissue, but we could choose a safer way, just gain the oocytes, which are the oocytes of the patients themselves having their own DNA. So just to use those, of course not for producing hormones, but for creating a pregnancy. The next step what I wanted to show, because of course we do not do this for a long time, we don't have that much experience, that's why I was looking for data to give you a little bit an overview on long-term experience. This is a paper from a French group. They were reporting 20 years of oocyte tissue cryopreservation, so it was done in 418 girls, so the range was from like a newborn baby more or less until 15 years. And there had been a certain time when they were also isolating oocytes. Up until the time of the publication of the paper, there had been only 3 patients who had been requesting retransplantation. And as said, at the time of the publication, there was no pregnancy achieved. And also, I mean, of course, this can be controversially discussed. We know that unfortunately not all of the children who are affected by cancer will survive the disease despite the advances of the treatments. This is another paper published from a German group. So in Germany you have like 2 centers which are like serving like biobanks where this ovarian tissue is cryopreserved. So they did a survey from 102 women which had been cryopreserving ovarian tissue. 53 answered this survey. So the average age was 15, but also they had like very young girls, pre-pubertal girls included in this population. And the questionnaire was sent approximately 7 years after the oocyte cryopreservation. So also for samples which had been frozen until that day, there was only one patient who underwent a retransplantation. For this patient, there had been signs of ovarian activity, but so far, no pregnancy achieved. When we are looking into publications, we see that from ovarian tissue, which was cryopreserved before puberty, there had been the reporting of 3 live births and 2 times when it was used to induce the period. So of course those are all preliminary data, because also you'll have to understand, or we'll have to acknowledge that of course when we are retrieving tissue of a girl who is 4, 5 or 6, it might take just 15 to 20 years until this discussion is coming up to return ovarian tissue for achieving a pregnancy. So I think also here we'll just have to be a bit more patient to see the results later on. So one topic which I just want to add for completeness is a hormonal stimulation. I had mentioned that in adult females it's one of the most preferred ways to preserve fertility. So what we are doing a hormonal stimulation. We retrieve the oocytes. Usually in adult females who are married, we are doing a transvaginal approach, which is the easiest way to collect the oocytes, but it can be also done transabdominally, and then the mature oocytes would be cryopreserved for future use. So I have seen one case report which was published from a group in Israel. So what they did, that they stimulated a 7-year-old girl with a Turner mosaicism. So of course this is not a girl which was asking for fertility preservation because of a cancer treatment, but as mentioned previously, Turner patients have a very fast depletion of the ovarian reserve. So what they did an ovarian stimulation protocol, and they could retrieve oocytes via an abdominal oocyte collection, and those oocytes had been then later on cryopreserved. Of course, this is a case report, and I think it leaves many questions open. So for example, we don't know how would we stimulate this girl, how would we trigger her that we can collect the oocytes? What would be the risk for the intervention itself, for the anesthesia? Also, when oocytes develop, the hormones will be a lot higher compared to a normal situation, especially when we compare it even to the endocrine situation of a young girl. So the question would be, what would be the effect of a short-term exposure to high estrogens and progesterones? Furthermore, we have no idea. I mean, even when we see that we can cryopreserve mature oocytes, we will not be able now to know what is the developmental competence of those oocytes. Will they all be healthy? Will they have a normal chromosomal status? And also, how many oocytes would we need for a later pregnancy? We know, for example, in women who are preserving oocytes for social reasons, we usually recommend that we should have like 20 mature oocytes frozen to have a realistic chance for a pregnancy later. So, but just I wanted to mention this. I mean, there are many open questions, and I think the future will have to be seen. Just one short slide. What's going on in males. Of course, fertility preservation in adult males is very easy. It's just to give a semen sample and freeze it. So in prepubertal males, unfortunately, the situation is much more difficult, even more difficult compared to prepubertal girls, because of course we can cryopreserve testicular tissue, but until now there was no successful maturation of sperm from this type of tissue. So what is my take-home message? I think also in cancer survivors, especially in young girls who did not do any fertility preservation at the time of diagnosis, but also depending on the treatment what she received, when she comes into puberty, when she's a little bit older, maybe then again we should discuss this topic and not wait another 10 or 15 years until she really loses the rest of the oocytes. Because in a girl who then, after surviving cancer, had the puberty and she will have regular cycles, then again we could discuss the option of freezing oocytes. And I think this is also something what will have to be highlighted, which is again a difficult discussion, especially here in the country, because it might be difficult. We'll have to discuss how we can retrieve those oocytes. It will be again most likely with an transabdominal procedure. Then in the end, for prepubertal girls, right now the standard would be to remove an ovary, to cryopreserve it with the option of later retransplantation. We would have to consider what type of tumor is it, and maybe even if it's leukemia, I would not say don't do it, because as the developments, there are a lot of developments also in the yielding of oocytes out of tissue, so we don't know where we will stand in 5 or 10 years. And as said, if a girl is 7 when it happens, I mean, after 20 years she will be 27, which is nowadays quite a normal age to have your babies. Also, we should not retransplant this tissue too early, because right now we do not know how long it will be hormonally active. For the hormonal stimulation, as mentioned just, we need more evidence. We'll have to see how this would go. And unfortunately for prepubertal boys, this testicular tissue freezing is still investigational. Thank you very much for your attention.
Thank you for a very inspiring presentation, highlighting very important question. So we have very limited time, but if somebody from floor have any question?
Yes, so just practical question. So sometime we've seen, patient needing to start immediately on chemotherapy, and let's say they are already in puberty. And many times we are facing difficulty in the timing, and patient is anxious to start therapy. So logistically, how fast can we do this? And many times certain center will say, no, we need to be in the specific time of the cycle, etc. But while others will say, no need to wait, we can do it right away.
No. I mean, if a girl is having her periods, so nowadays we can start ovarian stimulation at any given time point of the cycle. So this is, I mean, there's also in normal IVF treatments, this shifted a lot. So previously it was often to start at the start of the cycle, because also it was intended to do what we call a fresh embryo transfer, which means the embryos which had been created were returned the same month. But we are moving away from this. So, and we have seen, especially in fertility preservation, patients that's where the experience is coming from, but now we do it on a regular basis also in our IVF patients. We can start at any given time point of the cycle. The disadvantage is that it might take 1 or 2 days longer. It might require a little bit more stimulation medication, but there is no need to wait for the period to delay it. We can just start immediately.
Following on the same lines, sometimes we face like teenager girls who are post-pubertal, but they come in really sick with acute leukemia or like a huge mediastinal mass that we need to start treatment right away, and it's life-saving. And even if we go with the transabdominal approach, still, the time for stimulation, and so, it's a struggle. On one hand, I'm a strong believer that this is a right of the patient and should be offered. If the patient declines, that's their right, that's okay, but it should be offered to them at least. But in some circumstances, I feel it's like a balance between saving the patient's life versus saving the fertility.
Yes, you are right. I mean, if you really need to start immediately, then we cannot do hormonal stimulation. I mean, there is a type of stimulation which we call IVM, so where you retrieve oocytes at an early stage and you mature them later in the lab, but the results are not that good, and we usually do not get that many oocytes. So in the end, what can be done really in those cases, I would just send them for ovarian tissue cryopreservation, even in leukemia patients, even if we know we might not retransplant it. But as mentioned, I mean, I think technique will advance, so we might have the chance of having this retrieval of oocytes out of the tissue. And as said, those patients, they are so young, developments are so fast. I mean, who knows where we will stand in 10 or 15 years. And I think this is the message what I think is very important and what you highlighted in the beginning. So we'll have to leave those options open for these young patients.
Thank you. A question that always comes, if we give like the first cycle, usually the patient stabilizes once we start treatment. So within the first cycle, like between cycle 1 and cycle 2, we can establish the referral, and before starting cycle 2, we can do the cryopreservation. But is there a difference? Like, is there in terms of utility or quality prior to one dose of chemo, which are different types of chemotherapy, different types of cycles for different indications? But if we give like at least the first cycle, stabilize the patient, and then do the
I mean, there's like two questions. So one question would be how much of the medication of the cytotoxic reagents are still stored like in the oocyte and might impact the quality of the oocytes. I don't think we have any data for this. And depending on the dosage what you gave, maybe we will retrieve a lower number of oocytes, but I think it's still an option, even if it's not the preferred way, but I think it's still better than not doing anything.
Establish a pathway on the hospital to make that process more faster?
Yes, I think it's very important just to have a good communication, and we are happy to collaborate, and I gave you my phone number, so whatever. I mean, I think it's important just also to have a correct counseling for the parents, for the patient, depending on her age, and just at least to offer, and then maybe also be able to initiate it fast.
Thank you. Since there is no more question, we'll just close this session. Thank you.
Hello. So let's go to the next session, the hematology session. So I would love to present my colleague and friend, Professor Renato. So he's an expert in cellular therapy. He will be talking about cellular therapy for solid tumor, challenges and principle. Renato is the cellular therapy program lead in Sao Paulo. The floor is yours.
Hello everyone, good afternoon. It's my pleasure to be here. I'd like to say thank you for Professor Humaid and also for Chabel for this kind invitation. So it's a big challenge to speak about CAR-T for solid tumors. You have a very nice results for hematology, malignant disease, but let's try to understand why you are not using as for hematology disease and the CAR-T in solid tumors. There are many principles and challenges that it's interesting. But before that, I'd like to say the biologic syntax technology was the one that really changed the game, favoring to use a monoclonal antibody merged with many different strategies for cancer therapy. So you can use monoclonal antibodies, the SCFV, and for many different, like the bispecific antibody therapy and drug conjugated therapy, radiation, tumor-specific immunoglobulin can be developed and against the tumors in the same way against the also angiogenesis checkpoint inhibitors as the Nobel Prize. Let's see the next Nobel Prize tomorrow. Pay attention to that, maybe CAR-T, I don't know. And also for CAR-T cell, this is the high level of technology because you're not only merging technologies, but you are in fact design the gene, the DNA, that you give an origin to the protein, that's the CAR-T receptor. It's important to understand that this receptor is, in fact, designed to have the first signal for TCR engagement and also the second signal for the co-stimulation that can be CD28 or 4-1BB or many others, but they both are the most tested ones. And at the first beginning, the very beginning of the CAR-T technology only the TCR engagement through the signal 1 was used, and CAR-T never worked with that because they are not able to activate it and proliferate the T cells. So when you develop vectors able to give also the signal 2, the CAR-T really change the way they can destroy or kill cancer. So you can see on this slide on your left that you have an antibody against the tumor cells, and the portion that recognizes the target on the tumor cells is the SCFV portion. So this is the segment that you use to merge it with the CD1 and CD3 signal and CD28 to a second signal, as you can see on the right. So this is why you call a chimeric, because half of the receptors comes from a immunoglobulin, in fact, is the SCFV portion, and half of the receptor comes from the TCR and the T cell aspects of immunological response. So in the cell perspective, you can see the T cell that you have that will be transfected with a vector. This vector will be able to deliver the gene, and this gene will express new receptors in the surface of the T cells that now we're gonna call as a CAR-T. This CAR-T is able to recognize directly the antigen in the tumor surface, and that you activated the signal 1, signal 2, and you're gonna have delivery of cytokines and also the storm of cytokines, the cytokines we call cytokines release syndrome, and the tumor cell apoptosis. So this had profound results. You can see here, this is a curve for patients with lymphomas, and RR lymphomas, relapse and refractory lymphomas, and you can see how the curves change. So this is a game change for these patients. The same is for patients with acute leukemia, acute lymphoblast leukemia. Almost all patients you're gonna die in the long term, and you can change this curve for like 50% of patients will be alive in 5 years after CAR-T. But which are the universal barriers to CAR-T cell therapy? Cytokine release syndrome and the ICANS, they are very well known now. Side effects of CAR-T that you can manage very well with many different drugs, but we're still learning in solid tumors how to recognize and how it works. Tumor antigen modulation, intrinsic quality of the immune cells. So the cells for patients heavily treated is not very well fit to be manipulated in labs, so you can have a very nice technology inside the cells, but the cells are not in quality function.
Recording stopped.
And okay, thank you. And the manufacturing development also, how you can...
Recording in progress.
Okay, I agree, you can record. And also the high cost therapy of this treatment, what can impact the access of patients for this treatment. So take our look directly for the solid tumors. So antigen escape is much easier to happen in this scenario than for hematology, malignant disease. On target of tumor, that means I have a very nice targets, but these targets is also in the health cells. So that don't happen normally with hematology disease, but for solid tumors, the majority of the targets that you know is also being expressed in normal tissue. So that permits to have side effects that you have to be careful with. CAR-T cell trafficking and infiltration. So how can the CAR-T infiltrate the microenvironment tumor? That's probably the most big issue and challenge that you have now. This microenvironment is very immunosuppressive for these cells. I like to say, imagine that you have a Formula 1 car. Your Formula 1 car is very high-tech and is high-speed car. But if you want to run the Paris-Dakar rally, you're not going to be able to do that with a Formula 1 car. So you have to change the T-cell fitness to work in microenvironment, and you're going to see some strategy that they're doing for that. At the same time, the CAR-T associated toxicities that now you're also learning about the middle and long-term CAR-T infusion. You can see the picture here of the microenvironment tumor that you know that much better than me. I'm a hematologist guy trying to treat patients through a cell therapy in solid scenarios. So, but this infiltration tumor microenvironment, it's very really the biggest challenge that you have now. You can see many different examples of type of cancer and also target antigens that you have in clinical trials around the globe, mainly in Europe and the United States, also in China. And here are some examples. The EGFR, for instance, the organ 1, MSLN, and LN for patients with solid tumors. And now I'm going to just give some examples what has been published in terms of more enthusiastic results for the future. They are not still fit to be, I would say, our routine management of our patients, but bring big hope for us for the future. This is a single dose of peripherally infused EGFR directly CAR-T, so you can treat a glioblastoma, GBM, with these CAR-Ts, and that's very interesting. This is the Carl June group, the pioneer of CAR-T in the world. And you can see how many patients were treated. And also here, 10 patients in your right, on the below right, you can see how long the patients were able to have your disease control, and the median overall survival of more than 200 days. So for GBM, this is a very interesting results. We have some images of representative 2 patients, 205, 209. You can see the baseline. And 1 month, 2 months after the CAR-T infusion, this is a peripherally infused CAR-T. That's important to say because you're going to have also some examples of intrathecal infusion of CAR-T for a CNS tumor. And you can see on the right that there is the tumor reduce your volume and almost 1 year after CAR-T infusion. So that paved the way to understand how CAR-T can work for CNS tumor, and probably that will be the first scenario that you're going to have a CAR-T approved for solid tumors. But you can also learn about this kind of study in GBM that even tumors in CNS, also the CAR-T and the T cells can be overexpressed by PD-1. So the cells, you become dysfunctional in terms of cytotoxicity, and that paved the way to understand that you need to have maybe combined strategy to reduce this dysfunctionality of the T cells here expressed by the PD-1 investigation. This is another one that is trying to merge 2 strategies. One is to infuse the cells intrathecal, because that would reduce the side effects peripherally. Is also you reduce the traffic issues, so the cells don't need to circulate it in the blood and then go through the brain. You can put that directly. And also the other gene delivery, interleukin 13, this is a very well recognized pro-inflammatory and cytokine, and that maybe be able to promote a more inflammatory environment and a more cytotoxicity on CAR-T inside the brain. And the cell dose will be less, 10 times less than the traditional dose in the peripheral blood. You can put the Oyajima valve, and you're going to do many different infusions until the patient gets remission. You can see the 3 patients represented here, how they were able to have a reduction of the tumor. This is another very interesting study, because now you use the GD2 CAR-T cells, another target, mainly for pediatric patients with CNS. And instead of being the interleukin 13, now is the interleukin 7, the other one very well recognized as pro-inflammatory, and you can see the image and also the results on the left below. The patients were almost 60 weeks with disease control, so Some patients respond, others not. The majority didn't, but the ones that respond, you need to understand what happened with these patients to use this learn for the next platform. So this is a Berkeley study that now we're starting to collaborate with us in Brazil. So we have just created the Cell Consortium. It's a collaborative consortium in Brazil of many different institutions, São Paulo University, Hospital Santa Marcelina, and Institute Oncoclínicas. We're going to develop with Berkeley, the preclinical study and also clinical study to treat pediatric patients in phase 1 clinical trial through the CR7, GD2, and CAR-T. And also we're planning to bring the anti-CD19 and BCMA CAR-T for hematologic disease. So this consortium has just started, and now we are planning to have new targets study for adaptive cellular therapy, validation of GMP protocols for clinical purpose, and then to launch, if for success, phase 1, phase 2 clinical trials. But what you have in addition to try to circumvent all these difficulties and challenges I have just shown for you, the CAR-T 2.0, the TILs and another platform maybe can be used, the TCR T cells and another one that is quite interesting, natural killer T cells, and many other types of cells can be used. Let's see a little bit about the CAR-T 2.0. This is called also armored CAR-T because you express the CAR-T receptor against the target to kill the tumor cells, but also you can include another 1 or 2 genes that are able to secrete any molecule like the PD-1 blocker, for instance, and or IL-7 or IL-13, IL-18. So there are many different proposed in this way. You can see from the CD19 platform, for instance, they put together the CD19, the delivery of interleukin 18, and the results for the CD19 was superior when associated with interleukin 18. That's why they are trying to change the platform for this kind of construction. Here is another very interesting because you have the CAR-T against the target tumor, but also you can see the CAR-T are able to secrete a PD-1 blocking at the same size, at the same site. They are connecting to the target of the tumor. So it's like you are using 2 drugs at the same time, but you're not. You're just using a very well genetic modified cells to do the same job. So that's quite interesting. And the results is a preclinical study from Memorial, and the results is quite interesting. These are moving to a clinical trial. This is another interesting for patients with prostate cancer resistant to castration. So PSMA is the target here, and but as this is well recognized as a cold tumor, so the TGF-beta has a very important role in the immune suppression of the microenvironment. So they developed this CAR-T resistant to the TGF-beta interleukin from the tumor microenvironment. And you can see here on the mice how that was able to kill the cancer, the prostate cancer cells. And this study moved for a phase 1 clinical trial, also from Pennsylvania group. And you can see here the PSA level, how the PSA were able to reduce. For 1 patient was negative. For 9 patients the reduction was superior to 30%. And also you can see the image how they reduced that. Unfortunately, the best response patient had septic shock infection and died with 1 month after the infusion, but other patients also had some response with this strategy. In terms of TILs, this in fact is the oldest platform for treated for adaptive cell therapy for cancer. For melanoma is the initial or the beginning of this with Rosenberg at NCI. So they created the TILs to treat melanoma patients, and the results is quite interesting. But this is a very, I would say, you need a very high level of expertise to manufacture these cells, so it's not a very democratic platform. But even like that, the live low cell was able to be approved by the FDA recently, treating patients with metastatic melanoma resistant for PD-1 blocking. And also for other scenarios like KRAS and mutation cancer, also other epithelial and renal cancer and breast cancer TILs can be used, but now is not still approved. This is only in experimental setting. Maybe the TCR engineered T cells are the most promising strategy for solid tumors. This is very important because if you get our human proteome, only 27, almost 30% are expressed in the surface of the cells. These are the proteins that are the targets of the CAR-T. But the majority of our human protein, in fact, is inside the cells. They are intracellular proteins. That means I need to process these proteins, these targets, and present for the T cells through a new TCR and MHC, so almost 80%, 70%. So these are why the TCR were developed. The first one that was very interesting in terms of results was TCR engineered T cells against the E7 for patients with metastatic HPV-associated epithelial cancers. In the same way of the EGFR studies for CNS tumors, these patients also have high level of PD-1 expression in your T cells. So maybe the best way is to go as associated or study with PD-1 blocking and TCR. You can see the partial response for the majority of the patient and the stable of disease. Recently, the MAGA-A4, the second one here, durable response for synovial sarcoma, like I would say 3 weeks ago, was approved by FDA to be used for sarcomas with like stable disease and reduce the disease for some patients. Other cells can be used, but I'm not gonna give you a lot of details, just the natural killer. This is another platform that is gonna be developed and has shown promising results too, but is still in the experimental setting. And just to finish, let's remember that the CAR-T is also a T cells. So you can manipulate these cells to polarize the T cells, or can use T cell subsets or immunomodulated T cells, trying to optimize these cells, and also you work with new CAR designs. Let's look at an example. This is my data from my postdoc at NCI that were not published, this data, but you can see on the left, on the up left, the cells from normal cells from a donor, blood donor, they were cultivated in the normal concentration of oxygen. But then you can put 1% or just for 48 hours and 72 hours. And if you look, the secretion of interleukins, you can see how different are these cells. So maybe these cells can be selected to be the best ones to go through the microenvironment tumors. You still need to continue to study the cells. Or you can use selected cells that you have already naturally in our circulation immune system, like the stem cell memory and the central memory cells. They're the best ones. You can see the stem cell memory here. There is a phase 1 clinical trial from Luca being running at NIH. These cells is much better than the, let's say, the majority of PAN-T cells that you use for cell therapy. In the same way, the central memory cells also are superior, and you can maybe use these cells for this. There are many clinical trials that you can have, including solid tumors using central memory or stem cell memory for that. And also there is the manufacturing variables that you have to remember, because each variable can change the results of the cells that you have. So if you change just one variable, the interleukin, for instance, you're using, your final product will be totally different. You can just give an example. If you freeze your cells when you harvest them during the collection or not, you can use a fresh cells at the beginning or frozen cells at the beginning. But at the end of the manufacturing, if you look the gene expression, you can see how different they are. So what that's gonna be in terms of clinical outcomes, you don't know yet. You have to wait. But only the procedures for freezing cells are able to change the gene expression of these cells. So you need to understand a little bit better what that you see impact the future. So two pictures as a take-home message. First one, just remember, CAR-T, TILs, and TCR are the most promising platform. There are many, many different ones, but these are the most tested until now. And we're still learning how to do the cells work with solid tumors. And the second one, there is no way that to develop the new adaptive cell therapy for solid tumors without modifying your cells. So the gene addition, the gene modification, you can have many different strategies, many different genes that you can add, many different types of vectors. Each one you give a new function or many different functions of to your cells to try to treat our patients. And probably in the future, will be the combined strategy. And CAR-T with chemo, with radio, with immunotherapy in general. So is that what I see for the future of cell therapy in solid tumors. Thank you so much for your attention and for the invitation.
Okay, so I can ask first question and stimulate discussion perhaps. So what we know in solid tumor, it's much more difficult than hematologic malignancy, mainly because you have so many complex pathways. And to find the right target, that's the main challenge. We have seen baby steps, as you alluded to a few of them. One was published in New England Journal, the KRAS-directed CAR-T, although it was a baby step because it was for very few patients in pancreatic cancer, actually, targeting the KRAS, etc. But this is a difficult task. And what we also have an approval, already approved drug, is a bispecific product, where in small cell we have one approved already, tarlatamab, which is targeting, DLL3 with the T-cell activator, and it was really a success story, and it's already FDA approved. So I think that's a challenge, is really finding for different tumors what is your best target. So how are you going to work around this? And do you think the bispecific story was the success we had in at least one of the most difficult tumor to treat, recurrent small cell lung cancer? Where do you think the future may be going?
Yeah, that's a great question because, for hematology, it's totally different, the rationale of these strategies, including the bispecific and the CAR-T. The bispecific has pretty similar results of CAR-T and malignant disease, but when you have I would say, disease in non-hematology tissues, so the CAR-T seems to be better than bispecific, but you still need results for that. For the solid tumors, it's exactly this situation. So the solid tumor is not located in the blood or in the marrow. So normally in the cells or the bispecific, but the immune system to destroy the cells, you need to traffic through the tissues until your target. And that's interesting to see because if you look at the T cells infiltrated in the tumor microenvironment, normally these cells are very dysfunctional. High PD-1, CTLA-4, TIM3, and etc. So my question is how the bispecific is going to work with dysfunctional T cells. And this dysfunctionality of the T cells can be solved with T cell engineer. So you can edit the PD-1 gene, or you can even deliver PD-1 blockades for the tissue and try to do that. But on the other hand, you can get the bispecific and maybe do a combined with a nivo or pembrolizumab. So that probably should be the same. We don't know what we're doing. what I can say is, and for the CAR-T, is an opportunity, not only CAR-T, but genetic modified cells, is an opportunity to give a cells with a different functionality that can persist for a long term. So it's quite hard to answer your question, because I guess all this verbal depend on your patient, how his immune system normally works, what you don't know too much, you need to learn. But mainly for the baseline disease, so if you're going to lung cancer be one strategy, you go to CNS, you'll be another strategy, so it's hard to define. The best is to have both, bispecific, checkpoint inhibitors, and genetic modified cells too.
And just like you mentioned, I think the point is the more you delay such treatments, the more you have your T cell exhausted, you know,
Exactly.
and less if you're giving chemo, radiation. And we've seen same thing in hematology. The more you give in a later line, you don't see as much perhaps efficacy as or less toxicity perhaps if you give it in earlier lines.
And maybe also that the genetic modified cells can be the bridge for other disease. I would say, like in the prostate cancer, is recognized as a cold cancer. And for one patient in this trial, they were able to show that the tumor, in fact, became a hot tumor after the CAR-T infiltration. So maybe this is an interesting strategy. They're not going to solve the problem, but it's the bridge for other. Yes, this is the bridge for other strategies that can be in the further time.
I'm Shabir Rana, hematology consultant. So I'm very interested with regards to the intrathecal infusion of CAR-T. And you know, they've done these trials, and I'm just wondering, because we do see isolated CNS relapses either with lymphoma or leukemias. Would that be a strategy that hematologists should think about, giving the CAR-T through intrathecal therapy?
Oh, intrathecal infusion is only for solid tumors. For hematology setting, you don't need to use.
We haven't seen it in any clinical trials so far, so that's why it's just quite intriguing for solid tumors.
Yeah, the first 3 pivotal trials for anti-CD19 CAR-T, the first 2, they didn't include patients with CNS disease for leukemia and for lymphoma, but the third one include. And it's fine. You have more icons, but it's manageable, right? And now with real world data, you don't have you have some concern for these patients, but that surely they can use CAR-T even with infiltration of the CNS, right? But for the solid tumors, the point was the traffic. That was the main point. And the dose was 10 times less. And not only one infusion, many different hits, many different infusion with a valve, and you can do many and follow the patient and see what will happen. So it's a totally different strategy. And what's interesting, because when you infuse peripherally these cells, even for CNS patients, they had 2 cohorts, one peripherally, another one intrathecal. And what they were able to show is, for peripheral, you have more CRS because the cells are circulating until arrive to the brain. So you have better results and less side effects when using a trickle infusion. So probably the next clinical trials will be all done like that, right? Yes.
It's only just recently that they've been with good results.
Yeah, but for solid tumors, but also for lymphomas, when you have a big mass, you have to be careful, because the first phase of after CAR-T infusion for solid tumors in CNS is the inflammatory response. So you can have a bigger mass, and now you can hypertension, intracranial hypertension, and everything together. So maybe you do a radiotherapy before some.
People can then progress with
right.
Exactly. Yeah.
Maybe one last question, quick one. Thank you for a great presentation, very comprehensive. I noticed on one of your slides, for dual targeting. Did I see a CAR T targeting CD7 and GD2? Is that a dual targeting CAR T? And if so, what was the rationale on the cell consortium with Baylor, the work with Baylor?
Yes, sorry, I talk very fast at this part. It's not a dual target, in fact. The target is the GD2, but the CR7, in fact, it's not a target from the tumor, but is a sensitive receptor of the T cells. So they are able to be sensitive for the interleukin 7 for the microenvironment and be more inflammatory in this way.
Right, so it's an IL-7, not CD7.
Yeah.
Okay.
Yeah, they call it C7R, but it's just the name they put for the CAR T.
Right, it's membrane-bound IL-7 just to proliferate. Okay.
Exactly.
And just final question, thoughts about autologous versus allogeneic CAR Ts? I know that it's a big topic here. What are your initial thoughts about it? I know that there's all 6 approved CAR Ts are autologous, but there's a lot of clinical trials with allogeneic CAR Ts. Any thoughts?
Yeah, that's interesting because the allogeneic CAR T, they're trying to be developed because mainly 2 reasons. First of all, the T cell fitness, the quality of the T cells. If you use allogeneic donor, so you're gonna have cells from the normal donor, so the quality of the T cells is really better than the patient cells. The other way is CAR T is very high cost treatment, so you don't have a scale because it's a very personalized treatment. It's autologous treatment. It's 1-by-1 treatment. But if you are able to edit the TCR with a CRISPR-Cas9, for instance, you can produce allogeneic T cells for the shelf, and then you can have a high-scale production of that. That's fine. You have already phase 1 clinical trial working, but when you delete the TCR and the proliferation and the activation of T cells are not the same. So you still need to put something together to see what will happen. But that's probably, in my opinion, is the future. Okay?
Sorry, just one question, please. So with this new generation CAR T cell, we can see that we manipulate more the T cells before the treatment. Do you think we can face more risk of secondary cancer CAR T cell, like lymphoma and leukemia?
Yeah, that's very nice. Another very nice question because it's a very hot question. People are discussing that a lot because the genetic toxicity is a concern for the genetic modified cells. That happened majorly at the beginning for the immature cells. So if you get gene therapy that you use the stem cells, so very immature cells, the chance to have secondary malignancy is higher. You saw that for sickle cell disease gene therapy, like leukemia, 3 cases like that. And for CAR T, it's a little bit different because these cells is already mature cells, but even like that, the secondary malignancy came out in this scenario. But the majority is related for the history of the patient treatment. So they are very heavily pre-treated patients with chemo, with radio, and as this patient used to die before the CAR T, now they are living for 5 years, you are able to see the cytotoxicity of this strategy before CAR T for this patient. So the majority of secondary malignancies were not related for T-cell malignancy. But recently you have also described, was published at New England Journal and also Nature Medicine, a review with all these cases for T cells. And for some of them, you are able to see the construct of the CAR T inside of this T cell. So it should be that it's possible to have a malignant lymphoma or malignant T cell leukemia related to CAR T, but that is less than 1% of incidence. And if you consider the whole scenario of this patient is still an effective treatment, and FDA just mentioned that as a concern, but you can continue to move away. It should be that the multiple myeloma patients, they are more impacted for secondary malignancy. Right.
think if no more questions, we need to move on. Thank you very much.
Thank you. Thank you.
Okay, so it's my great privilege. We're going to change gears a little bit because I think there's some problem with connection with Dr. Jean Sheikh. So we'll move to the CML talk. First of all, great pleasure to introduce my partner in crime now. So Dr. Shabiha Rana, she is well known in the hematologic malignancy fields. And we are lucky to have her at King's College Hospital, London, Dubai now. Obviously, she has trained at Royal Marsden, I guess, or been there, and has many accomplishments in the field of leukemia, lymphoma, myeloma, amyloidosis, etc. And we'll see what she has to say about recent advances in CML. Thank you. Dr. Shabiha.
Thank you, Dr. Hassan, for a very kind introduction, and thank you for organizing committee to invite me to come and talk about CML, a great topic. And so I've kind of changed the name of the presentation at my own will, calling it Journey Through Time to Precision Medicine and Beyond. So I have 3 girls, but those who have boys, I'm sure know very well about the Toy Story and Buzz Lightyear. So I think this is where it actually came from. And I think we are in the era where things have actually changed from the century in 2000 when imatinib came into perspective and changed the game for CML. So what do we actually talk about today are updates in CML management. And just to brief you, I'm sure all of you know that CML is a myeloid malignancy. It's a cancer of white cells, predominantly raised by a mutation. It's a translocation between chromosome 9 and chromosome 22, when part of chromosome 9 actually translocates and adjacent to chromosome 22, causing this BCR-ABL mutation, which creates the fusion protein, which then drives the CML production, or the CML disease itself. What's the worldwide incidence of CML? It's pretty high in terms of all leukemias, about 7%, but considering other leukemias, it still takes a little bit of a backseat. But we must remember the incidence increases with age, and so does the mortality. What are the treatment goals for patients with CML? Most of those being diagnosed in the chronic phase. Now, people can argue about a lot of things, but I think to me, the main goal still remains to improve survival and quality of life. In the era of modern medicine, as we talk about, I think the goals that we cannot ignore with newer therapies and TKIs that we do talk about are to achieve major cytogenetic response, early molecular response, and a deep molecular response. And these are some of the targets that we do strive to achieve, and NCCN and ELN actually have produced these very stringent criteria for the response assessment of CML patients. So at 3 months, whoever you start on whichever agent, you need to get the BCR-ABL transcript level on IS score of less than 10%. Anybody more than 10% is actually either considered to be in the possible TKI resistance. Give them another 3 months, and if they still do not respond, they become TKI resistant, and so on and so forth. So you need to aim and target the response assessment between 1 to 10% within the first 3 months, and subsequent to that, we have 6 months target score and then 12 months target scores. The main concern that we have for any of these treatment-resistant or possible TKI-resistant concerns is actually the compliance of the patient. So the adherence to the drug and drug interactions and drug tolerance remains the first priority. Whenever we do see a patient, particularly in the last, I can say in 24 years, we do ask the patient to remain compliant to the medication. Whichever agent you give them, the first generation, second generation, third generation, the adherence to medication is the prime goal to achieve a good response, which is as in different timelines. What do we see in terms of the treatment lines that are available? We have the first line agent, imatinib remains the gold standard, which actually came around at the turn of the century. And since then, we have the second generation TKIs, and we know all the names with bosutinib, nilotinib, dasatinib. Second generation treatments approved initially like anything else for relapse refractory disease, and subsequently they've taken the front seat in the first line response as well.
Third-line treatments are also available, much more so in much more resistant disease, particularly with T315I mutations, where ponatinib and asciminib have taken the seat for response. Interestingly, allotransplant used to be the main treatment goal and idea for patients to bring into remission in CML. This is pre-2000. Now we do consider allotransplant, and considering that I'm a transplanter, but I have not transplanted a CML patient for, I think, more than 18 years. The last transplant we did in the UK was in 2007. So moving on to the lines of therapy that we have, we do talk about sort of, different lines. I've purposefully omitted imatinib because much has been talked about, but there will be some slides that you will see where these drugs have been compared as a first-line and second-line drugs and the response assessment. So dasatinib has been approved and called Sprycel for first-line treatment in patients with newly diagnosed chronic myeloid leukemia, in patients with CML in chronic phase, blast phase, or accelerated phase, particularly who are resistant or intolerant to the prior therapy. It is also licensed for patients who actually have transformed CML to blast crisis with AML now. Pediatric patients also get this with newly diagnosed Philadelphia positive CML or CML Philadelphia positive chronic phase, which is resistant to prior therapy. And the pivotal study, which actually brought dasatinib on the landscape, is DECISION. DECISION was an open-label sort of a trial comparing dasatinib and imatinib 400 milligrams, that's the standard dose. And you can actually see the cytogenetic response at 12 months is much better for dasatinib compared to imatinib. This is how the molecular responses were noted as well. So there is somewhat difference in the dasatinib arm compared to the imatinib arm, including the major molecular response as well. Secondly, we move on to bosutinib, which came out with the BELA trial, which was in relapsed refractory setting, but in the first-line setting, it's been approved and compared with imatinib in the BEFORE trial. So it is also approved in the newly diagnosed first-line CML patients with chronic phase, and also for refractory or intolerant patients with the prior lines of therapy as a second line. So this was the BEFORE trial that led to the approval of bosutinib in the first-line setting. Bosutinib was used as 400 milligrams daily compared to imatinib. And you can actually see the MMR at 12 months in BEFORE study, which showed an improvement for bosutinib arm compared to the imatinib arm. Here you can also see the MMR, or the molecular response, is better and in favor of bosutinib. Even the 4-log reduction subsequently to 4.5-log reduction is much better in the bosutinib arm compared to the imatinib arm. Next is nilotinib. It's approved initially as again for ENEST relapse trial, but again move on and took the seat in the first line for ENEST ND trial for CML chronic phase patients. And what we actually saw as part of this trial, quite promising trial, was higher rates of MMR, deep molecular response, and major molecular response, or 4.5-log reduction, much better in nilotinib arm compared to imatinib. It did have lower rates of disease progression versus imatinib, although it did carry slightly higher frequency for cardiovascular events compared to imatinib. So this was a trial where it actually was randomized 1:1:1 with nilotinib 300 milligrams BID versus nilotinib 400 milligrams BID and imatinib 400 as a standard dose. And really, I mean, what you could actually see that, the majority of the patients achieving the major molecular response by 1 year was much higher compared to imatinib. Here you can see the median time to first response of first MMR was much shorter with nilotinib compared to imatinib. Also, the median time to achieve the 4.5 log reduction is also much better for nilotinib compared to imatinib. Now, the biggest target or biggest problem that we see with patients is the adherence to drug. And really, in terms of what we actually see, that these trials have actually shown us a very good improvement with major molecular response by 1 year, 2 year, and even 4.5 log reduction, much better in terms of the second line responses. But we still see about 60% of the patients can either become intolerant or resistant to the drug. And these are two different issues that, they might be different in comparison to the patient's priority of intolerance versus for the patient, for the physician, the resistance becomes more of an issue for the drug. Now, we know that it's a chronic disease and requires long-term therapy, probably lifelong, and patients with CML need treatment which optimize their efficacy, safety, and tolerability. which is one of the prime goals in patients who require long-term treatment. So the relative survival of these patients with CML, particularly in the chronic phase, we see that they do better in terms of the duration of treatment. The longer the treatment, you actually can impose more side effects and can affect the long-term longevity of their quality of life. So the treatments that result in rapid molecular responses are needed. So we want an early molecular response. We want a deep molecular response in the quickest possible time. And if you actually see that these patients who actually achieve a quicker response need to do better, and that has remained the line of thinking about the TFR, or treatment-free remission. Now, how do we achieve these goals and targets? So far, we have been playing around and using the ATP competitive TKIs, which unfortunately do have off-target side effects. And these are quite important in particular drug groups, particularly nilotinib, with cardiovascular risk assessment and side effects. Dasatinib with pulmonary effusion or pleural effusion. Ponatinib, again, has increased cardiovascular cytotoxicity. Bosutinib, whoever you start, I'm sure whoever you've treated, the first 2 months are terrible with diarrhea. So each drug comes with its own baggage of side effects, and I think switching to another ATP competitive TKI can lead, due to either intolerance, may not lead to improvements in adverse events or quality of life. So what do we battle with? We battle with intolerance and resistance as the primary discontinuation reasons for these patients. And we actually can see that up to 63% of these patients actually can discontinue the treatment either due to side effects, about 30% of them actually come off because of side effects, and almost half of them, 15%, can come off due to lack of efficacy. And if you actually do the treatment switching because of either reason, due to intolerance or resistance, you might actually not see a great achievement, but you see that here patients who actually need treatment, they can either stay longer on or limit unnecessary TKI tox switching due to development of treatment-resistant mutations. With imatinib, you see that there's almost 25% resistance and 25% intolerance, and that varies between different agents that you use. Dasatinib has a lot of intolerance because of pleural effusion, and hence so on and so forth with nilotinib with cardiovascular toxicity. Now, this slide is important and gives us an idea about the adherence to treatment. If a patient adheres to the treatment, you can actually see much better molecular response and major molecular response, including some CMR. But if the patient starts to defer the treatment or becomes poorly tolerant or not adhering to the treatment, this actually reduces their overall response assessment. Now, where we are in terms of my title of Infinity and Beyond, I think where we are looking at another sort of a new kid on the block. As it starts from the relapse refractory setting, and now it's taking the first line setting. And asciminib is nothing new. Recently, we've been speaking about it quite a lot. But I think there's a landmark study published in New England Journal of Medicine. It's still in press, so clearly hot off the press. And that's looking at asciminib for first. So as for first trial, this actually looks at asciminib versus investigated tyrosine kinase inhibitors in newly diagnosed patients in CML. And this is the study design. So you're looking at the CML patients who are newly diagnosed, no prior lines of treatment, more than 18 years of age. They are selected and randomized to TKI. Now, this was an investigator-selected TKI in collaboration with the patient. So the investigator discussed the line of therapy or TKI choice with the patient, and the other, obviously, the experimental arm was asciminib. With this, what they did is actually they created a stratum for imatinib compared to asciminib, and then the second-line TKIs with asciminib. It's interesting to see that most of these patients had a lot of similarities in the data, but you could actually see that patients who are between 65 to 75 were slightly more skewed to imatinib, maybe because of those patients of their age. They had high cardiovascular risk score and lower ELTS, which is the Utah score, may reflect patients' preference for imatinib, not to asciminib due to their sort of trial comorbidities. And in the treatment lines, when you actually see, this looks maybe complicated, but I think that the take-home message from here is that there was much less discontinuation rate of asciminib in the patients who were treated with asciminib and are continuing with treatment. Almost 85% are continuing the treatment while being on asciminib compared to any of the TKIs. So the first blue box from the second box, which is the darker blue box, which is imatinib. So almost 36% patients discontinued, and in the second generation TKIs, almost 23-25% patients actually discontinued the TKIs. Now here again, it kind of emphasizes the discontinuation or the disposition of patients, that whoever was on the treatment, almost 13% of patients which discontinued asciminib was almost half of the patients who actually were on TKI. So 30% of the patients discontinued treatment while being on TKIs compared to 13% while being on asciminib. And here you're seeing very promising sort of results as a result of this first trial. Was major molecular response at 48 weeks was superior in the asciminib arm, which is the aqua green color, compared to the blue color, which is all or any TKI. Again, in the second, the darker green box is the asciminib comparison with imatinib. So again, you have a better response with the first-line TKI here as well. Secondary endpoint from the trial was major molecular response at 48 weeks with the second generation versus any TKI. So again, you're seeing somewhat better response with asciminib compared to any second generation TKI, 66% versus 58%. The molecular response, how early are you able to achieve, and is it actually worth mentioning? Yes, it is, because even early molecular response, the BCR-ABL target of less than 1% at 1 year, molecular response of 4 log reduction with MR, and 4.5 log reduction is all in favor of asciminib arm being used as the first-line agent. Again, molecular responses for asciminib in terms of all of these lines that we talked about are more in favor of asciminib. The overall or overview of side effects, yes, anything and everything that comes with efficacy and possible tolerability will have some side effects, but we see an overall proportion of these side effects more than grade 3 are higher in patients who actually are on second generation TKIs. With any patient of asciminib, the side effects of more than 3 grade or third grade adverse events are much less in the asciminib arm with a better tolerability, although the discontinuation rate is also low for asciminib, and leading to the adverse events which actually led to dose interruption or adjustment was also much lower in asciminib compared to the imatinib or second generation TKIs. Thrombocytopenia is an expected side effect with asciminib compared to all other hematological toxicity or side effects that we see, but it is relatively manageable. The non-hematological toxicities, I think majority of patients could actually report some diarrhea and some elevation in the transaminitis levels compared to the second generation TKIs or imatinib, where the side effect profile, the diarrhea and other risk factors, as we know, are much higher. So arteriocclusive events, it's interesting, and I think it's worth mentioning that as we know with nilotinib and ponatinib, the arteriocclusive events are well reported, and hence the dose of ponatinib actually was adjusted because of these side effects. The events here reported are relatively low in the asciminib 4 trial, although the trial, I think, still needs to go through a lot of follow-up with the longer exposure, and we could actually hear more about this if we can actually get more side effects, particularly arteriocclusive disease in terms of atherosclerosis, hypertension, myocardial infarction. Over time, what do we hear and get? So, in summary, CML, I think it's one of the greatest prototype of the drugs and has changed a lot of outlook for not just hematological malignancies, but a lot of solid tumors as well. Because of the molecular change and targeted therapy has actually, the credit has to be given to CML, how things have changed in the treatment of cancer front. Asciminib here now demonstrates superior efficacy versus all standards of care versus in the frontline TKIs. As you could see, the asciminib 4 first trial actually achieved both primary objectives with demonstration of superior MMR rates at 48 weeks versus all investigated selected TKIs, and also showed superior MMR rates at 48 weeks versus any of the trials, particularly also comparing the imatinib stratum. It has a safety profile which is rather favorable, and favorable tolerability profile as well, with fewer grade 3 or more adverse events. And with this, I thank you all, and thank you for your time and attention. I know, that's the other way around. I should be asking Dr. Hassan questions.
One question, then we'll open the door. So, as you mentioned, this is a typical disease where we have a target. Since we're talking about the CAR-T, this is a prototype where you have one only target that if you hit right, the disease is gone. Unfortunately, we don't see many of these diseases that have one, directly one driver. So my question to you, okay, we have now 5, maybe coming 6 first-line approvals, and of course, cost is completely different. Imatinib now being the generic and the cheapest. And if our aim, has kind of shifted, we are always greedy in oncology, that, okay, when we had imatinib, that's the best ever thing brought to humanity, but now we say, okay, we want to achieve a complete molecular response. Before, anything close to a CCYR was enough, and that associated with better survival, etc. Not as much now. It should be the aim, correct me if I'm wrong. So should our goal of therapy be really reaching that deep molecular response and ultimately trying to stop therapy, the TFR duration, etc. And with that, we have certainly 5-6 years with nilotinib and dasatinib, not as much with imatinib, and we don't know about asciminib. It's still too early. So if you're facing Monday morning with a new patient, how do you discuss these issues with the patient, and which drug would you choose?
So I think I'll start the answer. So we, as pure hematologists, we target one target at a time. So we target BCR-ABL, then we target FLT3, then we target IDH. So we go after one mutation and put everything towards it, rather than dealing with a lot of it at one particular time and shooting in the dark. So I think the first and foremost important sort of parameter for hematological response is, yes, to get a better molecular response. And I think the target should still remain the same. The ELN guidelines and the NCCN guidelines put a lot of emphasis of achieving that target with an early response. So I think the first 3 months characterizes it as an early response. So if you are able to achieve an early response, less than 10% or better, you are clearly on the right track. Will you achieve it with the first line or with the second line? I think that remains the choice between you, like as a physician, and a patient discussion. And I think you have to be quite open, which I do discuss, all the agents when the patients do come in. We discuss all agents with pros and cons and the side effects, and the decision has to be a combined decision. So patients, if they want to choose imatinib because of a younger age group, they have a lot of years ahead of us, and you're very well aware that the dynamics are in this part of the world. We have a lot of younger patients, and we do discuss, and we do worry about it. I personally do worry about pleural effusion. I do worry about cardiovascular risk groups, risk factors for these patients. So internally, I'm a bit more leaned towards imatinib, but in order to achieve an early molecular response, I do offer these other drugs because they have shown to be better in that situation. Also, in terms of the drugs which I think the most important thing is that we know that all these drugs actually have a clonal evolution. And there would be some resistance, or some new crop will come up and that will throw you off. So whether it be T315I mutation or any other drug resistance. So I'm very pro that the first hit has to be the hardest hit, the best hit. But at the same time, I'm mindful that if the first sort of reflection of the patient is not as resistant and I'm getting a better response with any of the other drugs, I'll probably reserve asciminib in a way that, okay, maybe put it when the mutations come, because that's better, and the patient is in a position to tolerate this because he's been through the worst mill. Now we want a quicker response in the second line at the first relapse. And what the patient's actually looking for is the longevity at that time as well in the second line treatment, because as a patient, one would fear that I've failed the first line anyways. Now I want something which will make me survive longer. I don't want the disease to progress. So I think that's another of the treatment goals for the patient.
So let me be on the other side of the discussion for the same thing you mentioned. Okay, but if I'm a young person and I want a quick response and a deep response, because that's associated with much lower rate of future mutations. That's another point we didn't dwell about, but those who really are in deep molecular response, it's very unusual, less than 5% that they're going to evolve into something else versus the one who are kind of on the margin. Or exactly. So why not, especially for younger patients who can tolerate these side effects, why don't we hit them harder in the beginning with the idea that in 3-4 years' time, they may be eligible to be in that deep molecular response and stop therapy altogether. And where we are afraid of the elderly of cardiovascular or pleural effusion, maybe those we can try the imatinib. And by the way, the data on imatinib at 3 months or at 6 months, about a third of patients at least, they are not going to hit those milestones that are set. So you are already destined those 35 to 40% to go to a second line, and anytime you go to a second line, it is not as rosy as when you hit them hard from the beginning.
Correct, I agree. And I think at that time, it's more of the risk sort of factors that you deal with the patient. So, smoker, male, a lot of other comorbidities coming along, that will sway your decision. Dr. Marwan.
Yeah, thank you very much for this very nice presentation, and excuse my ignorance for my question.
Don't worry.
As we are discussing those 5 or 10% who might not hit this deep molecular response, do we have any clue on a precision signature at the beginning, at their presentation, if we do for them next generation sequencing or any kind of screening mutations? Do we know who are these patients who will not hit this deep molecular response, because it will help us in our decision?
So it's a very, very good question. I mean, at the moment, we are doing the basic BCR-ABL translocation test. We are doing the cytogenetic test. And most of the time, thankfully, we don't find any other cytogenetic variant. And that gives us, straightforward CML, easy carry on. I don't know if anywhere else you're doing any NGS. We are not. No. So we're not doing NGS for these patients. And I think, it would help, and probably in future, we might be able to do that. But I think we had a good question, do I do a bone marrow on CML patients? I do. And that's kind of like primarily the reason that I want to make sure that, there's nothing else as a variant cytogenetically.
Yeah, I mean, if you have translocations like isochrome 17, trisomy 8, those will put those patients at higher risk. Also, we have clinical criteria. You can say low risk versus high risk based on platelet counts, based on spleen size, etc.
And basophils and all, yeah.
So yeah, there are certain clinical points you can make you at high risk or lower risk. And there is something called accelerated phase. I don't know, you're not into the hematology, but we can divide into accelerated phase versus the true chronic phase, CML.
Correct. So accelerated phase, with the newer classification, is disappearing.
Exactly.
It's becoming chronic phase and then blast crisis. So, yeah.
Any questions?
Amna.
Now, because we're using second generation anyway for almost all our patients, so do we really need to risk stratify them at the beginning? Because everyone almost receives.
She doesn't. She said she's leaning toward
I'm still old school. I might not look it, but I'm still quite old school. So no, I think it's just internally, it just gives me a little bit of a satisfaction. But I think you're right. Where we are, we have to achieve the early and a deep molecular response. And I think scientifically we are much more based and targeted towards that. So yes, I agree.
Thank you.
Change your mind. Say, okay. I think, thank you in the interest of time. Well, thank you.
First, thank you for everyone who's still here, despite that it's too late. So it gives me a great honor, actually, to introduce our next speaker. Our next speaker will be Dr. Jean Sheikh, who's an associate professor of medicine and clinical hematology bone marrow transplant at the AUBMC. Dr. Jean Sheikh has extensive experience in acute hematology transplant, and he's an excellent researcher. He's published a huge amount of research in hematology and bone marrow transplant. Before starting the talk about the chemotherapy-free regimens in acute lymphoblastic leukemia that are Philadelphia positive, we're really thankful to Dr. John, who's joining us virtually from Beirut, despite the war, the bombing, and everything that's happening there. Dr. John, please.
Thank you so much for the invitation. I was very happy to be with you in Dubai. Unfortunately, as you said, the situation in Beirut is very tense and very dangerous for everybody. We hope we will be better in the next future as soon as possible, and everybody will be safe. I want to thank the organizer for this beautiful meeting, and my topic today is to talk about the new era for the chemotherapy-free regimen and the treatment of Philadelphia-positive acute lymphoblastic leukemia. As you know, the acute lymphoblastic leukemia is one of the poor prognosis acute leukemia worldwide, mainly in the pediatric population. However, we have a slight increase in the elderly population after 60 or 65 years old, which is this population is a population with comorbidities, not eligible, not fit for transplant. So it will be a more complication for the treatment of this disease historically. As you can see, the incidence of BCR Abelson rearrangement according to the age, you can see the many or the most of the patients are in the older age range. And the survival of acute lymphoblastic leukemia improved in the last 20, 30 years. And the pediatric population increased in 20%. However, for the elderly population above 60 years and above, the improvement is really minimal, only 4% improvement of 5-year survival. What about the current treatment of ALL? ALL Philadelphia negative and Philadelphia positive. You can see in different cooperative group in Europe, in US, the Italian group, the French group, the Golams, the MD Anderson protocols, and the Lala French group. The percentage of Philadelphia positive is almost the same, around 17 to 23% of all Philadelphia positive TLL, almost the same percentage. And you can see in the right of my slide, the disease-free survival at 3 years, it's around 30, 35, maximum 40%. We have a new option, therapeutic option actually to treat not only the Philadelphia positive chromosome Philadelphia ALL, but also for the BALL, pre-BALL Philadelphia negative. We have this new option called the BITES, or the B-specific T-cell engager. In this case, I will talk maybe about the blinatumomab, the anti-CD19 combined to CD3. The blinatumomab has this option as a bridge between the T cells and the leukemia cells, CD19 positive. The CD19, as you know, is highly specific of as a B cell markers expressed through the B cell development, and almost more than 90% of B cell lineage cancers, not only in ALL, but also in non-Hodgkin lymphoma and many other diseases like CLL and so on. So the Philadelphia positive ALL treatment had a stagnation in the last 50 years. However, with the introduction of the tyrosine kinase inhibitor, we had some hope recently. But historically, the only chance for this very poor prognosis disease, it was the allogeneic bone marrow transplant when the patient is fit, eligible to transplant, and the other hand, when the patient had an optimal related or unrelated matched donor. However, the complex cure rate for this disease it was between 25 and 50%. Outside the transplantation, the outcome and the prognosis and the survival of this disease was very, very poor. The introduction of the first generation tyrosine kinase inhibitor like imatinib modified and transformed revolutionarily the standard of care in ALL. We have more complete remission rate, more eligible patient for transplant because we reduce the intensity and the duration of the chemotherapy with the introduction of imatinib. We have more and more number of patient survivor without BMT, those patients not eligible to transplant or maybe without a possible eligible or compatible donors. In this classical figures, you can see the patient who received a transplant had an optimal 3 years overall survival, almost 37%. However, the patient without donor had 3 years overall survival at 12%. In many different studies, in the French study with Hervé Dombré and the Lala group, and the US group, and many studies also in the MD Anderson showing the only possibility of care in this patient was the allogenic bone marrow transplantation. In this UK MRC group study, over almost 1,000 of patients, you can see in all
Dr. John, I don't know if you can hear us.
For the group without a donor.
Dr.
And
John,
when
can
we,
you please,
Dr. John, 41 to, yes.
This last slide you were disconnected completely, so if you can just start over this slide only.
This slide? Okay.
Yes, only this one.
Okay. So sorry for this interruption. I repeat for the UK study over 1,000 patients. You can see for the patient who had a donor had a better outcome, 53% compared to 45% the patient without a donor. However, when we split the patient by risk, the patient with a standard risk and had a donor had a better outcome, 63% compared to 52%. And for the patient with the high risk, you can see there is no difference between the patient with or without a donor, 41 compared to 35%. The transplant for the Philadelphia positive ALL, so historically, the study of Dombré and Goldstone, 34, and the more recent study by Adele and group, you can see there is a high impact for those patients who had a sibling matched donor, 44% survival compared to 35% for those patients who received a transplant from matched unrelated donor. And as the survival for the patient without a donor and who received only chemotherapy, the 5-year survival was only 19%. So the only hope for those patients before 2010, it was the allogenic transplant from any kind of donor. Well, later on, we had the imatinib era, so the first tyrosine kinase inhibitor, and you can see when we compare before and after the imatinib, the survival increased from 22% to 34%. On the other hand, we have a higher in the MD Anderson experience, adding imatinib to ipercibat, the classical protocol that we are using actually in our institution. We increased the rate of the complete remission to 93%, and a complete molecular response also increased. The estimated 5 years of disease-free survival was 43% for patients who achieved a complete response. So we have without the transplantation, almost the same survival rate when we add imatinib to the ipercivat regimen. The other point that I want to discuss with you is the status of disease. It's very important, the status of disease in transplant, not only in Philadelphia but in all the type of factor. The patient who was transplanted with a first complete response had a better outcome compared to the patient who didn't achieve a complete response and was transplanted, had the 3 years overall survival of only 9%. It was a Japanese study. What about the improvement over the last 30 years in MD Anderson? The Philadelphia positive survival, you can see, increased from between 1984 and 2000. The 3 years overall survival 13%, 5 years overall survival 9%, and actually we have the 5-year overall survival when we are using the blinaPONA. I will want to talk about this combination later on, the so-called chemotherapy-free regimen. We have 3 years overall survival 89%, and we didn't reach the 5-year overall survival, the median. So which is a revolutionary result compared to 20, 30 years before with all the type of combination therapy. The imatinib was really a game changer for the treatment of this poor prognostic disease. In this table, I put the different groups study, the Korean, the American, the French GRAL studies, the Spanish PETIMA study, and so on. And I want to highlight the overall survival with the ipercivat and different combination of chemotherapy based on vincristine, prednisone, asparaginase, the ipercivat without asparaginase. You can see the overall survival at 2 years between 60 and 70%. And the transplantation was 50 to 77% in different study group. The complete response, you can see when we add the imatinib, reached more than 90 to 95% of the patient achieved a complete response. However, when you see the PCR negatives, the MRD negativity is still lower compared to the previous studies. And you can see that this PCR negativity is between 40 to 85%. So I want to talk about the idea of this combination to leave behind us the chemotherapy regimen, the different complex, a very complicated regimen of ALL treatment. And we need to discuss the objective of this combination. Really beautiful partner, initially with the Italian group, Robenfoa, started to combine blinatumomab to dasatinib, the second generation imatinib, second generation tyrosine kinase, sorry, to reduce the Tregs promotion, a marked proliferation of immunocompetent, not only the T cells, cytotoxic T cells, but also the T-NK cells and the NK cells in particular. So in vivo, this combination had a potent modulation on the host immunosystem, and most likely it's a contribution to block the proliferation of the tumoral cells and to be able to give the same potential chemotherapy effect. This modulation of immunocompetent cells occurs also in patients, let's say, elderly or more elderly, above 60 years old, with Philadelphia positive ALL. And as you know, in this population, the majority, as I said before, had multiple comorbidity, not eligible to transplant, or maybe not fit to receive an allogeneic bone marrow transplantation. So the idea was to give a soft treatment without chemotherapy, and to see the ability to if we are able to cure the disease without the allogenic transplantation. So in this publication, a beautiful paper by the Italian group, Gimema and Robin Foa, published 4 years ago in New England, 63 patients, median age 54 years. They used dasatinib 140, so high dose dasatinib combined to 2 to 5 cycles of blinatumomab. The primary endpoint was after 2 cycles of blina to reach a molecular response was reached in 60% of the cases, and 53 post-dasablina 2 cycles, the molecular response was 60%, CMR 41%, and we have some patients with MRD positive. In those patients, 6 patients had the mutation T315I, and 8 patients had a relapse in CNS. In this study, they didn't use the intrathecal chemotherapy, the classical intrathecal treatment for the patient with ALL, either Philadelphia positive or negative. So the update, I received this recent update and follow-up from the ALBA protocol, and you can see the overall survival after 4 years, 81%, and disease-free survival 76%. Median follow-up 53 months, and 50% of the patients treated with a TKI blinatumomab. You can see 98% of the patients obtained a high CR. What about the post-blinatumomab treatment? 29 of those patients, I'm giving the update and the follow-up of the New England paper. So 29 continue.
Dr. John?
Continued the tyrosine kinase treatment. 21 dasatinib.
Dr. John, we cannot hear you. They all disconnected.
Hello?
Yeah, Dr.
Hello,
John,
hello.
since the start of the slide, we could not
Are
hear
you
you.
hearing?
The connection is not very stable.
Me? Yes? Hello?
Yes, doctor, we can hear you now.
Okay, I'm sorry. I'm sorry, we have a very bad connection the last day during the war in Lebanon, and we are facing a lot of problem with the connection. I'm so sorry, and I will hope to finish my presentation. So I repeat, post-blinatumomab treatment, 29 of those patients continued tyrosine kinase inhibitor. I'm talking about the follow-up and the update of the study, the ALBA, published in New England Journal of Medicine. This data is not published yet. So 29 allografted patients, 55% of the cases after 2 to 3 cycles of blina, received transplantation. So the update showed us that 30 patient or 50, more than 50% of the cases was able to proceed to transplantation, either because they didn't achieve a complete response, or maybe the performance status initially at diagnosis was not excellent, and with this treatment improved, we found an haplo donor later on. So the transplantation in this group remained an option and possibility for almost 50% of the cases. What about the update? This update was published in GCO last year, and you can see the overall survival 73% for the patient not transplanted and 71% for the patient who did the transplant. However, the disease-free survival, you can see 89% for the patient who had transplant compared to the patient who didn't receive a transplant, 70.1%. I repeat, the patient who received the allotransplant were the patient with MRD positive, patient with maybe poor prognostic factors compared to those who continued the classical regimen, blina, dasatinib. I want to highlight also, dear colleague, that the transplant-related mortality for those population and first complete hematological response was 12.5% only. The overall transplant-related mortality is only 13.7%, which is I know we cannot accept the toxicity. However, this rate or percentage of TRM was very, very low. So what about the take-home messages from the ALBA studies? So our 4-year result show that the feasibility of the chemo-free induction and consolidation approach is feasible, translated into a very good result and very low transplant-related mortality for those patients who proceeded to transplantation. Patient in molecular response had so far no relapse after 4 years, which is very reassuring. The combination induced a marked in vivo host immune response, and the IKZF1 plus remain unmet need. We need more novel strategy urgently. Maybe we need more targeted therapy in combination. And we have the main problem, it's the CNS prophylaxis with the intrathecal, because we have a high CNS relapse in this chemo-free approach era. And the transplantation has a very an excellent impact on the MRD negativity and MRD positive case. So far, not significant. So the chemotherapy induction and consolidation strategy was a bonus during the COVID-19 pandemic era, because the study was done during the pandemic era. So actually, we have the new protocol, the GMEMALAL 2820, a new trial, phase 3 trial. The sample size to 236 patients, adult patient, randomization 2-to-1, ponatinib plus blinatumomab versus imatinib plus chemotherapy. So we can discuss a lot about this two group. However, we need to see the difference in pona-blina versus imatinib chemotherapy, and we have the possibility of crossover to experimental arm if patient remained MRD positive. The concomitant BCR Abelson and IGTR screening for MRD evaluation, and the host immunomodulation also with ponatinib, blinatumomab, as I will show based on the MD Anderson and result. So in this Japanese study also the prognostic progression in patients with Philadelphia positive incomplete molecular response within 3 months, positive transplantation does not improve the outcome only. Yes.
Yeah, I don't know if this is your last slide, but we're barely hearing you.
Yeah. Yeah. I need 2 minutes.
Go ahead, Doctor.
I can proceed?
Go ahead, Dr. John, but we can really, it's really hard to hear you.
So in conclusion, the patient with Philadelphia positive who achieved allotransplant does not improve the outcome once a 3 months CMR is achieved. So the patient who will achieve a 3 month CMR, those patients, we can continue the consolidation therapy without the need to go to transplantation. And this in Lancet Hematology last year by season 2 years event-free survival 78% and 90% overall survival. 7 patients only relapsed with P190. 4 CNS relapse. I repeat to highlight the problem of CNS involvement and prophylaxis, and you can see the result in the right of my slide. So we have different ongoing question about the patient who need maybe to be consolidated with transplant or not. Our objective,
Dr. John, apologies.
However, our objective,
Dr. John, I think we should wrap up because we're not hearing 90% of what you're saying. The connection is really unstable. So if you have one last take-home message before we wrap up the lecture.
Okay. So my last slide, I'm so sorry about this. Open question for Philadelphia mandatory for ALL eligible patient. In my view as transplanter, and I have a long experience in transplant, in my view, no allogeneic transplant is not mandatory. However, patient with a good genetic profile at diagnosis and who obtained and sustained excellent MRD negativity can probably be spared the transplantation upfront. This not formally proven, but the 4-year follow-up data from the ALBA that I showed before show that patients in complete molecular are strongly suggestive that no need for transplantation. We have many questions to be clarified in the current GMEMA L2820 study. We need obviously a close MRD monitoring requirement, and our goal is to reduce the use of chemotherapy, bridge the patient the need for transplant in the future. And finally, we need maybe a consolidation post-transplant for those patients considered as high risk with a blina or maybe with tyrosine kinase inhibitor post-allogenic transplant. Thank you for your attention. And I'm so sorry from my colleague and the audience about the connection problem.
Thank you, Dr. John. Very interesting topic. I would wanted to start with the question if we think that maybe transplant will be just history in a few years after all this evolvement in the field of understanding the molecular biology of Philadelphia positive ALL. So I'll leave the questions open for the audience.
I'll start. Thank you, Dr. John, for this insightful presentation. First, I want to ask you, when you said, CNS relapse is a big problem, we've heard Kantarjan saying that he gives 15 ITs and he gives high-dose methotrexate with the therapy, so it's not chemo-free completely, but what do you think of this approach to prevent CNS relapse?
Obviously sufficient. It's a long debate because
Sorry, Dr. John, we didn't hear your answer. We did not hear your answer, Doctor.
Okay, what we are, I will repeat my answer. Are you hearing me?
Yes.
Hello?
Yes, we are hearing you right now.
I'm sorry. So I will repeat my answer. So basically, in the Italian group and in the MD Anderson group, when we use the chemotherapy-free regimen, we have a high risk of CNS relapse. So we rediscussed this issue, and we need prophylaxis for those patients. Either not only with methotrexate, I repeat, we need maybe combination and alternation between cytarabine and methotrexate, and initially maybe triple intrathecal therapy would be needed. So we need to highlight also when we give high-dose methotrexate, when we give intrathecal methotrexate, we should alternate with cytarabine. And in those patients, at least for the first year, we need to do this and to be able to decrease the risk of CNS relapse. For those patients who proceed to transplantation, we need to continue, obviously, the intrathecal prophylaxis for at least 1 monthly for the first year. So intrathecal CNS prophylaxis is mandatory in different type of combination, either blina, daza, blina, pona, or chemotherapy, blina, like iperciva, etc. Maybe to be transplant with high-dose TBI or intermediate dose of total body irradiation, we can give less intrathecal or no intrathecal prophylaxis.
Thank you very much, Dr. John. We thank the audience because we have difficulties in hearing you, so we'll end this session, and we hope to see you in the future in Dubai.
Thank you so much. Hopefully. Thank you so much. Goodbye.
Okay. Good afternoon. I know it's too late, but we have one more talk. It will be the last, inshallah. Bear with us. It is my pleasure to introduce our last speaker, who is a distinguished leader from Emirates Health Services, Dr. Sumaya Al-Bloushi. She is the president of Emirates Nursing Association and the director of Nursing Emirates Health Services, and she is the head of National Committee for Nursing and Midwife. She is going to cover during her talk nursing experience in supporting nurses and patients. Please welcome with me Dr. Sumaya.
So, good afternoon. Thanks a lot for those who are still waiting for the last sessions. I promise I'll take just 5 minutes, not to spend too long on my presentation. As we know, everyone for the last 3 days, they brought their expertise related to oncology and hematology. Yet, we understand that, and in spite of all those expertise, a multi-professional care is required to avoid any fragmentation in our patients' care. So one of the professions is also nursing, and they have a great role in supporting themselves as well as their patients. So supporting nurses in oncology environment, we understand it requires a multifaceted approach that addresses their emotional, professional, physical needs by fostering a culture of open communication, providing professional development opportunities, addressing workload management, and offering emotional and psychological support. Organization can help nurses thrive in their challenging but rewarding roles. Now, within the Emirates Oncology and Hematology Nursing Society, it is a non-profit champion volunteering group under the umbrella of Emirates Nursing Association focused on promoting oncology nursing and sharing knowledge obtained from international resources among different oncology nurses within the UAE who provide nursing care to oncology patients. And they have a vision and a mission, that group. They try to enhance and advocate quality care, promote integrity and excellence in cancer nursing. Their mission is to provide a community for cancer nurses in the country where together we will improve nursing care for cancer patients and their families, promoting nurses' role in cancer care and developing nursing leaders, shaping the future of oncology nursing care in the United Arab Emirates. The major key activities that this volunteering group is doing, they try to do annually conferences similar to Emirates Medical Society, and they collaborate and form the International Oncology and Hematology Nursing Conference. We just finished a few days ago the 4th year for that conference. It gathered for professional development, knowledge sharing, and networking, participation in international and regional conferences with a dedicated session, continuing education programs, workshops, seminars, and online courses, patient advocacy. We understand that the nurses are the most important role in patient advocacy, where they spoke and tried to understand what the patient wants, and they are the advocate for unspoken things for the patients and bring that within the multidisciplinary care. Community outreach, public education, campaigners, and support programs. They have a great role in educating the community to go for screening and understand also how to take care of themselves. So this year, as I said, the International Oncology and Hematology Nursing Conference was inducted for the first time in person, featuring presentation renowned pioneers in the field from around the world. It is organized by Meeting Mind experts in collaboration with Emirates Oncology and Hematology societies, and this is a great platform for conducive environment for healthcare professionals to come up together. They are working right now to develop a residency program for oncology nursing. They are trying to develop a link between international society to further develop advanced role in nursing oncology within the country. So working in an oncology environment as a nurse requires a specialized skill, empathy, and resilience. Both supporting nurses and patients in this setting involve unique challenges and rewarding experience. The challenges that are identified: general fear, societal taboo, vast community expecting active enrollment, identify patients who meet eligibility criteria, complete screening processes for identified population, referral sources for patients who screen positive. So they need a lot of knowledge within the country to understand and guide the community and the patients in the right way. Balanced nurse-patient ratio considering non-cancerous screening populations. And there are many other challenges that they are trying to tackle and do. What are the future plans for this working group? For patients, they would like to improve patient experience, a lot of program campaigns through community outreach where they enhance the patient satisfaction through personalized care plans, support services, and digital health tools. Enhance access to care. They advocate for increased access to specialized oncology and hematology services, including in remote or underserved areas. Mental health support, prioritize mental health support for patients and their family, offering counseling, support groups, and educational resources. Of course, as I mentioned, the community outreach, important programs because they provide, again, education, engagement with community in order to encourage further screening for our patients and community. So in conclusion, supporting both nurses and patients in oncology require an integrated approach that addresses clinical, emotional, and psychological needs. Thank you very much. This was the small presentation to show you what are the further steps that we would like to do it in, along with Emirates Medical Society Group. Yes.
Thank you, Dr. Sumaya, for this nice presentation.
I promise to be very quick. My name is Mary Bussell. I'm with Trimar Strategies in New York, and I am a nurse originally. And I'm really delighted to know that the Emirates Oncology Society recognizes the role of nurses, because in this scary time in a person's life, very often it's the nurse who has that special relationship, a unique relationship with the person. I try not to use the word patient, but with the person and his or her family. Yes. And so it's really, really exciting to hear about the work that you're doing here in the UAE. I commend you. I wish you really great luck and success. So no question, just wanted to say thank you.
Thank you very much.
Thank you so much. I believe we need some sort of advocate and support group inside the hospital, not only outside the hospitals, and even we need it for the family members, not only for the patient. What we can see nowadays, it is mainly focused on the patient themselves or their self, but not on the families. I mean, we are usually struggling with the breaking bad news with the family members, husband, wife, or whatever. This is a good, inshallah, movement. We hope that in the future we will have specialized nursing staff and the oncology in the same level globally and inside UAE. Thank you very much.
Thank you very much, Doctor.
Just, I think, if there is any other question, Dr. Hassan?
I just want to comment.
Yeah, please.
No, I was going to say our nurses are an integral part of the team. You know, oncology care is a team. I worked in the US by myself as a single physician, but I had 6 nurses with me. So without them, I couldn't have done it. You know, I had a full research center. And here in UAE, same thing, I'm at King's College. Without my nurses, certainly I cannot do it all. So there is no question how nurses interact with patients, how they explain more details. We spend with patients a little bit on side effect of medication, if any. We are all at fault because we don't have enough time. So we really depend on our nurses to do that. And on the other side, they are at the forefront of any side effect because the patient called them first. And they have to be prepared to get that question, try to answer it themselves, or certainly they can get to us to explain it more and take care of the patient. So there's no question we couldn't have done it without nursing support.
Thank you very much.
Thank you, Dr. Hassan. Yes, Doctor.
Yeah, thank you so much for the interesting talk. Actually, as said by everyone, briefly, we love our nurses. There's no doubt in that. But I think we need some a way for nurses who are currently working in oncology, who are interested in oncology, to be promoted as specialized nurses. I mean, I believe that in UAE there's no way or degree that you can get to be specialized in oncology, for example, or something else. So I think that we face every day lots of nurses who are really passionate and interested being specialized. We don't have nursing practitioners. They don't get to be practicing actually. So I think one way forward is to find a pathway for nurses to be licensed and specialized for the ones who are really interested.
Thank you very much. This recommendation is well noted. Recently, a committee is formed to work on, as I said, a residency program for nursing oncology. We hope that this program will be developed soon in the coming few months, and then it will go under the National Health Institute for health specialization within the country. Thank you very much.
And in US now they have some sort of fellowship. It is not only master or just a training. It is fellowship for a lead for nursing, physiotherapist, nutritionist. It is good to start with an affiliation with some international university. We will take the last comment or question, please.
It's not a question, it's just a comment. That thank you, Dr. Sumaya, for bringing this. I am a nurse also working at the Sheikh Shakbut Medical City as an oncology coordinator.
Great.
But when I joined in UAE 15 years before, and I said I am only oncology nurse because I already have 1 year diploma in oncology nursing. And then they were all surprised, like, what is this oncology nursing? But now the things have been changed, and I'm happy to see the future of oncology nursing. Thank you so much.
Thank you very much.
Thank you very much. Thank you, Dr. Sumaya.
Thanks.
It was a pleasure to have you here. Now we are going to close our day, our meeting. On behalf of Professor Hamid Al-Shamsi, the president of Emirates Oncology Society and the organizing committee for this meeting, we would like to thank you for being here with us until now. I know it was a long journey of learning from junior to seniors. It has different activities from formal presentation to the workshop, having multidisciplinary team discussion for some cases, debate. I think all of us, we learned, we really appreciate your presence and contribution, either as speakers, national or international, moderators, and by your comments and questions. I really appreciate this. We were privileged to have all of you here. We are looking forward to see you in the upcoming scientific committees, scientific meetings, which will be arranged and organized by Emirates Medical Society. Thank you very much. Special thanks to Micheline and her team. To be honest, I forget to mention, this is the most important. Those people who are working behind the scene, and they are really the hidden soldiers.